The Honorable, the Dean of the Faculty of Medicine, Universitas Diponegoro, the Vice Deans of the Faculty of Medicine, Universitas Diponegoro, the Head of University Reputations Office of Universitas Diponegoro, the Head of International Office of the Faculty of Medicine, Universitas Diponegoro, the Director of the Center for Bioethics, Harvard Medical School, the Chair of Bioethics Unit, Faculty of Medicine, Universitas Diponegoro, all invited speakers and facilitators, distinguished guests, participants, ladies and gentlemen, good morning. Welcome to the International Bioethics Symposium and Workshop 2025, organized by the Faculty of Medicine, Universitas Diponegoro, in collaborations with the Center for Bioethics, Harvard Medical Schools. It is a great honor to host this international scientific event, which gather experts, professionals, scholars in the field of bioethics to exchange knowledge, share information, and engage in meaningful dialogues on emerging ethical challenges in science and medicines. I am Nurahir, and I will be the Master of Ceremonies for today's event. Before we begin with the scientific sessions, let us officially commence the event with the Indonesian National Anthem. Ladies and gentlemen, please rise for Indonesia Raya. Ladies and gentlemen, please be seated. We are pleased to now invite the Chair of Bioethics Unit, Faculty of Medicine, Universitas Diponegoro, represented by the Secretary, Dr. Edward Kurniawan Setiawan, LMM, MHakes, SPPK Konsultan, MSIMED, to deliver his speech. Dr. Edward, the floor is yours.
Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. Om Swastiastu, Namo Buddhaya, Salam Kebajikan. Good morning, everyone. I would like to begin by expressing my respect and appreciation to Dr. Yan Wisnu Prajoko, Master of Health, Oncologist Surgeon, as the Dean of the Faculty of Medicine, Universitas Diponegoro, as well as our Vice Dean, Dr. Muflihatul Muniro, Master of Science Medical, PhD, and also Dr. Nuryanto, Bachelor of Nutrition, Master of Nutrition, and all members of our faculty leadership. A very warm welcome to our partners from the Center of Bioethics at Harvard Medical School. It is an honor to have you here with us. To our distinguished guests, Dr. Rebecca Brendel, Director of the Center for Bioethics at Harvard Medical School, and Dr. Hajung Lee, affiliate of the HMS Center for Bioethics and Associate Professor at the University of Phuket Sound. Professor Roger Chung, Co-Director of the Center for Bioethics at the Chinese University of Hong Kong, and Dr. Tan Hui Xiu, whose work in developing clinical ethics services in Malaysia is truly inspiring. I would also like to thank our dedicated facilitators today, Dr. Amalia and Dr. Bagasir, for guiding our discussion and sharing their valuable insights in workshop for next day. This year's program carries an important and timely theme: rehumanizing the health system for prosperous and fair services for patients, health workers, and the global community. In the midst of rapid technological change and complex global health challenges, this theme reminds us of our responsibility to bring back the human spirit at the heart of the healthcare, to ensure dignity, fairness, and well-being for all patients, health workers, and our wider communities. We are very proud to welcome 183 participants to this event, 77 joining us in person here in Semarang, in this room, and the rest tuning in online. Participants come from all over Indonesia. Our colleagues from Yogyakarta, welcome, Mrs. Siwi and Mrs. Puri, and also Dr. Peter from the Indonesian Bioethics Forum, and from Medan, Tadulako, North Sulawesi, Bali, Kalimantan, and Papua, and also throughout Java, showing our shared commitment to strengthen bioethics across regions and contexts. I'm delivering these remarks on behalf of Professor Dr. Randa Ani Margawati, Master of Health, PhD, Head of the Bioethics, Humanities, and Professionalism Unit. And she is unable to join us today due to other professional appointments, but she sends her warmest regards and best wishes for a successful event. Finally, I would like to express my deepest gratitude to the Center for Bioethics at Harvard Medical School for this meaningful collaboration, and a heartfelt thank you to the leadership in Universitas Diponegoro, Faculty of Medicine, especially to Dr. Astika and Dr. Ardita and Mrs. Astarina, whose dedication and tireless efforts have made this gathering possible. My today's discussion inspires us to work together to truly rehumanize our health systems for the prosperity, fairness, and well-being of patients, health workers, and the global community we serve. And the last thank you, and I wish us all a productive and inspiring program. Thank you very much. Good morning.
Distinguished guests, participants, ladies and gentlemen, Next, we are honored to welcome Professor Rebecca Brundle, the Director of the Center for Bioethics, Harvard Medical School, to deliver her remarks. Professor Rebecca, the floor is yours.
Good morning. It's so nice to see everybody here in person, and hello to those of you who have joined us online. On behalf of the Harvard Medical School Center for Bioethics and my colleagues who have come with me from around the world, it is truly an honor to be here with all of you this morning. We are here as part of a trip that we have been doing to bring Eastern and Western, Asian and US perspectives together to think all of us as physicians, as healers, as those involved and committed to health about how we can foster understanding and global leadership to advance our health, but also to advance our humanity. And so being here with you helps us do that through the work that we'll do and what we'll learn, but also through the relationships that we have in the course of planning this wonderful conference and will continue to build, shape the future through our commitment to each other and our community. So this is really an opportunity for all of us to continue some of the learning and the work that we've done over time with our colleagues from around the world. But I want to say something also about the very particular importance of Indonesia with our Center for Bioethics and Harvard Medical School over now very, very many years. So my dear colleagues, Mary Jo and Byron Good, both anthropologists, did the bulk of the work of their career in Indonesia, based at UGM in Yogyakarta. And we had the opportunity through that of being part of some very important developments in health and mental health in Indonesia over many years now. So Indonesia has shown leadership in rights to health and to treatment and to mental health care, right? A passage of a really groundbreaking law. And in addition, in thinking about universal insurance and access to healthcare for all persons in Indonesia, has included in that the establishment of centers for bioethics and units to really think about the social, political, economic, educational needs that surround the implementation of health equity, access to health and health equity nationwide. And in that sense, in coming to you from a country that has perhaps one of the most flawed right now healthcare systems, being here is such a gift to think about what a possibility could be and how we come together to make health and healthcare better for all in a global way. So before I wrap up, I would be remiss if I didn't talk about one of the greatest gifts of being a professor, a teacher, a leader in academic medicine, which is that our students are having the opportunity to work with wonderful, motivated, and talented students who bring our work forward to future generations. It's both a gift to be able to impart that knowledge and see it grow, and a salve for our sleep in knowing that after we're finished doing our work, the future will be bright. And so with that, I want to particularly recognize my dear student from Indonesia, Dr. Ardita Pramudani, without who this conference would not have happened and none of us would be here today. So Dr. Ardita, thank you so much. And if I start thanking all of the people without whom we would not be here today, we would never get to our conference today. So suffice it to say thank you to the Bioethics Unit and colleagues, thank you to the university, to the Ministry of Health, and to all who made it possible for us to come here together to do the work a one by one of helping our patients, helping ourselves as healers, and to advancing health and good globally together. Thank you so much for having us. It's truly a wonderful honor.
Ladies and gentlemen, now we are pleased to invite Dr. Yan Wisnu Prajoko, Magister Kesehatan, Spesialis Bedah, Subspesialis Onkologi Konsultan, the Dean of the Faculty of Medicine, Universitas Diponegoro, to deliver his welcoming address. Dr. Yan Wisnu, the floor is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, distinguished guests, dear colleagues, and participants. First of all, let us give thanks to God Almighty for His blessings and guidance, so we may gather here today for this important occasion. The Bioethics Symposium and Workshop, a collaboration between the Center for Bioethics at Harvard Medical School and our Faculty of Medicine, Universitas Diponegoro. On behalf of Universitas Diponegoro, I extend my warmest welcome to our esteemed international guest, Professor Rebecca Brendel, Director of the Harvard Medical School Center for Bioethics, Professor Hajung Lee, Professor in Religion, Spirituality and Society and Bioethics, University of Puget Sound, and an affiliate for the Harvard Medical School Center for Bioethics. Professor Roger Chung, Co-Director, Center for Bioethics, the Chinese University of Hong Kong. Professor Tan Hui Siu, Hospital Ethics Support Service, Hospital Ampang, Ministry of Health Malaysia. Professor Reni Burke, Psychiatrist at the Traditions Health Behavioral Health, United States. We are also honored to have distinguished representatives from our own ministries joining this important dialogue. Professor Basaruddin from Ministry of Higher Education and Dr. Anna Kurniati from the Ministry of Health of the Republic of Indonesia. And also our facilitators from Universitas Jenderal Sudirman, Dr. Amalia and Dr. Bagas, who will help enrich our discussions and workshop during these programs. Today, we gather to discuss not only the foundation of bioethics in clinical practice and education, but also to reflect on how our pluralistic values and diverse cultural contexts can shape ethical decision-making in healthcare. Bioethics is not only a topic for academic debate, but a principle that must guide our daily actions as medical educators, professionals, and policymakers. To this symposium and workshop, I hope we can strengthen our commitment to embed bioethical principles into our medical curriculum, from undergraduate level to residency, and encourage constructive collaboration among institutions, both nationally and internationally. I would like to express my sincere gratitude to the organizing committee, all moderators, speakers, and participants for their dedication to making this event a success. I hope all of you will find today's discussion meaningful and inspiring, and that you enjoy your time here in Semarang. Once again, welcome, and with that, I hereby declare this symposium officially open. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Ladies and gentlemen, before we continue with the next sessions, let's take a moment to enjoy a cultural performance, Tari Semarangan, presented by the students of Faculty of Medicine, Universitas Diponegoro. Ladies and gentlemen, Tari Semarangan is a creative traditional dance originating from the city of Semarang, Central Java. It reflects the vibrant, harmonious, and progressive life of its people. Ladies and gentlemen, please welcome Tari Semarangan.
Mlaku-mlaku ngubengi kutha Semarang, pemandangan bangunan kokoh terbentang, peninggalan saka Hindia Belanda, dadi cagar budaya Indonesia.
Kutha Semarang pancene maneka warna, kabeh ana suku agama budaya, kuyo rukun ayem tentrem lan prasaja. Mahripah rahayu sarta raharja.
Kutha Semarang nyoto semakin hebat, pembangunan ekonomi pariwisata. Kutha Semarang nyoto semakin hebat,
Yuk dijaga kuthane timen ngrembaka.
Well, thank you very much for the students presenting Tari Semarangan. Ladies and gentlemen, in appreciations to the valuable contributions by the speakers in our symposium and workshop, the Faculty of Medicine, Universitas Diponegoro would like to present souvenirs. We now invite our distinguished speakers to come forward. Professor Rebecca Brendel, Professor Tan Hui Siu, Professor Ha Jung Lee, and Professor Roger Chung. And we also invite the Dean of the Faculty of Medicine, Universitas Diponegoro, to kindly present the souvenirs to our speakers. Yes, please, Professor Rebecca Brendel, would you please come to the front? As well as Professor Tan Hui Siu, Professor Hajung Lee, and Professor Roger, to receive souvenirs from the Dean of the Faculty of Medicine. The organizing committee, would you please take the moment for the photo session? Gak apa-apa gitu. Yes. The first one will be provided to Professor Rebecca Brendel. And the second is given to Professor Tan Hui Siu. Thank you. And also Professor Hajung Lee, would you please receive the souvenir from the Faculty of Medicines? Thank you. And the last is Professor Roger. Thank you very much. And we also invite Professor Rebecca Brendel for gift exchange given to the Dean to the Faculty of Medicine, Universitas Diponegoro. Well, thank you very much. The speakers and the dean, would you please stay on the stage? And we'd like to invite our distinguished guest uh, and and also given to the vice deans. Thanks. And we'd like to invite all the speakers, invited guests, and also the participants to take a photo sessions. The first session will be for the speakers and also the deans, the vice deans, and invited guests. And we'd like to invite all participants, could you please come forward? All right, to take photo sessions together. All participants, would you please? The organizing committee, would you please help the participants? Okay. Di sini aja. Nanti nggak dapat background. Oh ya ada. All right, the participants, yeah, you can remain on your seat. Oh, sini. Oh, berdiri. I would like to invite participants to stand up. Right. We will take this photo for more efficient times. Uh, all right. Thank you very much. Well, distinguished guests, participants, ladies and gentlemen, we now begin with the first plenary sessions titled Ethical Foundations for a Human-Centered Health Systems. These sessions will be moderated by Dr. Astika Widi Utomo, MSc, SPFM from Universitas Diponegoro. Ladies and gentlemen, Dr. Astika earned her medical degree from Universitas Diponegoro and her master's degree of science from Universitas Gajah Mada, Yogyakarta. She also completed her specialist medical training programs in forensics medicine and medical legal studies at Universitas Diponegoro. She is currently teaching at the Department of Forensics and Medicines and Medical Legal Studies, Universitas Diponegoro. Ladies and gentlemen, please welcome Dr. Astika.
Good morning, ladies and gentlemen. On behalf of the organizing committee, it is my great pleasure to welcome you to Universitas Diponegoro in Semarang, Indonesia, and to this session of the International Bioethics Symposium and Workshop 2025, where we will reflect deeply in the theme of ethical foundation for a human-centered health system. In this session, we will delve into the roots of bioethics, explore its role in social advocacy, and reflect on how it shapes patient care in real-world setting. It is a great honor for me to introduce our distinguished speaker today, Dr. Hajung Lee. Dr. Lee is an associate professor at the University of Puget Sound and an affiliate of Harvard Medical School Center for Bioethics. With interdisciplinary expertise spanning bioethics, health law, theology, and biomedical engineering, Dr. Lee brings a unique and insightful lens to contemporary ethical challenges in healthcare. Her work focused particularly on reproductive ethics, immigrant health, and the moral complexities of clinical practice in diverse communities. Deeply committed to inclusive and culturally grounded education, she advocates for the integration of religious and cultural values into clinical ethic teaching and practice. Today, she will present on Introduction to Bioethics, its social advocacy, and impact to patient care. Without further ado, please join me in welcoming Dr. Hajung Lee.
Selamat pagi. I just learned it from the internet. Thank you so much for taking time out of your day to join us. And it is a great honor to be here in Indonesia. This is first time to be in Indonesia and speaking with healthcare professionals, medical students, and ethics educators. And thank you so much for the team who organized it. And thank you for Adita. I feel like she's my missing sister. I feel connected. And thank you so much for generous introduction. So today, I want to share with you some reflection on bioethics, and not just as a discipline of theoretical analysis, but as a living, dynamic framework that invites all of us, especially healthcare professionals, to engage with moral responsibilities and social advocacy. So today's talk will focus on the intersection of clinical ethics, health advocacy, and patient care, particularly how these ideas are shaped by religious, cultural, and social commitments. And I'll be drawing on global traditions with a special emphasis on Indonesia's rich ethical framework. So here, I'm going to briefly go over what bioethics is. I hope you have taken some bioethics courses, and if not, it's a super nutshell that you can see what bioethics is. And if you have any questions, you can talk to me after the session, or you can talk to any of us from Harvard, and we'll have some conversations. But very nutshell, what is bioethics? My students always ask me, what is bioethics? And they told me if I knew what bioethics was, then I could take the classes earlier, but they didn't have any idea, right? So bioethics is, according to the Hastings Center, the interdisciplinary study of ethical issues arising in the life sciences, healthcare, technology, and science policy. In practice, bioethics is about the daily challenges that all the clinicians may face. It's about the difficult conversation with patients and families, the tough decisions around resource allocation, and the broader concerns about justice and inequality in healthcare system. That's a very broad scope. And bioethics encourages us to wrestle with difficult questions. Oh, okay. And it goes beyond clinical dilemmas, includes social, cultural, religious, and political dimensions of health. So not only about the conversations at the bedside or on the hospital floor, but it's more broad scope. And how do we responsible with the scientific advancement? How do we respect the lives and dignity of those we care for? And how do we ensure equity and justice in access to medical innovation? So you've probably heard of 4 core principles of bioethics. And those 4 core principles are autonomy, beneficence, non-maleficence, and justice. So it gives some framework and very handy work to analyze the cases, but this is not like representing the whole foundational framework. So autonomy is respect for a person's right to make their own informed decision about their own bodies and lives. Beneficence, a commitment to act in ways that promote the well-being of individuals and communities. Non-maleficence, do no harm. Justice, fair and equitable distribution of healthcare resources, and respect for rights. And there are other very crucial values we must consider in bioethics. Those are dignity, integrity, accountability, solidarity, relationality, sustainability, respect for religious and cultural diversity, empathy, and compassion. These values are deeply relational and humanizing. They call us to a medicine of care, not just care, just cure. They also create an ethical vision that can extend into public policy and community advocacy. So today's talk, the learning objectives are these three. So I hope we take away from today's presentation that you can define the scope of ethical and social responsibilities of physicians beyond clinical care, including roles in community leadership, public health, and advocacy. And second, critically reflect on personal and professional boundaries. Where should advocacy begin or end in medical practice? How can doctors ethically manage multiple forms of accountability? And the third, recognize diverse ethical frameworks, including ancient traditions, secular principles, religious teachings, and some professional code in Indonesia that have shaped physicians' responsibilities across different cultural and clinical contexts. So traditionally, the physician's primary duty has been to the individual patient. This is grounded in principles such as beneficence, non-maleficence, and confidentiality. But physicians also live and work within society. They observe firsthand how injustice, poverty, stigma, and structural barriers shape patient outcomes. So here's our question. So should clinicians or should physicians advocate beyond their patients, beyond their hospitals? Do they have to participate in promoting public health? Do they have to work on expanding health access to healthcare? I don't have an answer for you, but I'll give you framework so you can find your own answer and think of what your ethical and social responsibilities are as clinicians. So that's the big question that I want to throw today. So some social responsibilities of clinical doctors that you can think of are health equity, access issues, public health advocacy, systematic injustices, and environmental and global health. Of course, engaging in advocacy comes with many challenges. So if I ask some doctors, do you want to join promoting public health? What would be their answer? If someone is a resident, fellow, very busy, no sleeping time, maybe not. And if I ask a very busy surgeon, like, do you want to join me, like working on protesting something to build better access to healthcare? I gotta save my patients, right? So there are a lot of different duties of doctors, and many times overloaded clinical workload limit extra steps. And advocacy may be perceived as political or outside professional norms. And moral fatigue and emotional strain can reduce resilience. People get burnt out, and many medical professionals are known to be burnt out and depressed. So can we ask them to do more work and add more and more responsibilities? What should we do, right? And engaging in advocacy can cause professional or legal complications. Sometimes you may do some work which may violate your code or legal codes, and you may need to take a risk So it's not an easy task. And you also need to be culturally sensitive, which is not easy to achieve either. So risk of unintentional imposing values when working across diverse communities. And Indonesia is known for with 800 languages, is that right? I've tried to learn about Indonesia and ask a lot of questions to my friend Adita there. And it's very diverse communities and very unique with 6 officially recognized religions are. And in the afternoon, I'm going to talk about like religion and bioethics later. So stay tuned. And so there are challenges of doing advocacy here. And I want to give some framing thoughts before we go over the framework. So traditional core duty to prioritize the well-being of patients, grounded in principles like beneficence, non-maleficence, and confidentiality. And then we may think of expanding role, systematic injustice and public health crisis blur boundaries between care and advocacy. Unless your patient is living in a good condition, decent housing, clean water, good, not polluted air, like their health conditions may not improve no matter like how hard you are working on the treatment, right? So today, because of the global environmental issues and climate changes, the boundaries have been very blurred between care and advocacy. So maybe advocacy is very important today. And there are some ethical tensions. So if we remain silent, are we complicit in systematic harms? If we let this systematic harms happen, then are we responsible for it? And should all doctors be activists? Or is advocacy a personal choice? So some people may think it's like extra work on you, or some others think that I'm like obligated to do some advocacy work. And where does a professional obligation end and moral conviction begin? And should medical boards and institutions provide the guidelines or leave it to conscience? So in other words, are they obligated to do some work for social responsibilities, or is it purely personal choice? That's the question. So physician ethics have deep roots in these foundations. So Hippocratic oath, I mean, globally it has been used. It has been modified with like many different versions, but it has been used. And ancient Chinese and Muslim traditions, Western principalism, World Medical Association, and American Medical Association. So we're gonna go over that briefly from global bioethical perspectives. And then we're gonna go over briefly about Indonesian professional perspectives, Pancasila, and Code Ethic Kedokteran Indonesia. I hope my pronunciation is okay. Indonesian health law, religious and cultural perspectives in Indonesia. So the first one, Hippocratic Oath. It focuses patient only, actually. So it may implicitly uphold honor of a profession, but does not explicitly mention society at large. So it doesn't really talk about social role of doctor, social responsibilities of a doctor. And there are some Chinese ancient traditions here in ethical wisdom. So Sun Simiao, king of medicine from China, he said, when one devotes oneself to healing, one should not pay attention to status, wealth, or age, whether the patient is attractive or unattractive, a friend or a foe, a Chinese or Indonesian or a foreigner, foolish or wise, everyone is the same. So he really emphasizes on treatment without any discrimination. And next one, Zhang Zongjing from China, the medical sage, that's how we call it. When I perceive signs of illness, even before it fully appears, I am moved with deep compassion. So it really emphasizes on compassion of physicians. And these early teachings point toward a medicine of inclusion without discrimination and moral vision with a heart for humanity. And some ancient Muslim physicians we can learn from Al-Hawi, author of the earliest Islamic ethics manual. He wrote, physicians should be morally upright, humble, and prioritize service over profit. So it tells something about capitalistic society today and how the world of medicine and industry of medicine has been involved and worked. And he saw medicine as a noble calling, not merely a trade. So not for making money, but it's a noble calling from God. So it's supposed to be a sacred work. And second, Al-Farabi, he said, physicians serve not only individuals, but contribute to the harmony of society. When we saw this beautiful dance, I hear the word harmony, and harmony has been great virtue in many Asian countries. And physicians must engage in public reasoning and provide moral leadership. So emphasizing on moral leadership as well. The third, Avicenna, offered a strong warning. True healing cannot serve both profit and virtue. So their message is clear. Medicine is not a trade. It is a moral vocation, and for many Muslim physicians, it's supposed to be sacred work that you are being called by God to treat others and help them out. So it is a very serious matter. And we just went over Western principalism, like autonomy, beneficence, non-maleficence justice. It offers some aspects of ethical responsibilities of physicians, but I'll skip this and talk about World Medical Association International Code. So according to the World Medical Association, they state the physician also has a responsibility to contribute to the health and well-being of the population of physician serves and society as a whole, including future generations. And the American Medical Association affirms, the second one, a physician shall recognize a responsibility to participate in activities contributing to the improvement of the community and the betterment of public health. So from like global perspectives, like many codes emphasize on social responsibilities of doctors. And these declarations reflect the ethical expectation of advocacy. And then we can briefly go over some Indonesian bioethical foundations. So Indonesia contributes richly to the ethics of care. Pancasila here as moral foundation. I think everyone like memorized it, and I've heard like a few times so far. And belief in the one and Almighty God, just and civilized humanity, the unity of Indonesia, democracy via deliberation, social justice for all the people of Indonesia. So those are supposed to be principles for like any ethical issues in the Indonesia. And here, you can find some core values in bioethics and healthcare from these principles. So the first one, belief in the one and almighty God. We can find like respect for religious and spiritual diversity, moral accountability. And the second one, just and civilized humanity. You can find core value of compassion, dignity, non-discrimination, and human rights. And unity of Indonesia. Cultural pluralism, inclusivity, teamwork across religious or ethnic boundaries, and democracy via deliberation, shared decision-making, patient voice, collaborative ethics, and social justice for all. You can find core values of equity, universal access to healthcare, attention to health disparities. So do we have to respect and seek those core values as physicians or future physicians? Like I'm throwing that question to you. And here's an Indonesian medical ethics code. Like, what do they talk about? Responsibility, social responsibilities of doctor. Doctors must pay attention to promotive, preventive, curative, and rehabilitative aspects and serve as a servant to the community. So emphasizing their function as a servant to the community, not only to the patient, individual patient themselves. And then from Sumpah Dokter, Indonesian physician's oath, it says, I will devote my life for the sake of humanity, not only your own communities, but for the sake of humanity, by taking into account the interests of society. So it does mention of something ethical and social responsibilities of doctors. And there's the health law. It says every citizen has the right to health and serve both individuals and society. They emphasize on like, you gotta serve society as a doctor. And it promotes just, ethical, and humane care, and doctors can play a significant and essential role there. And we'll go over some religious and cultural perspectives in Indonesia. So Islamic ethics. According to Islamic ethics, your vocation as a doctor can be a sacred duty to God in medical practice. And the concept of Ihsan excellence calls Muslim clinicians to excel in compassion and integrity, treating medical work as a service to God and humanity. And it also is, your job is duty to preserve life and moral responsibilities for outcomes that has been emphasized, like highlighted in Muslim tradition. And the third one, act of worship, saving lives, alleviating suffering, and being just and kind. Like that's what you're supposed to do as a doctor and in your practice, and that's supposed to be acts of worship. And the second, from Buddhist perspective, compassion has been highlighted, and non-harming ahimsa has been also underlined. And care for sick is equal to like care for Buddha. In Christian tradition, it's similar thing. Like if you care for the sick, the least one, marginalized one, that's equivalent to care for Jesus or care for the kingdom of God. So causing harm to patients can be seen as negative karma, whereas healing and caring are meritorious. So it will be helpful for your reincarnation of next life, and the patients and the doctor can get like good marriage actually. And the third Protestant perspective, I'm gonna introduce the Catholic perspective as well, and there are duplicated values here actually. And medicine is as a calling to serve following Jesus's example of healing the sick in the history of Jesus. he healed people, and doctors are supposed to like follow what he has done, and emphasized on the sanctity of life and the duty to care for the least of these people. Least of these mean poor and marginalized patients. They are going to heaven, and they're going to have the spiritual rewards. And compassionate love has been emphasized. So a lot of these Christian Protestant doctors are supposed to commit to charity and mission. And similarly, in Catholic social teaching, it really emphasizes on solidarity and care for the poor. The preferential option for the poor by Paul Farmer came from this Catholic social teaching and the idea. And you should defend life at all stages. And from Hindu perspectives, dharma, duty, righteousness, guiding a doctor to uphold honesty, do no harm, and serve society. So again, emphasizes on serve society, and encouraging Hindu clinicians to treat their work and service to God dwelling in each patient. So it's a spiritual duty. And Confucian ethics, humaneness, empathy, Ren, you should hold compassion, you should hold empathy and humaneness, and care is a social responsibility. In Confucian ethics, they really emphasizes on social responsibilities and social roles, like who you are, what you are doing to build harmony of your society and community. So understanding the broader message from these beyond any single tradition, holistic ethics. Doctors are not merely technical experts. They are moral agents entrusted with promoting well-being, dignity, and justice. And their responsibilities often extend beyond the clinic into communities, systems, and society at large. We found some sources like the sacred books say so, and the moral code say so, and your professional code say so. And multiple accountabilities. Physicians must navigate various forms of accountability to their patients, professional codes, institutions, legal systems, and ethical or religious traditions. And balancing these sometimes conflicting expectations is an ongoing ethical challenge. So let's assume that you do have social and ethical responsibilities, but like how much you can push yourself, like when you are busy to treat patients, do you have to sacrifice your own leisure time, or do you have to sacrifice your own like family time? Like how much should we push the boundary? So it is not easy to do some good work for promoting good health and expanding access to healthcare, or trying to solve global warmings, global climate changes, all these like global issues together. But this is a very hard task. So I want to give these 5 questions that you can reflect on your own after going home, or today, or for a lifetime, right? Because it is a challenge, because you may want to do some work to humanities, but like what kind of role that I can take, and how much work that I can do, and what are my responsibilities. So here are 5 questions that I give to you. First one, in your view, what are the limits of a doctor's ethical responsibilities? I don't want you to be completely burned out because of thinking of these social responsibilities or participating in all of these work or advocacy. And the second, should physicians have a duty to speak up on issues like drug pricing, climate change, or healthcare access? Is that our responsibility to speak up and talk about these issues? And then third, what do you think is the doctor's role in public health emergencies like pandemic or social crisis, like some natural disasters? Number 4, how can doctors balance their individual obligations to patients with broader public responsibilities? Number 5, should medical education include training in health advocacy and social justice? as you know, medical training and medical curriculum has like competing with like so many different subjects, and they gotta know medicine. They gotta take so many different subjects. But do we have to like emphasize on advocacy, health advocacy, social justice for the next generation? So a lot of you are educators, and think of those questions. And thank you again. And I look forward to our continued dialogue. And if you have any questions, reach out to me. And terima kasih banyak.
Thank you very much, Dr. Hajung Lee, for your very insightful presentation. Thank you very much. You can just sit down here or come back to the... Now we are pleased to continue the session with another distinguished speaker whose work lies at the intersection of psychiatry, ethics, and health law. Please join me in welcoming Dr. Rebecca Brandel, the director of the Center for Bioethics at Harvard Medical School and associate professor of psychiatry at both Harvard Medical School and Massachusetts General Hospital. Dr. Brandel brings a wealth of expertise in clinical ethics consultation and education, especially in the field of mental health. Her leadership in both academia and professional organization, most notably as the president-elect of the Massachusetts Medical Society, underscore her dedication to advancing ethical practice in medicine at both state and the national levels. Today, she will be speaking on a topic that is increasingly vital in today's healthcare landscape: mental health ethics and well-being. Dr. Brandel, the screen is yours.
I'll put it here. Thank you. Good morning again. So I'm going to take us a little bit from the, I want to really thank Dr. Lee for her wonderful introduction for us to the work that we're going to be doing here together. And to take a minute to reframe for us, because part of what Dr. Ardita asked me to do was to spend a little time with you framing another aspect of how we think about our professional responsibility, which is about our own well-being, how we take care of ourselves as professionals, and also how that empowers us to take care of those for whom we're responsible. And so I want to tell you a little bit of a story about a place that we find ourselves within the United States, but that really resonates broadly also to Indonesia and other low middle income countries in terms of of our need to both use this as a warning sign of where we are, but also an opportunity for how we can create systems of care and systems of professional support that can lead to a sustainable future for the delivery, not just of mental health care, but of health and healthcare more broadly in general. Okay. So here are the broad themes of what we're going to talk about, and they're really straightforward. The concerns about mental health are not new, but they're concerns about well-being that we need to continue to think about and take care of ourselves. I want to use the COVID-19 pandemic as an example of a stressor. It was like a stress test for our system about where we're struggling and also where opportunities are for change. It gave us a particular awareness in the US about our need to address challenges in mental health and our workforce. But I'll say a little bit about how that's the same and also different as elsewhere. And then really think about these ongoing challenges for us as physicians for the profession, not just in terms of ourselves right now, but in terms of our medical students and our residents, our physicians in training, and how this might go forward for the future generation and what we need to do. So, and then I'm going to step away for the next talk, but when I come back and talk about professional ethics, we'll have touch points back to this to be thinking about how this can also be an example for how we build the kinds of institutions and organizations that sustain us as healers. Okay, so why does any of this matter? Why are we talking about our mental health and our well-being? One reason that we're talking about it is because we're people and we're human, and so how our well-being matters. But the other is that it really does matter in terms of our work advancing health and healthcare, right? So when we think about this quadruple aim, this is academic medicine in the United States. What we think about is 4 different areas that we need to address, right? So one is around patient experience, making sure that we're providing excellent care, but also doing it in a way that's patient-centered, right? As you heard about, bringing in the values that matter to patients, respecting patients' humanity, and continuing to deliver care. But another, right, is very much a different thing. Not just individual patients, but also population level health, right? How do we think about the health of communities as opposed to just individuals? How do we make interventions that reduce communicable diseases, right? In general, how do we think about interventions like vaccines, right? Clean water, the kinds of things that matter at a population level. How do we take the resources that we have, not just the money that we use to pay for healthcare, but the natural resources that we have, in reducing costs and using our resources effectively within health and healthcare? And then finally, how do we take care of ourselves as those who deliver healthcare? How do physicians continue to find meaning in their work, sustenance in care, and also support around the challenges? And then, this does translate. You heard a little bit from Dr. Lee just before me about professional ethics and norms, right? You heard about the World Medical Association Code. You heard about responsibility is put forth by the Indonesian medical leadership. And so it also matters when each and every one of these, physician heal thyself, caring for ourselves before we can care for others is primary. Whether we look to early Confucian elements, whether we look to Hippocratic Western writings, however we look at this, taking care of ourselves to be able to take care of others, right, is one core value. And then the last reason why this really matters is because of our humanity, because we're all human, right? And if we want to cultivate the capability for care, for discernment, for taking care of others, we need to start by recognizing those attributes in our very selves, right? We are people too. Okay, so I want to tell you a little bit about what happened in the US to get us to recognize our mental health. When I come back and tell you some narratives of US physicians, you'll see that we have historically done a very terrible job of taking care of ourselves. But what we saw following the COVID-19 pandemic was that all of a sudden, we had a mental health pandemic in our country. So we did not have enough resources to take care of people in the general public. We did not have enough clinicians to take care of them. We had both adults and children who were having difficulty. And this was both, whether you looked across the medical literature or the popular literature, the press, the news, this was the story back at the end of 2022 going into 2023. And whether or not it's about a pandemic that affected different parts of the globe somewhat differently, although it did have global impact, what I want to keep for you to keep in mind is that this is a slide that comes from the uniformed services from work done by our military responders, but that we have lots of different kinds of disasters, right, or challenges that are large or small, right? So we know Indonesia, for example, has many, many islands, lots of, right, it's a climate where it's not unusual to have flooding, to have weather events, to have natural happenings that affect people. And being in a place that can be so affected by weather and other kinds of events, right? Understanding that the nature of a psychological footprint will always, right, be larger than the medical footprint. So once we are finished taking care of the injured, of the ill, delivering the medical care, right, what lingers on into our consciousness and our work is this mental health and psychological footprint. So that's why this matters. In the US, we are completely unprepared for this, and we are not dissimilar from other high-income countries. Our supply of psychiatrists is declining. The demand for mental health services, as you just saw, is increasing. We have a large country, and so we have uneven resources in many places. And even though we're able to train more psychiatrists, we won't have enough. So I think this is one of the things that we're really looking at is even in a comparatively high resource setting, we're not meeting the mental health needs. And what we also know is that our frontline healthcare workers, since the global COVID-19 pandemic, 75% said they had a negative effect on their mental health, and 70% reported feeling burned out. So this is not just physicians, this is everyone who's caring for patients in clinical settings. Okay, so we're also facing within our healthcare workforce, a major epidemic of burnout, that people are feeling that they're working so hard, they're not experiencing interest in their work any longer. They're feeling very stressed. They're maybe making more mistakes or wondering whether or not they should make a career shift. And so this just really is some data that shows that we are in a place of dire need in delivering mental health care. And then just to say that we as health professionals are not immune from the challenges that the general public faces. This is actually, this is now a couple years old, but this was a survey of psychiatrists themselves. This is an instrument called the Oldenburg Burnout Inventory. And what it showed, really, you'll see on the right hand of the graph, the pointer doesn't work well, but what you'll see is that 80% of the psychiatrists who filled this out, there are about 2,800 psychiatrists, so that's just about 5% of the psychiatrists in the United States, that they were at high risk for burnout, right? For becoming unhealthy themselves or not finding fulfillment in their work due to the challenges before them. And then you can see that when you look at increasingly younger psychiatrists, so this is the year of medical school graduation. So these are psychiatrists who are just entering into the workforce, that our younger physicians are much more at risk. And that's something that we really have to think about. How do we nurture the next generation to be able to have long careers? And then this is, instead of looking on the y-axis at burnout, this actually looks at the PHQ-9, a screening instrument for depression. And the take-home message here is that more than 1 in 5 psychiatrists who responded had a score indicating moderate or higher risk for depression. So just looking even at physicians who are trained to take care of the mental health of others, right? more than 1 in 5 are at risk of depression themselves. Okay, so how do we think about this? Not just the story I told you about the United States, but also in the context globally about what we should do. So there's been, because of all this data that's been coming out, there's been a lot of attention by the Association of American Medical Colleges, by the American Medical Association, by different professional organizations as well, about physician stories. And one of the big concerns about this are these stories about how prevalent stress is amongst physicians and yet how hard it is to come forward, right? The stigma or the concerns of what would happen to a career. So the story on the left, the link is on the bottom of the slide, is to a story that was done by the Association of American Medical Colleges that really looked at risk over the course of, and stories over the course of training. So it traced the story of my colleague, Jessie Gold, who's devoted her career now to well-being and workplace mental health. She's now at the University of Tennessee, but talking about how the pressure of being a medical student alone really compromised her mental health and led her to get help. So this was not something major, even like failing a test. It was within a medical student context of getting a grade that was less than a perfect grade, right? Getting a B instead of an A on a test, right? And feeling like the performance pressure of those of us who choose to be physicians is so strong, it can seriously impact our mental health. There's another story in that article of Dr. Veal, who talked about becoming so overwhelmed by pressure and having second thoughts about being a physician, beginning to have suicidal thoughts as a second year medical student as well as a resident. And then the most poignant story that I want to leave you with is actually the story of Carrie Cunningham, who is a surgeon, a very, very prominent surgeon. She was the president of the Association for Academic Surgery. And she made the bold decision, having struggled with depression over the course of her life. She was an incredibly, incredibly accomplished surgeon, as well as an athlete, a scholar, and in many, many areas of her life, but struggled with depression. And so in her closing speech of her term as the head of the academic surgeons in the whole United States, she made a confession. And she made a confession that she had been struggling with depression and mental health concerns, and that she was not alone among surgeons. And that if we were going to take care of the well-being of our workforce and take care of patients, that we really needed to tell our own stories and to reduce the barriers. But what she said about coming forward is that the thing that concerned her most about telling people about her experience, right? And this is somebody who's a huge leader, is that people would see her as weak, emotional, or damaged. So this is somebody who is clearly not weak, clearly not overly emotional, right? And if she is damaged, then we are all incredibly imperfect. And so I bring that up to say that in all that we do, we have an obligation to be thinking of ourselves and our humanity and welcoming these conversations as opposed to stigmatizing. We also have had, I know this is true, there's been some concerning cases of suicide recently in Indonesia amongst trainees. Physician suicide has also become a major concern of the profession. Okay. So there's been, if you read articles about the rate of depression and mental health concern in physicians, you will often see that the rate is higher than in the general population. It would suggest that we are not a healthy group of people. Interestingly, this study from 2021 by Harvey and others said, well, maybe against the general population is not the right comparator group. right? Maybe we should be looking at physicians not compared to the general population, which includes people who are working and who are not working, right? Or people who may have other things going on, all different ages. What would happen if we compared the rate of depression on common mental disorders in physicians compared to other employed occupational groups, right? So the groups that they used were teachers, academics, manual workers, military personnel, social workers, and all white collar workers. So people who were working not in direct labor settings. And what they found actually was that physicians didn't look a heck of a lot different, right? So you see on the left is physicians, maybe a little bit lower, but almost an overlapping, pretty wide confidence interval on the right with other workers. That's neither here nor there. I think what it tells us is that we ought to be concerned about the mental health of all workers, right? But it puts in context the fact that physicians may not be such outliers. Although obviously our concern about the mental health of physicians is well placed because we're responsible for taking care of others in very personal and profound ways. So I think this paper from the Lancet, this review is a good one to know about. The link is on the bottom of the slide here for your references, but just to think about what we can know. So just to give you the general sense of the numbers from this paper, a pooled estimate is that about 28% of physicians do suffer from depression. It ranged between 25 and 32%. In high-income countries in particular, the rate of alcohol use or abuse disorders is quite high, about 20%. The rate of other illicit drug use is also is not as high, but is not insignificant. And also, some of the things that we might think about are that some of the generally protective factors are on decline in terms of the kinds of things that were helpful to physicians in improving their senses of well-being. So in the United States, for example, increasingly physicians work for large organizations as opposed to in smaller group practices. And have had higher expectations. So working in systems that give individual physicians less control seems to be a bit of a risk factor. If you compare this from the US and Europe, and you then compare it to low and middle income nations, some of the risk factors for depression and mental health concerns around physicians seems to have to do with stressful work environment, resource shortages, and then also infrastructure complaints, right? So being able to know or have some knowledge of what one could do, but not having the ability or the resources or the access to be able to do that for patients. All of this is to say that this story is very much an evolution. And it's something that I hope, especially the young physicians amongst us, will keep their eye on for the future. Okay, so I want to just take a minute here and talk about physicians in training in particular. You'll see there, you actually have some very good data from a 2024 report about Indonesian residents. But looking at this, you're not so different from the rest of the world. It showed that about 22.5% of medical residents reported depressive symptoms in the period of the survey. And about 2.1% of medical residents were quite depressed, so either moderately or severely depressed. And there was also not an insignificant report of suicidal ideation with, during the course of the study, about 3% of residents expressing that they had feelings or thoughts that they would be better off dead. So that's seriously a warning sign of something that we might think about. If we also think about symptoms that might be associated with risk of developing burnout or depression, more than 50% of medical residents, this is a shocking value, not really, that was a joke, 51% said they're tired. Okay, so I think there was nobody, who has been a medical resident who hasn't been exhausted in the course of training, but we should also be thinking about what downstream effects that has. Almost 40% felt they didn't get enough sleep. 35% expressed lack of interest. And about a quarter said they were experiencing symptoms of feeling down or having poor appetite, right? So this just shows that these symptoms, whether or not they amount to a full diagnosis, are present and need our concern. Comparing that to this study in Japanese residents, just to bring in another country, some of the risks for burn. So the association between being burnt out and depression was not clear. We have a lot of work to do on figuring out the connection between the two. But some of the risk factors are starting to really come together as we look across both young physicians and established physicians, as well as physicians within a specific country. But being a woman puts you at a higher risk for burnout in Japan. Working in a larger institution and working more than 100 hours per week, right? So these are some of the things that we could think about in terms of making this better. I want to just point out, though, that in this bottom corner, one of the things we've been thinking a lot about in the US is about how physicians can most effectively advocate for themselves and being able to provide care for their patients. And we've been thinking a lot, increasingly, physicians in training are forming labor unions, organized bargaining units, to be able to get better work conditions, to ask for better pay, ask for better benefits. And if you actually go back, what I said, what's old is new and what's new is old. If you go back actually to thinking about physician labor and organizing, it was actually residents in New York State in the 1930s, so 100 years ago, who formed the first organized labor unit for physicians because they were not paid. They did not have adequate sustenance or food, right? They had poor living conditions, and they had terrible occupational risk of injury and death. It turns out that at that time, the way they would teach the medical residents would be to bring them around riding on ambulances. And at that point in time, we didn't have a lot of road safety. We didn't have seatbelts. We didn't have lots of interventions. And physicians were actually at risk of death due to accidents and injury while they were working. So I think this trend of thinking about how we can help, in particular, young physicians, residents, physicians in training who are generally poorly compensated, or if not at all, without a lot of us advocating for their working conditions, we can make huge differences by really attending to their needs and also learning about how we can be effective for voices for change as well. All right, so where does this all leave us going forward? You could be either very, very depressed that we haven't gotten very far in taking care of the mental health of physicians and our workforce, or you could say the fact that we're talking about this now, the fact that our big leaders in medicine are talking about the reality of the pressures and the stress gives us an opportunity to make positive changes. So the first thing we can do is really, really simple. We can actually learn to talk to each other about our mental health and our well-being the same way that we talk to our patients. Beginning a conversation, if we're noticing that one of our colleagues, noticing first in ourselves, but sometimes that's hard, but noticing in our colleagues, if we're not engaging in good self-care, if our colleagues who are seeming not to enjoy their work so much, or feeling a lack of joy, being flexible and asking about family and things, other commitments outside of work, opening up the door for a conversation to really engage and try to help each one of us improve our well-being. I want to point out, though, here, this is a study from the Dr. Lorna Breen Heroes Foundation. This was organization was started after the pandemic in memory of Dr. Lorna Breen, who was a very exceptional young physician who sadly took her own life. And many of the things that physicians say are that if I have depression, it says something negative about me, or people will think less of my my abilities, or that I'm going to lose my job, or I'll lose my ability to practice medicine because people will think that I'm not a good doctor. And one of the things that goes along with that is that physicians in the United States are very, very worried that they'll lose their medical license or their ability to practice at their job if they report mental health issues. So one of the things that the Dr. Lorna Breen Medical Heroes Foundation has done is actually change licensure laws. The licensure laws would say, do you have a medical condition that currently limits your ability to practice? And then the question right below it will say, have you ever in the past or now been diagnosed with a mental health condition? And the difference between the two is that for mental health, it was like a lifetime stamp or stigma. And for physical health, it was just something that interfered with your ability to function. So they've been working on closing those loopholes, both for licenses and for hospital privileges. We've also been working, this is from the American Psychiatric Association Foundation, to develop workplace toolkits. These are available with that QR code, and they're free to help institutions and hospitals, right? Medical schools have resources for peer support, for reducing the fear and shame of coming forward, and also for preventing suicide in particular. This is my last slide before we wrap up, but this is back to the Harvey article. And basically, after doing that review of what some of the risk factors were for physicians suffering from mental health conditions, really making the argument in a pictorial format that taking care of our mental health and our well-being is something that needs to happen across the entire lifespan of physicians. Right. So developing all the way from medical school in working on coping skills and normalizing health-seeking behavior instead of stigmatizing it, to ourselves as young and older physicians to train using adaptive skills and providing specialized services. And also then, as we become more senior, building that into our care or supervision practice with junior physicians. And then also even beyond, right? Thinking about having been in a profession that has such a strong calling and such a strong identity, how do we take care of ourselves even after retirement across the whole lifespan? Okay. So with that, I want to just sum up what we've talked about a little bit, and I hope that that's inspired you to think about ways both within yourselves and within communities that we can build resources to support the mental health and well-being of the physician workforce so that we can advance the care of those who we serve. So we talked about how we shined a spotlight, right? So if you have something that's a stress or a disaster or a major medical mass casualty, a way of thinking about it can also focus attention on the need to meet unmet challenges. We talked about the ongoing challenges for physicians throughout the lifespan and also for the future generations. And really that it's in order to take on a problem of such great import, we're going to need to take solutions on multiple levels. Number one, with individual conversations with each other. Number two, by building in education and resources. And number three, by building a healthcare system across the lifespan of physicians that makes resources available, as well as increases the ability and reduces stigma or barriers to engage in mental health and wellness care for physicians. So with that, I thank you for your attention, and I'll look forward to questions when we come to our panel discussion. Thank you so much.
Thank you very much, Dr. Rebecca Brendel, for your thoughtful and timely presentation. It reminds us how essential it is to prioritize the well-being of healthcare providers in an increasingly complex and demanding clinical environment. So before we go to our next speaker, we'll now be taking a 10-minute break before we continue with our next session. So you can grab and recharge and grab some drink outside the venue. We'll resume it in 10 minutes. Is it all right? Okay. Uh, you can grab the drink outside. introduce you first. Oh, okay. Okay, let's begin again. Our next speaker is Dr. Tan Hui Siu, a respected clinician and certified healthcare ethic consultant, HECC. Dr. Tan holds a Master of Bioethics from Harvard Medical School and a certificate in pediatric bioethics from Kansas City. With extensive clinical experience, she formerly served as the district head of pediatrics in Malaysia, contributing to both local initiative and national ethical guidelines. She currently leads the Hospital Ethics Support Service, or HESS, at the Hospital Ampang, where she focuses on ethic consultation, communication training, and capacity building in clinical ethics. Today, Dr. Tan will share her expertise in presentation titled Healthcare Ethic Consultation. Dr. Tan, the screen is yours.
Okay. Thank you so much, Dr. Astika. So, selamat pagi, ya. Selamat pagi. Kita kirim salam, ya, dari Kuala Lumpur, ya. Saya seorang pegawai kerajaan, ya, juga. So, dari Hospital Ampang, ya. So, very happy to be here. So, I'm going to share more today on the experience. So, more sharing, lah, yeah, more of sharing, and the service that we have and the consultation flow methods that I'm going to just share what we are doing in Malaysia. Okay, so this is where I'm from. So I'm from the pediatric department. I lead the hospital ethics support service as well, and also the co-chair for the clinical ethics committee at my hospital. I'm also a member of the Malaysian Research and Ethics Committee and have been recently appointed to the National Bioethics Council by the Ministry of Science and Technology and Innovation. So I used to be quite active in the Malaysian bioethics community during the COVID time, and definitely we have a small group with the pediatrics as well. Okay, so the one thing that I would like to share these slides, the issues that got me into bioethics. Okay, so I think there are many clinicians today, ramai doctor today, kan, and also medical educators, and I think the things that got me very, I would say, into the stage of like what Dr. Lee has said about burnout is some of these things are here. And I have been still seeing our colleagues that are not able to actually feeling comfortable to disclose error, not knowing how to say sorry, not allowing family presence, even during the end of life, like during resuscitation. And we have issues and we have problems with not having that real conversations, that we are more focused on signing BNR forms. Yeah. So I'm not sure whether it's particular to just Malaysia, but definitely there are many of us are still signing AOR forms, meaning, Dharma forms, okay, for patients who wish to go home. I think we have an issue with spending too much time doing documentation because of the legal risks that we are very worried about, okay? And also always forget about the patient themselves when they are still having that capacity to make decisions. So we tend to focus on what the family wants, okay, or prefers, that we tend to actually forget that the patient may want something else, okay? So these are some of the issues that we may have. They are not exhaustive, but I always believe that sometimes doctors do make decisions because of the conditions they are being put under and also the pressure they have. And it may be related to skills, it may be related to knowledge gaps, external factors, and also professional integrity, okay? So if we have rules that we tend to try our best to observe, yeah? So definitely we have rules, we have guidelines, we have code of conduct, okay? We have professional guidelines, we have also clinical clinical practice guidelines, CPGs, we have the associations, medical associations with their guidelines. And I think it's important to be there and to remind us on duties and boundaries and remind us on our standards of care, and also protect the rights of patients, especially the ones who are vulnerable. But it is still insufficient to resolve some of the complex ethical dilemmas and gray areas of clinical care and practice. Okay. And because of this fear of litigation, and I would say sometimes we do take a defensive or defensible stance in the way that we make decisions. Okay. So I think many clinicians are still doing what is required to get out of trouble. And we find that to get out of trouble is actually an easy way out, because sometimes there are many more things that we have to ensure that the patient, gets what is, what he prefers and what he wishes for. So when I think about that, when I went, on the journey of bioethics, and I was thinking, is it just an issue with, Malaysian clinicians, doctors, and the healthcare system, or is it the struggles of medicine itself? As we know, medicine has progressed. Okay, definitely we have seen how ventilators come about, how dialysis comes about, and how many of the biotechnology has come about to actually prolong life. And I think we are taught to save lives. Okay, so there are like no other, options that we have. We are tasked, we are entrusted to actually save lives. So medical heroism is actually something that can be helpful, but also at the same time has been something like a catch-22 situation where we are not able to know what to do otherwise. Okay, we are still focused on curative medicine in Malaysia. And I think the professional integrity is also at times being very heavy, and it can be burdensome to some of us who feel that, we may have to let go at times to make sure that the patient receives what they want. Okay. I think there is a redirection that we need to focus on health and well-being. And I think the previous speakers has actually already illustrated on that. I think the one thing that we do not know is how to manage death and dying, and especially the steps to actually let go is still very much lacking in Malaysia. Again, when we talk about respect for autonomy, I think it's important that we look at respect for persons and connect and understand wishes and values. So we may have the afternoon session talking about more on that. Okay, we need to actually know what is moral distress, basically a phenomenon that has been coined, has been termed to use for clinicians and doctors and healthcare professionals when they cannot do the right thing. And definitely we must look beyond the walls of clinics and our hospital walls to actually understand many of the instances is beyond our power. Yeah, we can't do anything much because there are many things that needs the help of other ministries, other sectors to actually kind of make sure that the social determinants of health is being taken care of. So what I've learned during my journey, definitely, what is bioethics? Where does the laws come in? Moral distress, okay, moral dilemma. So I've learned to actually use systematic approach to resolving moral dilemma. And if I have a regret because there are choices that I can't make, also I've actually learned to know how to disclose, apologize, compensate, and change the way the systems are. So there is a need for clinical ethics in Malaysia, and this has been, I think the field has been a bit more active for the past 7-8 years to actually address the challenging cases and issues, ensuring quality of care and the moral distress of clinicians, and at the same time to actually kind of balance, the overpowering legal risk management and defensive medicine in practice. So I give you just a quick one, so it's a bit more interactive today. So we kind of have these questions. I've prepared these questions, very simple one, and you can just go through thinking about when someone talk to you about healthcare ethics, okay, clinical ethics, what does that mean? Okay, is it a very subjective view? It has a systematic approach to resolving ethical issues. Its recommendation is binding. Okay, so if you have a consult, are those recommendations binding? Its main aim is to monitor the ethical conduct issues of healthcare professionals. Okay, main aim. Its roles can be seen through consultation, education, and policy making. The principles and framework that it uses confine to the 4 ethical principles. Is very much about person-centered care and patient-physician relationship. It does not take into account legal matters, and a thorough consultation process requires a process because it deals with specific stakeholders' values and conversation. Information must be adequate and accurate. At times, we need engagement and dispute resolution skills. True or false? So you can actually kind of write it down somewhere or just, mentally just think about these questions, okay? So when it comes to the field of bioethics, I think what we are trying to give you, an overview, there are many subfields under the field of bioethics. Definitely, it has stemmed from the medical side and, the biosciences field, and it has branched out to things like research ethics, public global health ethics, environmental ethics, animal ethics, biotechnology, and clinical ethics or medical ethics is one part which is related to care. That there are many framework or tools that we can use in ethics nowadays. Okay, so when it comes to clinical practice, because I'm a practitioner, so there are a few things that we are always go back to. First thing is going to be your professional ethics, which is a bit more on duties, your standards of care, and you can find this in your code of practice, as in Indonesia as well, and in your medical council. Okay, things that regulates the profession, regulates the doctors, regulate the care that we provide to patients. Okay, so it can at times be rigid, legally flavored, and it involves the contract-minded patient-physician relationship and the narrow definitions of ethical principles. Okay, so do you agree with that? Okay, so the next will be virtual ethics, basically what a good physician would do. Okay, so I think this will fit into many of us when we actually went into medical school or, taking up biosciences subjects, that we want to do good and we want to help others. Okay, so I think these are the attitudes that clinicians should hold, and sometimes it can lapse into self-righteousness, also paternalism, if not sensitive to the nuances and aberrations. So it's sometimes, we say we want to do good, we must be truthful, we must be honest. Okay, so but at times we won't be able to fulfill that as well, right? Am I right? So I think, but this is the main principles that guide us. So other things are, the framework that I've shown to you. So clinical ethics is related to clinical practice, and it should be part of clinical care. So these are some of the framework that we won't be delving today, but you would want to know that apart from principalism, you have casuistry, narrative ethics, feminist ethics, and microethics. And I think we have more topics tomorrow. Am I right, Adita? Yeah. Okay. So this will something that we can go into tomorrow. Okay. So the history of clinical ethics, this is just one side of, I would say, one published article on clinical ethics. And this is Dr. Mark Ziegler. So at the beginning of when we were born, there were already issues with Western medicine, okay, I would say. So this is where, there are many troubling questions that send his students trying to find the answers because of the advancement in intensive care. So his model that he has started begins and ends with the patient, guided by the patient-doctor relationships. So what happened is he teaches his doctors to actually try and solve the issues in clinical care by having special approaches and frameworks. Okay, so at that point, the doctors were saying, this is where we have to step in and take charge of the medical dilemma, the ethical dilemma ourselves, rather than leave it to the philosophers and also the legal academicians and, lawyers to actually define what is right. So that is where in the US, ethics consultation matured, very long ago, 40 over years, and even reached the stage where there is a top-down requirement by the Joint Commission on the Accreditation of Healthcare Organization that requires hospital to have committees, okay, and consultation service. And the main aim is actually to improve the process and outcomes of patient care by helping to identify, analyze, and resolve ethical problems. So when you come to the definition of clinical ethics, clinical bioethics of health or healthcare ethics, it is basically a practical discipline that provides a structured approach to assist healthcare professionals in identifying and then analyzing and resolving ethical issues that arise in clinical practice. Okay. So the goals, first thing, as we have said, okay, second, we hope at the same time it actually empower healthcare professionals for ethical practices, to create a moral space and support for stakeholders through the process of ethics deliberation and reflection. I think that the third is the one which stands the most important. It is a commitment to say that we are here. There is a venue to actually come together and actually discuss the problems that we have. Okay. So the fourth is to advocate changes to systemic barriers and inadequacy that affect care. So when you look at the goals, to fulfill these goals, most of the time in an institution, there may be a case consultation service, educational activities going on, or policy making processes by the committee. Okay, so these are the roles or the activities that can be held in a hospital by individuals, a team, or a larger committee, usually institutional. So it can be in a university hospital, it can be in a university, it can be in the hospital, but can also be in a regional. So this is just a one slide just to let you see some of the hospitals in Malaysia. This was just very recent. So some are from the public hospitals. They are small specialist hospitals. Some are bigger tertiary hospitals, and also the university hospital like in University of Malaya. Okay. So the models that we have in terms of committees, because we are talking about people coming together, right? Okay, so people coming together, I think in most of the Asian region also, I think we have a lot of jawatan kuasa, yeah? So jawatan kuasa can be big, can be small. So there is pros and cons when you have a large group of people coming in. You may have the best diversity that you would like to look in ethics committee, and you may need a secretariat, and it is for the best representation and it's suitable for policy making. But not so much of active cases ongoing because it needs to get everyone to sit in, unless you have special provision about quorums. Okay, so a small group will be easier to meet. You can actually discuss cases more easily, but may lack perspectives. Okay, so the other model is to have a large and a small group, where you have a small group as working group managing active cases, and a bigger group when there are more challenging cases, or when you have to actually discuss on issues or policies. Okay, so in Malaysia, we have actually tried and think about how are we going to call someone who are doing ethics work. Okay, so in the US or in many of the Western countries, they may use the words like ethics consultants. Okay, and we feel a bit humble about the whole word about consultants, because medical consultants takes many years and many years of experience and training. So we have kind of decided that an ethics officer will be good enough if you are qualified and trained, and if you are part of the committee of the team, that you are actually assisting the ethics committee and also the ethics officer, and we have actually kind of termed ethics facilitators. So again, when you have a committee, kalau you ada committee, you ada sekumpulan doctor ke nurse or any clinicians, what we are actually doing is not only looking just the case, the doctors involved, or the families involved, and most importantly the patient, but we are also looking at the systems, the policies, the health, the law, and the social cultural context when we are looking at the case. So we will need to actually balance and weigh the issues, and what are the significance of each principles, and decide where are permissible, where are impermissible, and where are the gray areas. So importantly, we are trying to enable permissible actions. Okay, so actually there are more permissible actions than are impermissible. Okay, so the circus looks exactly the same size, but they are probably not. This is where, when we talk about clinical ethics, some of us have thought about what are our roles, what are, in the end of the day, what are we trying to achieve? And I think what happened is when you sit together, kita panggil, kita nak cuba dapat satu consensus, right? Consensus. So consensus too is where, because everyone will have different values, different perspectives, and different moral appeals. So we need to sit down and try and balance those appeals when we talk about rights of the patient, the person themselves, of our virtues, or even the system, the cost effectiveness of care, and also justice. So sometimes it may lead to different conclusions, right? But at least we have to actually start somewhere, yeah? So again, when many have actually has these answers, questions about like, are you an expert? Are you someone that we should go to because you're an expert? Or are you somebody that facilitates the process, having that interaction with all to make sure that the ethical process goes on, okay? So it's either to know or to do. So sometimes some of us falls in between some of this, okay? At times we do, we're able to actually be the one who's listening, and we are there to actually offer ethical languages that is easier for everyone to understand and to come to terms and to come to a common interest, okay? So this is a very general framework where every time when there is an ethics consultation, when there are a case or issue, we go through the process of intake and we go through the process of asking what is your ethical questions. Okay, so like research questions, definitely you have research questions when you conduct a study, am I right? Because without a research question, you may not, with the PICO method, and you may not know where you're going to go in, where you're going to zoom in, which population, and what you are trying to measure, what is the hypothesis that surrounds the questions that you're going to ask. So that is very important to actually frame what is your ethical concerns, follow by the information that you need to gather. So it's very much like research as well. You have to actually collect data, you have to get your information, that's where you're going to analyze and in the end come up with the conclusion or recommendation. So it's very much like research, right? If you think about it, okay? What happened is many has not reached the stage of stakeholders engagement, which I feel would be the most important part, because the stakeholders engagement is where the facilitation of conversations comes in. We mediate conversations, we are there to support everyone. So we are more or less like a neutral third party, okay? I didn't know this as an animation, okay. So this is a long list, but just to show you from the American Society of Bioethics and Humanities do have a framework, okay? The diagram is an easy way of just capturing 10 steps here, okay? Yeah, okay. So these are, some of the standards that we are following in the ethics case consultation. So again, when you talk about an ethicist who knows, who are advisor versus someone who does, okay, someone who partakes in the conversation and also the dialogues, okay? So I think that is where we are able to come with resolution for a particular patient, family, because we do consider everything, okay? We do consider all the context and most importantly, the patient's values, okay? So we go back, information is important, effective communication is important, including some of us do try and pick up dispute resolution skills, okay? So this is just a referral flow from one hospital, which is my hospital. So many have asked, how are we going to put in as a referral? So I would say, any clinicians that felt, a bit wrong about something, they feel macam bersalah ataupun dia rasa macam geram dengan rakan sekerja, or they feel something not right, sometimes they just pick up a call and ask, why is this happening? Can I do something about it? So at this point, we have not expand to more than, beyond the doctors, they are still doctors mainly. Again, as you know, the power dynamics of things and, the decision making is always at the specialist level. So at this point, many of the referrers are still at the specialist level. Again, we call it ethics case consult. We have a Google form. They can call, they can email, can fill up the form. And because case might come in any time, but we do say that if can, you try and get in touch with us during, the office hours. So what happened is when the referral comes in, there is a form where we do ask them, how urgent is this, okay? Is this within 72 hours, 1 week or 2 weeks? And at the end of the day, we do spend many hours interviewing families, sitting in the family conference, interviewing the doctors, interviewing the teams, and sit down writing and sit down and discuss and, looking through all our resources in terms of policies, in terms of what are the guidelines, getting more second opinions with other specialists. So in the end of the day, when the recommendations come in, what we always stress is they are advisory in the sense that we do provide recommendations on the ethically acceptable and options and their moral weight and significance. They are not binding and usually one-off. So the final decision lies with the primary team in consideration of the patient's goals and values. What I find for the years that we have been doing this, we find that the process of interviewing and discussing, most of the time, they tend to find, an answer to it. They find something that they could work with, they agree. And I think that actually kind of help more than just a report, okay? But we do have a system where we kind of put out a survey and asking about how did we do in terms of efficiency, quality, and outcome survey for the clinicians. So this is the report framework. Okay, and the challenges, we are almost at the end. I will just share a bit on the challenges that for these few years, and I think we have had a few conversations also with those in the US and knowing how they have started, how they were sustaining themselves, and the challenges they face is not far away from what we are having as a very new service in Malaysia. First would be the lack of awareness on the sportive roles of ethics. Okay, often I think the one thing that we are worried to go about is being seen as an ethics police, and also trying to say that we are there to make sure that everyone complies and everyone obeys. I think that's not the main aim. Okay, we do encourage and we do empower doctors to try and think about what is the right thing to do. But at the same time, to understand that the challenges, that the barriers that they face, definitely we still have a tension with defensive medicine, and the lack of measurable outcome for administrative persuasion. Many of us are still clinicians, so we are still going on call. We see patients in the clinics, in the wards, and I think that needs a lot of sustenance and stamina. We don't have many that does this, okay, to be frank, okay? And I think in terms of expansion of service, because there is dire needs, there are many who actually, that has put in a referral, and there is a balance of how far we should expand versus the quality of service. So the practical steps that more often I will share with many of the hospital directors or even the state health department would be, if you want to take the first steps, would be to think about how would you create the awareness, okay, by integrating into daily clinical practice. Okay, it would be anything from a bedside discussion or, incorporating into any of the, case discussion that we have in the wards, and about where are the ethical dilemma, are we feeling distressed about the final management, the final decisions for that patient. So it can come into a form of ethics rounds, even virtual webinars, or even ethics reflection during case discussion. The next step could be forming a committee. You can find anyone who appears to be very interested and also can champion the whole cause. That's where we can actually sit down and think about whether we should be discussing on cases or whether we should think about policy making, okay, or improving the policies that we have. Skills and competencies are something that we are running on the ground now by HAS, that we find that it's actually very important to actually get this up as well, because that is where, without that skills, you can't even start to discuss between teams or with the families, okay? So the next step was actually trying to train many of the ethics committee members at this point of time. So we just came back from a workshop on Monday and Tuesday. Step 3 is when it goes to institutional or national. That's where the policies such as advanced care planning, the crisis standards of care during pandemic, will come in to actually try and improve care across the board, okay? So this is where I think would be important for us to think about if we are going to take this, embark on this step. So conclusion for today, healthcare or clinical ethics consultation is new in Malaysia and the region, with an understanding of its roles and concepts to be strengthened. It is a systematic venue to address moral distress and dilemmas in practice, resolve conflicts and complex decision-making, eventually improving the quality of care, empowering clinicians to do what is right, and creating moral spaces for all. There are remaining challenges, but there are practical steps that institutions can consider when the system are still in the early phase. So thank you. So the answer, I think it is there, yeah? But I'm not sure whether you agree with me, lah. It is subjective, maybe yes, maybe no, but I decided to put a false there. It has a systematic approach, true. Its recommendation is binding, false. And also the question about if it's not binding, then what's the point, but we talk about that later. Its main aim is actually to monitor the ethical conduct of healthcare professionals, no, okay. Its roles can be seen through consultation, education, and policy making. Through the principles and framework that users confine to the form as ethical principles false is very much about the person, yes, and relationships. It does not take into account legal matters, false, and the last one is true. Okay, thank you very much. Okay, thanks.
Thank you very much, Dr. Tan. It's very empowering presentation. It's remind us that the ethicist is not a moral virtuoso, but also a participant of this whole process. Okay, for the next session, we are pleased to welcome back Dr. Rebecca Brandel for her second presentation in today's session. In this next talk, Dr. Brandel will broaden the lens from clinical settings to the organizational level, addressing themes that are deeply relevant to the healthcare institutions around the world. Her presentation is titled Organizational Ethics, Moral Leadership, Professionalism, and What Can We Do Better? Dr. Brandel, the screen is yours.
Thank you. Okay. So, Dr. What?
My name?
Do we have the slides?
Do you have the slides?
Okay. All right. While we're waiting for the slides, maybe I'll start talking. So, no, that's not it. Okay. So actually, let's just start talking about it. And maybe this will help. It's been a little bit of a while of of a lot of lectures and talks. And what I want to talk about now is thinking about what the interaction is between us as humans, as actors, and the institutions and the organizations that we built. So this morning you heard first from Dr. Lee, who talked to us about different codes, about different ideas, about different ways that we could think about and bring our culture, our beliefs, our commitments into our work. We also then heard about the role of different principles and ideas in clinical ethics consultation. I talked to you a little bit about some of the challenges we have for our own well-being as healthcare providers. We've mentioned in a number of different places, there are standards for how we do clinical consults from the American Society of Bioethics and Humanities and other groups. WHO is coming up with standards also. We talked about professional standards that come from the World Medical Association, right? We talked about different ideas of where this could come. And I want us to start out, though, with this other kind of competing idea. You heard a little bit from Dr. Tan just now about this idea of virtue ethics, right? So we oftentimes, when we're thinking about our ethics, what we're thinking about is how we should be and or what we should do, right? So what is the right thing to do? That's what a clinical ethics note is all about, right? That's what the team is coming to ask Dr. Tan and her colleagues when they ask for an ethics consult. When they're interested in, and when we're interested in thinking about what the right thing to do is, another way we might go, you heard from her, is this notion of virtue ethics, right? What kind of person should I be? How does the good doctor act, right? And I have ideas about what the character traits would be that would help me do that. I have ideas about who my role models are, who my mentors are, right? Early on or in practice or when we have very difficult cases, we oftentimes think, what would my mentor do, right? What would my teacher do, right? And so we think about ideas of moral exemplars, people who we aspire to be like in our ethics. Okay. Now, the idea of all of this is that if we have some guideposts about what the contours are or what puts out the ideas of how we can be a good person, okay, that we will do the right thing. Okay. And if there's one thing that I want you to remember, there's one point in this whole entire, that we have 28 minutes left. So you can write this down and then you can nod off or daydream, or I hope you'll want to listen more. But if there's one point that I want you to remember, It's that we cannot do it alone as humans. I'm going to give you some evidence to get us to think, some thought experiments, some studies that have been done, some other some other information to prove my point to you. But what I want you to remember is that we as humans can't do it alone. Number one, we are very susceptible to influences from our environments. Okay? So in a good environment, it might foster us to behave altruistically or beneficently. In an environment that's less supportive or threatening or punishing, right? Think about how afraid physicians were, even senior physicians, to say that maybe they were struggling with a mental health condition. In an environment that does not bring out our best selves, we will struggle more. What does all of that mean? What that means is, as we think about the way we teach and our schools, the way we take care of patients and our clinics and our hospitals, and even more than that, the way we build a healthcare system for a whole entire country or region, right? The decisions we make, the institutions we build, and the structures that we put into place will say a lot about how we ultimately do in the end, about whether they support our commitments and our care, or whether they take us astray. Okay. Yeah. Did we find them? Do we have them? You want to plug them in to the, yeah. Mail. Yes, please. You can judge me on how well I did with my slides without them. Okay. So, all right. So, this idea then that so the interaction between individuals and systems and organizations is where we're going to place ourselves for the purposes of this talk. All right. While they're working on pulling up the slides, let me add a little bit more to this story. Okay. So you heard about this idea of virtue ethics, right? So the person who came up with virtue ethics in Western philosophy, or one of them, is let's see if they get them. Is the Greek philosopher Aristotle. Okay. And so what Aristotle had, and this will sound very familiar to you because he's just one person and probably not the most, okay. So not the first person, right? So there's a lot there, as we've been spending time having a dialogue between Asian ideas and Western ideas. This is very much has resonance of some Confucian thought as well. There are also ideas in Buddhism that resonate with this. The idea in particular of virtue ethics is that cultivating our character is what's going to make us act the right way, becoming good people, right? So we have ideas that are ideas about core focal virtues of being a physician: compassion, discernment. Let me just see. Would it be helpful if there's a drive there too? Oh. Okay. All right. So this idea, right? So tell me about what are some of the character traits? We'll crowdsource this. What are some of the character traits that would be associated with being a good physician? Who wants to give me one? Somebody who you know who's a good doctor. What resonates with you about them? What makes them a good doctor? Patience. Care. Excellent. What else? Okay, respecting patient autonomy. So being somebody who's a good listener, right? Or is respectful. What else? Compassion. Empathy. Great. Okay. These are all characteristics that we think would make physicians good. So, and one of the things that we think about physicians is that working in the interest of others, right? For the good of the patient is one of the core values that we would bring forward. Okay. So let me tell you a little bit of a story. So sometimes we think that people who are religious leaders are very compassionate and good people too, right? They dedicate their lives to a higher calling, right? To ministering to the ill, to the sick, to the needy, to the poor, right? And so there was a study that was done now 50 years ago in Princeton, New Jersey at one of the seminary schools that really wanted to look at how virtuous, right? How good seminary students might be. So what they did was they asked the seminary students to prepare a lecture on the story from the Bible of the Good Samaritan. Who knows what the story is of the Good Samaritan? Do you want to tell us? That wasn't fair. I asked you if you knew and then I put you on the spot. Does anyone want to tell us? The Good Samaritan. So the Good Samaritan is a story about finding somebody wandering, right? Who's needy, who's poor, who has few resources and who's lost. And it's really about one's obligation to stop and help somebody who's in need of care, who's in need of our concern. Okay, so here you can imagine you have all these seminary students and they've just studied about the story of the Good Samaritan, about responsibilities to stop and offer care to somebody else who's in need. And then they did the following thing. They told these young seminary students that they were going to be graded, evaluated on their sermon, their lecture on the Good Samaritan. And then they divided them up into 3 groups. They said to the first group, hurry up, you're late. Your lecture is going to be starting and everyone's waiting for you. To the second group, they said, make your way or you'll be late. To the third group, they said, make your way in no hurry at all. Okay. So, on the way, they send all these students out into the seminary to go to the other room to give their lecture. And what do you think happens on the way? It turns out this is a psychological experiment. So the seminary students don't know it, but they have somebody who's a bystander, just a person who's on the ground moaning in pain, right? As if they need help, right? Not unlike the sermon, the story of the Good Samaritan that they've just read, right? So you would think that they'd be primed. Oh, I've just studied this and now I see somebody who's in need. I'm going to stop. Well, what happens? Well, for the students who are in a very, very big hurry, they're going to be evaluated. They're under stress and pressure, and they think their whole career is going to be over if they don't get there. How many do you think stopped to help the person who appeared to be in distress? Did they all stop? Because they had just studied? No, everybody knows where this is going. I set it up too clearly. I wouldn't be telling the story if it were true. Okay, so it actually turned out, right, that a minority of the seminary students stopped, right? About a third. When you take the group that's told go on your way. Don't get distracted. Time is of the essence, but you're not late under that pressure. What do you think happened? Did more or fewer students stop to help the person who acted like they were in distress on the ground, moaning on the ground, right? So if you're in a little bit less of a hurry, are you more or less likely to stop? Right? You're more likely to stop, right? If you're late and you're going to be in trouble, you're going to make your way straight there. If you're in a little bit less of a hurry, right, you're going to be a little more likely to stop, but you're not going to want to be detained if you think you have something else important to do, maybe. What happened with the students who weren't really in a hurry at all? They just had to make their way for the next class. How many of them stopped? Did they all stop? No, I wouldn't be telling you the story if they all stopped. Okay, so they didn't all stop, but more of them stopped. Okay. What is the lesson of the Princeton Seminary study? What the lesson is that even when you know what the right thing to do is, even when you've studied the right thing to do, even, I'm in trouble, I'm going to do something very bad today, even when you prepared a lecture, right, about the right thing to do, we are still human, right? So 100% didn't stop even when they were weren't in a rush, but just being in a rush, right, makes future members of the clergy, right, future priests, seminary students, right, it makes them less likely to stop. That should give us pause, right, because we know that when we work in healthcare systems, right, we're in systems that put us in a big hurry, we're in systems that put us under pressure, right, and we're in systems that automatically set up the kinds, oh, look at this, the kinds of situations, yay, that can put us, okay. The kinds of situations, right, that can lead us to not act as our best selves or not put our best foot forward. Okay. So, and I want you to just remember that, right? That doesn't mean we're bad people, right? It means that even when we know what the right thing is to do, and we want to be the sort of people who do the right thing, our environments do matter. And so that gives us a particular responsibility to build the kinds of structures and organizations that bring out our best selves, not our worst selves. Okay, that's the whole lesson of this. So what was the stuff I was going to tell you about if I had my slides? So we talked about this, right? I don't know if you can see in the background, this is very funny. We have a supermarket in the US, if you've ever been there, it's called Trader Joe's, and they have funny names for all their products. So the picture in the background was given to me by a student, but they're called moral fiber bran muffins, right? They're very good for you. They're very healthy, right? But it's playing on a pun of what your moral makeup is. Okay. So we think of ourselves as people with moral fiber. We're people who have, who try to be good people and act in certain kinds of ways. And we think that's relatively durable. We talked about this idea of character going along with virtue ethics. In the background here is Aristotle. But this idea that we could have focal virtues or character traits that would make us particularly good at being doctors. Compassion, discernment, integrity, trustworthiness, conscientiousness. We also talked about, we had care in there with compassion as well. Okay. And then this was a contextual example because it turns out actually that people who are doctors sometimes do very bad things, right? So one of the things that's happened in recent history, and the example here is that physicians in the National Socialist Party in Germany in the 1930s and 40s, actually physicians were big leaders within the Nazi Party and were major leaders both in conducting unethical experiments on people of Jewish and Roma descent, but also considered themselves physicians. And they and how that worked and how that happened had a lot to do with the environment and the structures. Okay, so There are some other things that we could say. So we talked about the seminarians, but it's also true that if you think about something that's even less than being able to go and help somebody, if you ask someone to make change or to help you with something small, you drop a folder full of papers. It turned out that if it smells good in the environment around you, if you're standing next to a bakery or something with pleasant odors, right, or pleasant smells, you're more likely to be helpful than if you're standing next to a garbage truck, right, or something that smells terrible, right? So these are little ways, just little clues about the ways that our environment plays in. So these were the examples I showed you. This was the seminary experiment. So at baseline, 63% stop to help. If you're in a rush, only 1 in 10, right, future members of the clergy who had just prepared a lecture about stopping to help will actually help. And that should say something to us about that. This is another example that I'm not going to go into, but this is a situation in which they did studies just on volunteers and asked them to deliver an electric shock to help a so-called learner learn. But what was really alarming about this has never been repeated. It's broadly now considered incredibly unethical because of the stress it caused to the participants, was that even if you thought you were hurting someone, even if someone asked you to stop, right, in the interest of an authority figure telling you, please continue, please do, you must go on, that people would go on till the end with little variation between cultures and persons to do something that was affirmatively harmful just because of that coercive element, right? And the environment there. I bring that up because that's the second piece of this, that our environments can prevent us from being our best selves, but they can also, right, override our impulses. So how do we build them? Okay. So I want to suggest that what we need to do is to say that our character, who we are, how we build those values, the kind of ethics education we're doing today, the kinds of learnings that we're doing about how do we make these hard decisions in clinical ethics scenarios that you just heard about, that our character does matter. It matters for us to know our values. It matters to have codes of ethics. It matters to have the kinds of default rules or expectations. But also, right, how we engage in our work and how we build our hospitals and our systems also matter, right? This is a picture of a ballot box, right? That's supposed to remind us that what we choose, listening to voices and coming up with consensus around things, can be very, very helpful in helping us feel that we have agency and participation in our work environments. But there are a lot of challenges now, right? So when we think about practicing between one physician and one patient, we know what to do when we're at the bedside in and of itself, right? But when we start increasingly working in institutions, when we have pressure about how many resources we have to use, right? When there are more patients to be seen in a day than we could see working at twice or 3 times what we think a reasonable capacity is, those are some of the kinds of stresses that can erode our empathy, make it harder to do the right thing. Okay, I told you one thing already that I wanted you to remember, right, was that to do this work well, we can't just count on ourselves. We also have to count on the kinds of systems and institutions that we build. Right? Okay. The second thing that I want to leave you with is that that's going to continue. That takes a lot of work for us. And that as our systems get increasingly complicated, it gets harder to do that. And we have to put more and more energy into it. All right. So at the same time that we have to think about the aims of our systems and the work that we can do, right? We also want to make sure that we're creating and cultivating the skills in ourselves to assess how we're doing. If it's not working, what are the alternatives and how we can do that? All right, so let me talk about a couple of the things that I think are really potentially going to be challenging for us as we think about both how we want to be as physicians and how we can deliver the best kinds of care. First, there is this issue with how do we deal with funding and putting resources into a healthcare system. Every country is facing that, right? So the U.S. is, this is not, in the U.S., I had mentioned before, we're not doing very well. We spend more money. We spend almost 17% of our gross domestic product on healthcare, maybe more depending on how you figure it out. We do not have the best outcomes for health in the world. In fact, we have some pretty low outcomes. But even more than that, we've just had part of our government already vote to cut funding for healthcare for those who need it the most, to cut our social safety net programs in the interest of having people pay fewer taxes. So just because we know that we can and we have the ability to do it doesn't mean that we're going to do it, right? And so we're going to have to begin to think about and continue to think about, even when we do have lots of resources, how we deal with the tension between our mission and our margin, right? How much money we think we should make, how much money we think we should spend, and how we think we should take care of people. Okay, that's the first thing. The second one is that when we've generally thought of medical professions as self-regulating, right? One of the things about being a professional is that we set the standards. People don't tell us how we should provide care to the patient before us, right? We do regulate that, and we do have certain parameters. You need a license, right? Why do you need a license or permission and training? So that you're not dangerous, so that you actually take care of somebody, so that you have the requisite knowledge. As we increasingly are thinking about, right, as you increasingly have health insurance coverage, right, for everyone in a country, as you increasingly have the availability of technology, of medications, is the ability to treat people, that also has to be regulated. And how do we think about the relative voice of physicians and the government, right, or health ministries, right? And how do we keep the values of healing and care central in that? A third thing that I want us to keep thinking about in terms of the relevance of this is when I asked you about what the core values would be of a doctor, the kinds of things that came up were things like compassion, right? Respecting autonomy, right? Listening. As we think about that and the human parts of medicine, how does the increasing availability of technology change that, right? Okay. So when we have Dr. GPT, when we can just go to the computer and get the knowledge, right? What does the role of a physician become? Right? How do we keep that compassion and that ability while we also are dealing with increased technology? And then finally, want to bring up this idea that where we started with the talk before about wellness and well-being, right? That we also have to think about the importance of care to ourselves to make sure that we keep ourselves well so that we don't become even more susceptible to our environments or to the pressures or to the things that might let us, even being in a hurry, that might let us not be our very best selves in terms of the work that we do. So I want to introduce you to these principles, because I think that these very ideas are ways that we as physicians, not necessarily the people who are in leadership, the people who are making the laws, the people who are setting up our clinics, the people who are telling us what we need to learn might say, but that there are certain basic skills that we can bring into our conversations that can help us keep an open mind to creating the kinds of environments and spaces that help us keep the virtues and the practices and cultivate the values that we know are most important to the profession. So the first, right, is this idea of not getting ourselves into hot water because we have to be right. Instead, to lead with our humanity. Know that even the seminary students who had studied the Good Samaritan story, right, were prone to err. We're all human, right? If we start there, we can give grace and forgiveness to others, but most importantly to ourselves, right? We are going to make mistakes. How we handle that within a system is going to matter. Bringing in many different voices, making sure, right, that we're considering all opinions in thinking about how we want the world to be. Be thoughtful in the way that we use our words, and not just in our speaking, but also being active listeners, and make sure that we're reflecting on and getting all the information that we can. Bringing forward, all of you led with that when we said, which are the virtues that are really, really important of being a physician? It was about empathy. It was about compassion. It was about care. Let's not lose that. Understand when we're in a situation where we might have a difference of opinion, but it's not a difference of fact, right? So be clear which is which. And then finally, being open-minded and considering alternatives in the way we do our work to be able to have the best outcomes, both the best health outcomes for those who we take care of, but also the best outcomes in terms of our own humanity and the respect for the people who we take care of as their physicians. So with that, I'm going to stop. I think we're moving into a discussion, so have some time for questions. And thank you for bearing with the technical challenges. Did I do okay? Did I say what I was supposed to say even without the slides? Okay, thanks.
Well, for reminding us that we are still human and the error was not really normal. Okay, that's a perfect way to conclude our series of talk for this session. At this time, I would like to kindly invite all of our speakers to come forward and take their seats on the stage for our panel discussion and Q&A session. Please welcome back Dr. Hajung Lee, Dr. Tan Hu Xiu, and Dr. Rebecca Brendel. We now open the floor for question, reflection, or comments. You can raise your hand and our team will assist you with the microphone. So probably one question from the middle. We wait for the next question. Kindly begin introducing yourself before asking your question.
Thank you so much. Hello, my name is Bagas. I'm from Jenderal Sudirman University in Central Java. So I have some remarks. First one is for Hajung. Thank you so much for putting all of those local values and religious in the slides. And I don't have any question. I just want to really appreciate everything that it really makes me and my colleagues felt heard. So thank you so much for putting that on screen. My second remark is for Dr. Brendel. So this is regarding the mental health assessment. So in recent years, we have this discussion on whether or not we should put mental health assessment as one of the selection process that could eliminate the student from being admitted, for example, to medical schools or medical residency training or even scholarship. Of course, there are some dilemma in it. And there are also efforts to actually put students with mental illness as one of the disability entrance level in a way to accommodate them. But in fact, they also face some issues later in their studies regarding the mental health illness itself and also their own struggles within the study. So I would like to know what is the best way to navigate this dilemma in this kind of selection process. And my third remarks is actually for HS. So this is regarding the litigation that you also mentioned. We also have this serious issues on how we can also support healthcare providers when they are facing some legal dispute. So we would like to know how these kind of challenges are faced in Malaysia and how do you usually support this? Thank you so much.
Well, I think, I'll give you the short answer on the mental health piece of it, right? So, given the age that most mental illness begins, right, is roughly for most major mental illness, it's going to start happening around the time that people would be in medical school and medical training, right? So the idea that you might have knowledge beforehand, I think one of the real challenges has been that this is very likely to happen if it's going to happen while somebody's in medical school, right? So you can't prevent all the major mental illness that's going to happen no matter how hard we try. But I think that question is even a little bit besides the point, because really the issue is what we should be thinking about both for physical and mental health concerns is really about competency, right? So do the symptoms that you have impair your ability to practice? Understanding that on the one hand, there are any illness, right, could have a period of impairment and a period where we could function just fine. If you think about major depression, that's probably the most common. You have episodes where you might not be able to function and episodes where one could. So I think an ability framed mindset, right, an accommodations framed mindset that protected both the safety of the physician and the safety of the patient is what has to be at the core of this. And also having a serious conversation about the risk factors in high pressure, high performance professions where there is a burden of care, there can be burnout, about how do we build into our knowledge, attitudes, practices, and competencies, how to build in, right, resilience, how to build in tools, how to learn about talking about the warning signs so that we're not thinking about downstream how we mediate between severe symptoms and patient and physician well-being, but that we're actually building a system that supports well-being and the kind of nurturing and care that's necessary. But it should not be the case that either a physical or a mental illness per se would prevent someone from being a physician per se, right? What we need to think about, it also might be the case that somebody could have any kind of illness that would make it too hard or impractical or make them unable to practice. But within that, there is a huge range of what we could do, especially because we know the mental health burden of practice has gotten so much higher that we can build in the kinds of systems, the kinds of skills, attitudes, and competencies that was suggested in that final slide, so that across the spectrum, we would just expect that we're going to have these stresses. We just expect that many of us, just like other professionals, will have struggles, not just with mental health, with physical health. And then we can create a system that allows physicians to flourish, but also supports the safety and care of patients.
Okay, thank you.
Next to Dr. Tan, probably.
Yeah. So the one thing that we are having in Malaysia is where, there are many hospitals now. We have we call medical legal units, and basically they deal with risk management, legal risk management. So they deal with where there are complaints, and they will send in the internal inquiries and also external inquiries, just to kind of investigate and try and mediate between families and patients and doctors. So the question about how do we look into ethics, trying to solve some of the risks that we have in legal matters. I would say simple wise, it's just 3 words, is to get good lawyers, get better lawyers. I think that is the one solution we try my personal best to actually put it out there. Yeah. And I think it is wrong, such as how, the question that you had for Dr. Brandel about we are trying to prepare our doctors to be able to face what comes in medical practice. which can be very challenging and harsh. And we want to try and make sure that they don't break down. We try and teach them, to be resilient. And I think it is the same thing where, when you ask doctors to try and take the steps not to get into trouble in the courts, and it may not be the right thing to do, because I think the one thing that we need is the best lawyers that you could to actually defend us in the courts, and so that the doctors doesn't need to be distracted and they can just go back to do what is right, And I think the courts, most of the time, I think when it comes to taking the right decisions and making decisions that what they think is in the best interest of the patient, I think most of the time, I think the court do understand, but it depends on how the lawyers are going to frame it and trying to get doctors to lose out in that legal battle, but it doesn't really define whether they are a good doctor or not and whether they have done the right thing. And we have it has been quite a messy place in Malaysia because of that. And we have had even close friends, just talking to me, and she would say, I've been seeing my gynecologist, and, I've been knowing her for past 18 years, and she's not been looking at me anymore because she'll be looking at the computer and trying to document everything. So that takes away, the real thing about, the personal connection. And also, the one thing that we have actually teaching students about to build connection and relationship, and so the connection with our patients, that it was actually really being taken away by this part of risk and the fear of it, which can be unwarranted and which can be just a fear rather than a reality. So I would always say, that the guidelines or, the code of conduct or, professionalism is always there. It's just there. It's been there, Maybe the systems works in a way that we are not able to comply or obey, like what Dr. Brundle has said, the systems are, and the conditions are not, is just make us choose between ourselves and our patients, interests. But in the end of the day, I think it is there. We know it. We don't need the lawyers to tell us what to do. So I think ethics wise is where we are trying to balance that nowadays. Yeah. To try and say, you have a system problem, you have problems in the clinical practice and care. We are here to actually support. And most of the cases that we have engaged at this point has come out quite okay. There are no legal consequences or anything else. And I think many of the doctors just want that someone to actually give the green light or even enable them to do what is right. Because they tend to get caught with the legal risk of some of the actions that they thought should be the right thing for their patients, but legally was not right. That includes things like not disclosing an error, at the right time, coming in with compassion, coming in with empathy, and they shy away and they tend to get swayed that they are not supposed to handle those cases and not supposed to say sorry. And, and that makes things worse actually at the end of the day. So that's just one example. Thanks. Okay.
For Ms. Harjung, do you have any remarks for No? Okay.
Thank you so much for your kind remarks.
So we begin with another question. Okay. Go ahead, sir.
Good morning. I'm Manopu from the Indonesian Bioethics Forum. I would like to address my question to Dr. Brendel, Dr. Lee, and Dr. Tan. To what extent we could figure out and fix the ethical conflict between one another in the four ethical principles, among these four principles? Thank you.
When I was speaking about ethical and social responsibilities, I faced this ethical dilemma. Like, I didn't mention of it during my session, but I heard that residents are not paid during the training in Indonesia, or So when we try to put like governmental money or tax money or like anything subsidy and for medical training and education and pay properly for the trainees like residents and fellows, like when they get properly paid, then probably we'll ask more ethical and social responsibilities. So when they don't get paid well and when they struggle to live out their lives financially, hard time with family, for example, then I'm not sure how much we can like ask them social responsibilities, especially during the training time. Maybe like after their lives gets stabilized financially, they can get involved. But I mean, time-wise and like financial-wise, I think we should pay them properly, and then they can have they can think of their like ethical and social responsibilities. I mean, it's not not only about the monetary financial issues involved, but like, I mean, as a doctor or as a human being, we can think of ethical and social responsibilities, but I think we should pay properly. Then we may ask like doctors to do like more of this work and advocacy. So I felt that was like ethical dilemma, and especially like Dr. Brenda was talking about the conditions and medical students' mental health conditions when they go through all this. Like probably it's too much to ask around that time. But I mean, systematically, I think we need to like think and change the training system and payment, and like let's take care of mental health. Like when doctors are not taken care of, like how can we offer any good service so it can be collapsed? So I think we need to really think bigger change in our healthcare system and education. Principal.
Okay, so I think, let me just say a little more broadly the idea of the four principles and what we do with them, because I think Dr. Lee's just given us a really good example of some of the places where there's both a responsibility to be able to take care of one's self and one's training, and also responsibilities to others, and how do you balance between them? So really, when we're talking about the four principles, each of them would be fine on their own. It would tell you the right thing to do, except when they come into tension or conflict with each other. So sometimes we have to balance between the patient who says, don't do this to me, right? And in mental health, we have to do this, but knowing that delivering an intervention could save a life. And so we think it's the right thing to do anyway, right? We have to balance between the autonomy and the beneficence, right? The reason I bring that up is because that's exactly what makes ethics hard. If ethics is the study of how to make hard decisions in the face of competing values, right? We have to make a hard decision there. And so we talk about that in terms of moral residue, right? When we have to make a decision between two principles, but we cannot be faithful 100% to both of them, then we try to do things to lessen the impact of the one that we couldn't be faithful to. Does that make sense? So, and learning about when we can't be faithful to all the principles at the same time can help us develop the kinds of skills and the kinds of moral discernment to be able to continue to make better decisions going forward, or to mitigate the moral effects of not being able to do that. So the example I often use is if I have a patient who's going to harm themselves or someone else because they're really quite psychotic, they're mentally ill, they're not thinking clearly. Their autonomy might say, their decision might be, don't give me the medicine. But I know that treating the person would mean they could go back to live with their family. They could go back to work. They could have all the relationships and the things that matter to them the most and not be dangerous. But it still gives us pause that we did the wrong thing anytime we don't listen to the patient, even though on balance, we know that we did the right thing. So I bring that up just to say, we could ask the patient, if you had to take medicine, what would it be, right? If you had to go for treatment, what are some of your thoughts and values about this? But it's really about what we do when we can't be faithful to all four principles in the balancing amongst them.
There any more question probably? Okay, one from the ladies from the front.
Thank you. My name is Zahwa. I'm from Indonesian Defense University. I would like to seek your opinion as the experts. Dr. Lee mentioned before about the important value of bioethics, which are empathy and compassion. I am currently studying about the empathy and the compassion and medical students. In your opinion, how can these two concepts can be unifying into single concept or single terms, or perhaps is there any broader framework itself that can encompasses these two concepts, because we know that these two concept has a different psychometric tools itself. Thank you.
Dr. Tan, probably.
Asking about the compassion. Can you repeat the question? Is it right about the tool, about how to about the compassion, how to
I'm sorry, I mean that is there any broader framework that can encompasses these two concepts, empathy and compassion?
Oh, empathy and compassion together. I think from like Western tradition, and we talk about like empathy a lot, compassion and empathy. They're like a little bit different nuances involved, and like empathy and compassion, like when we talk about like compassion, actually compassion is very universal kind of term, especially from religious studies point of view. Like almost every religion has concept of compassion, and people feel compassion in like many different like religious or belief system. So compassion can be very much universal language that we can feel towards like medical students, residents, patients, like human beings, or like, you know, anyone. So I think like compassion, it can be used for like any of our ethical practice, actually, not only like, you know, bioethics, medical ethics, but when we like work for health advocacy, like we like act out of compassion potentially, right? Like maybe not necessarily with empathy, but like in medical setting, especially in clinical ethics on the hospital floor, when we talk to patients and patients' families one-on-one, like we emphasize on empathy, but I'm not sure how those can put them together, but at least what I can say is like, you know, compassion can be used a lot, and that has been like a missing piece in Western tradition, but like in non-Western tradition, we talk about actually compassion a lot, especially like Buddhism or any human acts. We try to be kind out of compassion. And I think it should be highlighted like virtue in medical practice universally.
Dr. Brendel or Dr. San probably? There.
Um, I think it's part of the ethics of care as well that comes into one of the framework nowadays that at times that your principals doesn't feel into what the patient wants, respect for his wishes, or what do you think would be best for the patient. So I think there was one essay that was written by our MBA program student also, and about a demented patient, then that he was like, a professor, he has wanted, if possible, that he would want to prolong his life. I cannot remember the details, but then he got demented. It's not himself anymore. And at times when you look at the person, you think about the person, not only what is best for him, because he was starting to pull out his rice tube, his NG tube, and he's not eating. And I think overall at that point, I think if you are going to be the provider, okay, you look at the person and you think about his whole life, he has been, of great contribution his whole life. And, and you think about him as a teacher, so that's where, sometimes our decisions is based on compassion also as well of like, trying to maintain his dignity at the end of life, So even though it may go against what he has previously wished for or what we think is best for him, but overall as him, as a person, we put in that compassion there to think, what is, would be appropriate for her or him. And I think that's it. Sometimes, you get a bit too much of compassion that you get burned out as well. That's the other end. But of course, when it comes to empathy, to put ourselves in others' shoes, right? It should be part of one of the components of compassion. Am I right? Yeah. Yeah. And I think, it works in, I think, not only decision making, but also part of microethics, I think, in terms of knowing what to say, knowing how are we going to frame our words, how are we going to interact with each other, what are things that we should say, whether we are withholding some information, or, out of compassion, so sometimes there are also actions that we take along that lines of putting ourselves in that person's shoes and trying to make sure that we don't harm them more by saying things that may make them go into high emotional distress and whatnot. So we may sometimes we don't do the whole full truth telling and whatnot because of that reason. So I think putting oneself in another shoes would be part of that compassion as well. But I'm not sure whether we answered your question or I answered your question well enough. Okay.
Dr. Brenner, probably. Okay, it's a very hard question. Okay, so what was it? Compassion. Got a really good question. Okay, the last one probably from the back, Nurse Rika, probably.
Well, thank you so much for inspiring talk. And I'm so interested, especially with the part of mental health and well-being. I'm Rika. I'm mental health nursing lecturer, and I have witnessed many students experiencing significant mental stress, especially during clinical rotation. So it can be like academic stress or even clinical demands. And especially if they also limited support. So from your perspective, how can health educators like us ethically integrated mental health support into the curriculum or clinical supervision while maintaining academic integrity and professional standards? Thank you.
That was a beautiful way of summing up all the complexity of doing what was on the slide, right? So, one reason I think we've moved from mental health to wellness is the idea that we all have an ethical responsibility in promoting the kinds of environments that allow us all to function and flourish and perform our tasks. Now, I think we're not going to have great success if we say we shouldn't evaluate medical students or we shouldn't evaluate their performance, because once they're no longer students and they graduate and they have we have satisfactory performance as students, then we become physicians and we're responsible increasingly for taking care of patients. So it's really a balance about what are the necessary stressors of the training process, and how can we also build in tools and resilience so that they don't become overwhelming. And there's this other piece of it, right? So if we know, for example, that getting data about it and really studying can also help us, where are students having fewer problems, where are students having more problems, right? So working over 100 hours a week is clearly one of the places where people are having more trouble. That's probably also unrealistic. Like if we look at the whole system, maybe it needs to happen in a crisis, but we need to be having realistic expectations for our systems down the line, that we have enough healthcare providers that we're not doing that. The longer answer says we need to be thinking about what each member of a healthcare team is doing, who really needs to be doing it. How do we extend the ability of a single physician to meet the health needs of a large population? But the fundamental pieces of this are to understand what sets it up, and try to figure out what the different alternatives are for meeting the objectives and the needs, say in medical education or in residency training, while also being very, very aware and transparent that we know that by the end, everybody struggles to some degree or another, more or less, and building that also into the expectations of discernment and professional development over the course of a career. Because it turns out that talking about it and making it okay to talk about, not like I can't do my test today, I can't see a patient, I need a medical school experience without evaluation. Nobody's saying that, because that's unrealistic. But how we develop the sort of the attitudes, behaviors, and skill and thoughts, beliefs, and skills to get through that is, I think, really what we're talking about capacity building, skills building, and support.
That will be our last question. So thank you very much for all our speakers, Dr. Hajung Lee, Dr. Tan Hui Siu, and Dr. Rebecca Brandel, for your inspiring presentation and thoughtful insight. We hope the ideas we shared today will continue to spark reflection, dialogue, and collaboration. With that, we officially close this session. Please enjoy the rest of the symposium. Terima kasih, and see you in the next session. Thank you very much.
Our symposiums, and we will now have a break times for prayers and also lunch. For your information, especially for Muslim participants, sekali lagi kami sampaikan kepada seluruh peserta yang masih berada di ruangan untuk berkenan memasuki ruangan, karena beberapa saat lagi acara akan kita mulai. Terima kasih. Well, good afternoon, ladies and gentlemen. Welcome back to the afternoon sessions of the International Bioethics Symposium and Workshop 2025, organized by the Faculty of Medicine's Universitas Diponegoro in collaborations with the Center for Bioethics, Harvard Medical Schools. In a few moments, we will begin the second plenary sessions with topic Aligning Education and Policy for Ethical and Equitable Health Services from our speakers. The moderator of this session is Dr. Rizky Murdito Budi, MSc Fodont, PhD from Universitas Diponegoro. Ladies and gentlemen, Dr. Rizky earned his degree in dental surgery from Universitas Airlangga in 2016, followed by a master degree in forensic odontology from Catholic University of Leuven, Belgium in 2018. He completed his PhD in forensic odontology from the University of Dundee in 2023. Dr. Rizky is currently a faculty member at the Department of Dentistry, Universitas Diponegoro. Ladies and gentlemen, please welcome Dr. Rizky.
Yes. Okay, good afternoon, everyone. I don't know, should we speak in English? Don't think so, yeah? Do you want me to speak in English or Indonesian? Kind of mixed bag, but kita bicara bahasa Indonesia aja. Selamat siang, rekan-rekan semua, Prof, Dokter, rekan-rekan yang berbahagia. Pada sesi kedua kali ini kita akan berbicara tentang aligning education and policy for ethical and equitable health services. Untuk pembicara pertama kita ada Prof. Tri Nur Kristina dari Fakultas Kedokteran Universitas Diponegoro. Beliau akan membacakan dan mempresentasikan tentang Bioethics Implementation and Challenges in Medical School from Undergraduate to Residency Students. Prof. Tri adalah profesor dalam bidang medical education yang secara aktif berkontribusi di bidang interprofessional education dan perkembangan kurikulum community-based learning di Fakultas Kedokteran Universitas Diponegoro. Prof. Tri menyelesaikan dan mendapatkan medical degree dari Universitas Diponegoro, Master of Science, Magister Kesehatan di Universitas Gajah Mada, dan dilanjutkan oleh doktoral di bidang medical education. Oke, sorry for the interruption. Dengan pengalaman global, jadi Prof. Tri bekerja saat terutama saat COVID-19 ya Prof ya. COVID-19 untuk melakukan pionir dalam interprofessional education virtual dan mempromosikan hal-hal pedagogik yang luar biasa untuk menunjang pendidikan di Fakultas Kedokteran Universitas Diponegoro. Tanpa berlama-lama, mari kita sambut Profesor Tri Nur Kristina. Round of applause.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Terima kasih pada panitia telah mengundang saya untuk sharing tentang implementasi bioetik di kurikulum Fakultas Kedokteran UNDIP. Mudah-mudahan ini menjadi suatu pembelajaran dan mungkin awareness kita mungkin masih lemah di sana sini ya. Jadi saya sangat sangat yakin yang namanya kurikulum itu nggak pernah sempurna. Jadi sambil berjalan, sambil kita lihat setiap saat, kemudian kita perbaiki. Termasuk juga bagaimana bioetik ini masuk di dalam kurikulum pembelajaran anak-anak kita. Ya, ini adalah basis konsepnya dari medical ethics ya. Jadi di sini memang medical ethics merupakan obligasi ya dari semua para provider health profession ya. Jadi di sini untuk memastikan bahwa pasien itu mendapatkan respect ketika dia sakit, proses dalam decision making sehingga apapun keluarannya itu ada kepuasan baik dari pasien maupun keluarganya. Jadi di sini diaplikasikan pada semua healthcare provider sebagai konsep yang dinamis, yang bervariasi dalam berbagai society, kemudian juga tidak memandang agama maupun budaya. Mungkin tadi pagi sudah diberikan ya fundamental dari bioetik, ada 4, yaitu beneficence, normal efisiensi, autonomy, dan justice. Ya, jadi di sini untuk nomor 1 adalah the duty to do good, ya, untuk selalu melakukan hal yang baik gitu ya. Kemudian untuk yang nomor 2, the duty to not do bad. Jadi ini benar-benar suatu filosofi yang harus nancep betul ya di kalangan health provider, nggak cuma dokter saja tapi juga perawat ataupun health provider lain. Kemudian otonomi yaitu merespek ya, kita menghargai hak-hak dari pasien untuk bisa menentukan apa yang terbaik bagi dirinya gitu ya. Saya kira ini semua sebetulnya kita sebagai dokter tahu semua ya tentang hal ini ya. Kemudian justice ya, untuk memperlakukan setiap pasien secara adil dan tidak membeda-bedakan apakah itu agamanya beda dengan kita ataupun bangsanya beda ataupun suku bangsanya berbeda dan sebagainya ya. Sebetulnya yang nomor 1 dan nomor 2 itu selaras ya dengan Hippocrates ya, yaitu to help and do no harm ya. Mengapa kita harus mengajarkan ini ya? Jadi di sini karena sangat berkontribusi terhadap caring dari pasien kita ya, bioetik ini ya. Kemudian juga di sini untuk meningkatkan kualitas dari patient care dalam tidak hanya outcome-nya tapi juga prosesnya ya. Jadi ketika kita mengimplementasikan bioetik ya dengan baik, itu tidak hanya untuk outcome-nya saja yang baik tapi prosesnya itu sendiri juga baik juga. Sehingga di sini pasien itu akan lebih terproteksi ya. Dan di sini untuk decision tidak hanya untuk etik saja, tetapi kita lihat prosesnya juga ya. Jadi di sini untuk skill dari ethical analysis sebagai bagian dari kompetensi seorang dokter sangat penting ya untuk melengkapi aspek etik ini ketika menerapkan clinical medicine. Bagaimana mengembangkannya? Ya, jadi di sini untuk etika ini meliputi berbagai multifaset approach ya, yang mengkombinasikan teori dengan praktis. Experiential learning yang biasanya dialami oleh mahasiswa kita yang sudah masuk di profesi ya. Jadi itu belajar tidak hanya pasien yang di karang-karang ya, ataupun yang kita buat dalam kasus-kasus, tetapi benar-benar the real patient. Jadi ini ketika mahasiswa kita sudah masuk di profesi, itu udah bisa kita bilang sebagai experiential learning dan juga reflektif praktis. Jadi apa yang dihadapi pasien tersebut kemudian juga direfleksikan apakah kita sudah menerapkan bioetik dengan baik pada pasien ini. Jadi sangat krusial untuk mengintegrasikan etik ini selama pembelajaran atau selama kurikulum di kedokteran. Ya, jadi terintegrasi, tidak sendiri-sendiri. Kalau udah diajarin bioetik di semester 1 ya wis itu. Ya, suruh menerapkan sendiri, tetapi sudah harus didesain. Oleh karena itu saya sangat senang nanti jam 4 akan diundang untuk merefleksikan apa yang telah kita lakukan, sehingga kita harus honestly ya, saya sendiri merasa bahwa mungkin bioetik yang kita kita lakukan belum memuaskan, sehingga dengan adanya diskusi nanti jam 4 sore itu mudah-mudahan membuka mata kita untuk lebih baik lagi. Ya, jadi di sini Ya, jadi idealnya adalah untuk mengembangkan pengertian tentang medical ethic ini adalah dengan praktis menganalisis situasi yang dengan menggunakan kerangka dari etik dan juga ideologi. Saat ini memang sebagian besar medical ethics itu diajarkan sebagai pembelajaran yang terpisah di preklinik begitu ya. Jadi di sini bisa juga menggunakan case study dan di mana juga menerapkan prinsipal sebagai metodologinya. Nah, padahal ya seharusnya learning objektifnya itu harus lebih diluaskan dan juga diset sesuai kebutuhan. Jadi contoh yang pasti diberikan memang di semester 1, tetapi ketika mahasiswa itu sudah belajar di semester-semester berikutnya, banyak sekali hal-hal yang dia pelajari yang menyangkut bioetika ini, sehingga harus diintegrasikan di dalam, kalau kita memiliki istilahnya modul atau blok ya, di dalam blok-blok. Dan sifatnya juga longitudinal ya. Jadi di sini diharapkan supaya ada perubahan ya yang menetap dalam hal bagaimana dia menerapkan reasoning dalam menerapkan bioetika ya, dan juga akhirnya akan menjadi behaviornya atau perilakunya sehari-hari. Ya, jadi di sini sebaiknya tidak hanya di preclinical years, tapi terus-menerus, bahkan sampai dia lulus dokter, bahkan nanti kalau dia nanti ngambil residensi pun bioetik bukan berarti ditinggalkan ya, tetapi justru digunakan terus-menerus. Saya boleh minum ya? Minum sih ya. Ya, siapa yang harus mengajarkannya? Ya, tentu saja sebagian besar ya Pak Dokter, Bu Dokter gitu ya, yang memang sehari-harinya bergaul dengan pasien gitu ya. Dia menjadi role model dari anak-anak kita, bagaimana dia menerapkan bioetik dalam pekerjaan sehari-hari. Idealnya ya seperti itu ya. Jadi tidak teoritis, tetapi kita harapkan orang yang memang menerapkannya dalam pekerjaannya sehari-hari gitu ya. Nah, sekarang kita refleksi diri dengan dengan experience kita di UNDIP ini. Jadi saya tidak bisa bilang bahwa UNDIP udah menerapkan dengan baik. Enggak. Saya merasa masih kurang gitu ya. Justru yang saya bilang tadi ya, nanti jam 4 sore itu kita nanti akan refleksi diri, apakah kita sudah menerapkannya cukup atau masih kurang gitu ya. Ya, jadi di sini UNDIP memang mengintegrasikan kurikulum karena kita menerapkan SPICES ya, student learning dan seterusnya itu ya. Yang pasti yang kita ajarkan itu enggak langsung susah begitu, tapi dibuat yang sesederhana mungkin, dari simple ke kompleks ya, kemudian juga dari mudah ke sulit. Selanjutnya juga tidak langsung yang patologis tetapi fisiologis dulu baru ke patologis. Beberapa fakultas kedokteran yang pernah mengundang saya itu pada bingung juga ya, karena tidak paham dengan istilah integrasi itu, early clinical exposure itu seperti apa. Sehingga mahasiswa semester 2 ya ketika belajar muskuloskeletal begitu itu bukan belajar bagaimana bergeraknya sistem tubuh tersebut, tetapi diajarin sampai ke kasus bedah gitu ya. Jadi dokter bedah udah ngajar dari A sampai Z sampai penata laksanaan ya. Nah, waduh ini ya. Jadi integrasinya itu kebablasan gitu ya. Jadi di sini yang dimaksud dengan early clinical exposure untuk mahasiswa yang masih awal itu ya diberikan itu sedikit saja, terutama untuk supaya menarik Karena kalau ngajarin ini untuk gerakan ini, untuk gerakan itu, tapi tidak ada sedikit sentuhan dari klinik, memang kurang menarik jadinya. Jadi early clinical exposure untuk mahasiswa tingkat awal itu bukan sampai ke penata laksanaan, tetapi lebih ke why this happen. Ya, mengapa ini terjadi gitu. Ya, seharusnya seperti apa. Kemudian juga kita menerapkan spiral kurikulum ya. Jadi spiral kurikulum itu kan kalau lihat bentuknya Bapak Ibu tentu tahu ya. Jadi kita misalnya prinsipnya adalah memberikan topik yang sama selama dia belajar, tetapi semakin dalam, semakin luas, begitu ya, semakin kompleks. Contoh misalnya mahasiswa diajarin metabolisme glukosa di semester 2 misalnya ya, di mana dominasinya adalah faal dan biokimia gitu. Nah, nanti di semester 4 atau semester 3 itu belajar diabetes misalnya ya. Bagaimana seorang yang terkena diabetes, apa saja pemeriksaan yang perlu dilakukan, obat yang standar perlu diketahui apa. Nah, nanti mungkin semester yang sudah mendekati lulus itu sudah komplikasi orang yang diabetes. Jadi semakin sulit begitu. Nah, itu adalah prinsip dari suatu spiral kurikulum. Jadi kalau udah diajarkan itu bukan berarti terus ditinggalkan begitu saja. Artinya apa? Mahasiswa itu yang namanya anatomi nggak boleh lupa begitu. At least patogenesis dari suatu penyakit dia nggak boleh lupa basic science-nya. Kira-kira itu prinsip dari spiral kurikulum yang kita terapkan ya. Nah, bagaimana mengajarkan bioetik? Ya, jadi di sini memang di-reinforce di dalam kelas dan juga di dalam diskusi-diskusi. Dalam hal ini adalah diskusi tutorial. Jadi teman-teman dari tim bioetik ini yang mendeteksi sendiri akan mengajar terutama memang di blebeke di semester 1, tetapi bila mana perlu modul-modul berikutnya pun bisa diajarkan juga yang penting tentang bioetik ini. Tetapi yang sangat banyak adalah memasukkannya aspek bioetik itu pada problem based learning. Di mana kasus itu membutuhkan aspek bioetik, maka harus dibuat sasbelnya atau learning objektifnya, gitu kira-kira gitu, supaya mahasiswa mendiskusikannya dan untuk si tutor juga tahu bahwa aspek ini sudah didiskusikan atau belum, gitu ya. Jadi di sini medical ethic diajari selama kurikulum dengan berbagai metode pembelajaran. Pada preklinik ya di sini terutama lecture juga ya untuk fundamental dari pengetahuan tentang etik dan juga ada task based learningnya. Jadi dikasih tugas-tugas yang terkait dengan bioetik. Tentu seperti yang tadi ya prinsip dari mudah ke sulit ya dari simpel ke kompleks itu diterapkan juga untuk aspek bioetik ini. Kemudian juga di sini pada praktikum anatomi begitu juga ya respect terhadap kadaver misalnya itu juga tentu adalah salah satu aspek dari bioetik ya. Kemudian di dalam PBL diterapkan di beberapa blok meskipun tidak semuanya, ini hanya sekedar contoh saja ya. Ketika di semester 1 misalnya ya blok 1 itu adalah professional development. Jadi di sini kita bikin kasus di mana mahasiswa mengupload video dengan kadaver di medsos misalnya begitu. Mahasiswa diminta untuk mendiskusikannya, kemudian dari aspek bioetiknya seperti apa. Kemudian beberapa blok yang terlibat antara lain maternal and child healthcare, aging, emergency dan beberapa blok atau modul yang lain. Selanjutnya juga di skill lab ya. Di skill lab kan memang akan embedded dengan pembelajaran communication skill-nya gitu ya. Jadi penerapkan aspek bioetiknya itu juga di embeddedkan dengan communication skill ya. Dan tidak lupa di dalam interprofessional education di semester 6 aspek bioetik ini juga kita terapkan. Jadi dengan menerapkan do good no harm itu makanya kita memilih mahasiswa yang sudah cukup bekalnya gitu ya, supaya tidak dirugikan nanti keluarga yang didatangi untuk sebagai pembelajaran IPE ini. Di mana IPE ini tidak hanya melibatkan fakultas prodi kedokteran, tapi juga kedokteran gigi, keperawatan, gizi, dan juga adik-adik dari farmasi. Nah, ini adalah contoh bioetik pada kasus-kasus PBL yang kita insertkan di dalam sasbelnya atau learning objektifnya. Nah, bagaimana di clinical year ya, di ketika koskap ya, jadi di sini sudah menerapkan experiences learning ya dengan pasien nyata ya. Jadi di sini dokter DPJP itu berperilaku seadanya, dan dia harus tahu bahwa dia menjadi role model untuk masalah behavior maupun bagaimana menerapkan bioetik ya, sehingga di sini mahasiswa bisa mengamati dan insya Allah bisa akan berperilaku yang sama pula. Nah, tentu saja juga dalam hal penugasan ya, task based learningnya misalnya case based discussion, di mana mahasiswa mencari kasus yang menarik, dan aspek bioetiknya juga tentu harus dilaporkan dan didiskusikan. Tidak hanya penyakitnya apa, diagnosisnya apa, penata laksananya apa, tetapi juga proses tentang ethical issue ini juga didiskusikan. Yang terakhir adalah di comprehensive collective. Jadi ketika mahasiswa sudah lulus semua kepaniteraan klinik, nilainya bagus, kemudian dites dengan OSCE, oke, lulus, baru dia boleh ke kompre. Istilahnya mahasiswa itu kompre. Kalau kami sebetulnya singkatannya adalah pansip atau kepanitraan komprehensif. Nah, jadi di sini tentu ketika dia sudah kompre, mahasiswa itu udah lebih independen, karena memang kita melatih independensi. Jadi mahasiswa itu ketika kita postingkan di puskesmas ataupun di rumah sakit tipe C atau D, itu udah kayak Pak Dokter, Bu Dokter kecil gitu ya, bukan kecil deh, muda gitu ya. Jadi kalau kecil nanti UKS lagi ya. Nah, jadi di sini mereka sudah memiliki tanggung jawab, meskipun tetap di bawah supervisi, tapi kalau dalam kenyataannya tuh wis percaya banget ya, apalagi lulusan UNDIP begitu ya, anak-anak UNDIP itu udah dilepas begitu aja ya. Yang saya tanya, kamu kalau di puskesmas ini sehari jaga di UGD dapat pasien berapa? 30-an. Waduh, alhamdulillah. Capek tapi senang gitu ya. Jadi jauh lebih banyak pengalaman yang dia dapatkan ketika kompre ini dibanding ketika dia kepanitraan klinik. Ya, ini contoh ya, comprehensive collective di primary care. Ya, apa sih challenge kita ya? Jadi di sini memang kita harusnya mengevaluasi sampai ke mikrokurikulum. Sejauh mana sih bioetik kita ini benar-benar sudah diimplementasikan gitu ya. Seperti apa sih pemetaan yang telah dilakukan oleh teman-teman tim bioetik ini terhadap kurikulum kita, masuk ke blok apa saja, itu memang perlu kita lakukan evaluasi. Dan selama ini tampaknya nih mudah-mudahan Bu Dita udah pulang, sudah lulus gitu ya, insya Allah nanti bisa melakukan evaluasi mikrokurikulumnya. Kalau makrokurikulum pengen saya kebuntat gitu ya, tapi kalau yang mikrokurikulum tuh tampaknya perlu banget itu. Ya, kemudian tentu saja bisa untuk penelitian selanjutnya, apakah memang ada impact dari learning kita itu terhadap nantinya kualitas dari patient care-nya. Sebagai kesimpulan, sebetulnya di sini banyak sekali yang bisa kita lakukan, yang bisa berbasis bukti dengan melakukan banyak penelitian tentang bagaimana sih kalau kita sudah menerapkan bioetik dengan baik itu paling dekat adalah kepuasan dari mahasiswa. Refleksi dirinya mahasiswa itu semakin meningkat atau tidak. Baru selanjutnya ke arah outcome dari pasiennya. gitu. Jadi ini mungkin teman-teman dari bioetik bisa banyak melakukan penelitian dan mudah-mudahan bisa jadi guru besar dalam bidang bioetik. Bismillah, alhamdulillah gitu ya. Nah itu ini yang saya sarankan. Jadi meskipun tentang bioetik tapi juga dikaitkan dengan pendidikan karena itu memang tidak lepas. Saya kira ini yang bisa saya sharingkan pada Bapak Ibu sekalian. Mudah-mudahan bisa membuka wacana kita tentang bagaimana seharusnya yang mengimplementasikan bioetik ya dengan baik. Saya yakin yang di UNDIP ini belum terlalu baik, tetapi mudah-mudahan ada pertanyaan sehingga dari pertanyaan itu nanti kita bisa iya ya, oh iya ya harusnya gini, harusnya begitu. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Terima kasih, Prof. Tri. Berbeda dengan sesi sebelumnya, kalau sesi ini kita langsung tanya jawab saja. Mungkin dari rekan-rekan di ruangan ada pertanyaan, silahkan. Boleh minta tolong mic-nya?
Yes. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Terima kasih banyak paparannya Prof. Tri, sangat membuka wawasan bagi kami karena kami juga sebagai pengajar di Fakultas Kedokteran Universitas Jenderal Ahmad Yani yang kebetulan sama-sama juga mulai mengembangkan kurikulum bioetik dari tahun 2015 waktu itu. Cuman di sini yang mungkin kami minta sharing dari Prof. Tadi saya lihat bukan hanya pada tahap preklinik gitu. Di sini kami masih kesulitan, terutama adalah untuk bisa memasukkan perbagian nih, gitu ya. Di kurikulum kami, kebetulan kami adalah di forensik, jadi kami masukkan ada materi tentang bioethics di kurikulum kepaniteraan forensik. Tapi yang kami kesulitan adalah gimana nih buat masukin di departemen yang lain gitu. Ketika kita mau menjaga gitu ya, tadi udah spiral kurikulum, di S1-nya udah bagus gitu, tapi ketika di koas tiba-tiba mungkin bisa hilang gitu. Padahal kita menginginkan kan itu juga bisa mereka terapkan keilmuan yang mereka dapatkan gitu, baik secara teori yang ininya bisa dipraktekkan gitu kan. Sama satu lagi pertanyaan saya, mungkin Prof bisa sharing terkait penerapan IPE gitu ya. Tadi saya lihat di semester 6 untuk diterapkan IPE-nya, mungkin bisa sharing jadi kami juga bisa belajar dari pengalaman dari UNDIP. Terima kasih. Assalamualaikum.
Waalaikumsalam. Ya, terima kasih pertanyaannya Ibu dari Ahmad Yani. Di Ahmad Yani itu Bu Weli ya? Bu Weli juga ya? Salam ya nanti ya. Ya, jadi untuk yang di kepanitraan, memang kita jangan terlalu berharap bahwa kita bisa memberikan kuliah, begitu ya. Jadi yang bisa kita berikan adalah learning objektif. Sasaran belajarnya bila perlu ada modulnya tentang bioetiknya, seperti itu. Sehingga mahasiswa itu kan jangan kita harapkan untuk kita dulang terus gitu, tapi dia menerapkan. Makanya ketika sudah di kepanitraan itu saya tuliskan di situ tadi experiential learning begitu ya. Jadi benar-benar dari pengalaman. Nah, yang tidak kalah pentingnya adalah role model sebetulnya. Apakah dokter-dokter misalnya di bagian kebidanan misalnya, apakah dia menerapkan aspek bioetik ini begitu. Nah, itu tentu saja kita bukan pengen ngajari mereka, tapi mungkin mereka malah lebih bagus menerapkan bioetiknya dibanding kita yang latar belakang pendidikannya tidak spesifik seperti yang di bagian kebidanan seperti itu. Jelas mereka akan tahu saya harus menerapkan aspek bioetik untuk kasus ini seperti apa. Nah, untuk itu supaya tidak lupa ya learning objektif, titip learning objektif saja. Nah, itu untuk untuk supaya mahasiswa itu juga menerapkan. Kan biasa ya kalau nggak di LO kan ya lali wes ngono ya. Nah, untuk itu di dalam penugasan misalnya untuk case based discussion. Nah, kita bisa bikin checklist apa saja yang dia harus presentasikan, termasuk jangan lupa aspek etik apa yang ada pada kasus yang saudara presentasikan, begitu. Nah, diskusikanlah di sini dengan mungkin paling tidak dari 4 aspek yang tadi, misalnya begitu. Kira-kira gitu ya, Bu ya. Yang itu adalah jalan termudah yang Bismillah kita lakukan dengan tentu saja yang penting adalah komunikasi. Jadi sering-seringlah bikin apa ya istilahnya ya, evaluasi kurikulum itu kan berarti kan evaluasi kurikulum untuk prodi profesi dokter. Nah, kan berarti kan mengundang seluruh ketua bagian dari itu. Nah, itu kita bisa masuk di situ. Sama seperti yang telah dilakukan di preklinik. Masuknya lewat skill lab dan juga lewat PBL gitu. Jadi tidak hanya dibelebeki tentang bioetik di semester 1. Iya, itu di situ memang benar-benar karena fondasi ya di situ. Tapi yang penting kan penerapannya lagi begitu. Meskipun itu secara teori. Pertanyaan yang kedua. Untuk EPE, jadi di sini kalau dipikirkan nomor 1 adalah do good dan do not do harm, kan begitu ya. Nah, oleh karena itu filosofi dari IPE itu saya sebetulnya mengambil dari itu. Mengapa? Karena jangan sampai masyarakat yang didatangi oleh para mahasiswa ini, apalagi dari berbagai profesi ini, untuk mahasiswa yang masih kurang sangunya begitu. Makanya kita ngambil kenapa di semester 6. Yang pertama karena kami lakukan dulu matching kurikulum. Kapan mahasiswa itu bisa kita barengkan di komunitas. Nah, pada waktu itu alhamdulillah 3 prodi bisa, yaitu prodi kedokteran, keperawatan dan gizi di semester 6. Itu benar-benar kami lakukan matching kurikulum dulu. Itu nomor 1. Selanjutnya Gigi pingin bagaimana kalau semester 6 bisa enggak? Ternyata butuh waktu ya, dari teman-teman dari Gigi itu butuh waktu bagaimana supaya bisa dipaskan di semester 6 karena kita sudah berjalan begitu. Nah, alhamdulillah sekarang sudah 2 kali ya. Sudah 2 kali ini. Nah, kalau untuk Gigi dan farmasi itu sudah 2 kali ini dan jumlah adik-adik di Gigi dan farmasi itu kan enggak banyak ya. Jadi nanti di dalam pembagian kelompoknya itu kedokteran karena paling banyak itu dalam satu kelompok bisa 2, nanti nurse-nya 2 kan nurse juga banyak, tapi gizi 1. Nah, nanti dari Gigi dan dari farmasi 1-1. Tapi ada juga kelompok yang enggak kebagian teman dari Gigi dan farmasi, ya seperti itu. Jadi kita luas aja. Tentu kalau enggak ada ya mungkin tidak ada pemeriksaan gigi pada keluarga tersebut misalnya gitu. Kira-kira gitu apa ada yang mau ditanyakan lagi? Jadi kuncinya nomor 1 tuh adalah matching kurikulum dulu gitu. Dan juga kesepakatan tentang nilai. Bagaimana menilai itu juga harus harus kita sepakati betul ya karena namanya juga satu seorang DPL ya, dosen pembimbing lapangan menilai mahasiswa yang bukan anaknya lah dalam tanda kutip. Nah, itu bagaimana itu harus kita tetap harus ada training dulu begitu. Ya, jadi training terhadap para DPL dulu siap mengerti paham filosofi dari IPE baru kita laksanakan. Ya alhamdulillah Pak, selama ini enggak terlalu banyak kendala sih.
Terima kasih atas pertanyaan. Mungkin ada lagi, itu waktunya masih banyak kok Prof. Ya, jadi waktunya belum habis. Ada pertanyaan lagi? Mungkin silahkan. Bapak yang di belakang dulu ya. Nanti setelah ini ya.
Ya, terima kasih kesempatannya Prof. Tri. Saya Bagas dari Unsud, rekan dari Bu Miko, Bu Amalia. Mungkin pertanyaan saya ada 2 Prof, terkait dengan yang pertama proses pembelajarannya dan yang kedua dari assessment. Untuk proses pembelajarannya ini mungkin di Unsud kami kalau misalnya di preklinik kan ada PBL ya Prof, untuk membahas kasus-kasus etik. Nah kebanyakan yang kami dengar adalah ada kesulitan dari teman-teman tutor di dalam mungkin proses memfasilitasi diskusinya, kemudian untuk menerapkan konsep-konsep atau framework etika, walaupun sudah kami bekali dengan buku panduan tutor begitu, Prof. Jadi mungkin dari pengalaman Prof Tri, apakah sampai perlu sertifikasi khusus bagi teman-teman tutor agar bisa terlibat di dalam blok-blok bioetik, tidak hanya core teachers-nya seperti itu, atau ada langkah-langkah lainnya. Kemudian pertanyaan kedua terkait assessment, Prof. Pada saat preklinik di kami ada untuk menilai moral reasoning skill itu dengan istilahnya discussion of ethical case analysis. Jadi mahasiswa diminta menganalisis kasus, kemudian menjelaskan kira-kira apa isu-isu yang terkait, prinsip apa yang bisa dipakai gitu. Namun saya rasa jebakan Batman-nya adalah mereka terpaksa untuk pokoknya ada 4 prinsip, kasus apapun harus muncul semuanya digatuk-gatuk gitu. Jadi agak kadang-kadang jadi maksa gitu ya. Kemudian akhirnya pada saat koas asesmennya juga sepertinya agak kurang, Prof. Jadi lebih ke kita melakukan diskusi etik, teman-teman koas membawa kasus, kemudian kita ajak untuk diskusi, tapi sepertinya asesmennya juga tidak se-structured yang ada di preklinik. Jadi mohon arahan dari Prof. Tri. Terima kasih.
Baik ya. Jadi begini ya, kita kembali ke filosofi dari self-directed learning ya. Jadi kita jangan terlalu berharap bahwa kalau kita yang ngasih pasti anak-anak ngerti. Oh itu adalah mimpi ya. Jadi kalau kita ngasih gitu, kita ngasih perkuliahan, Bapak Ibu sekalian ini kan banyak mendengar ya. Paling nanti yang teringat paling cuma 10%. Karena saya bicara, penjenengan mendengarkan, dan saya ada visualnya juga. Jadi antara 5 sampai 10% tergantung seberapa perhatiannya. Demikian pula ketika mahasiswa itu yang lebih aktif, harapannya seperti problem based learning. Kalau problem based learning kita bisa berharap memorinya dia, teringatnya dia itu sampai ke antara 60 sampai 70%. Karena terpaksa dia bicara. Ketika dia bicara, dia terpaksa harus belajar dulu supaya pede untuk bicara. Jadi kita jangan terlalu berharap banget bahwa mahasiswa itu kalau sudah dikasih, didulang, ataupun dia itu juga dimasukkan ke dalam PBL, kita yakin bahwa dia itu oke. Jangan. Itu kembali kepada anak-anak kita sendiri. Gitu. Ketika kita mengajar, ya kita mengajar, maka retensi yang kita bisa harapkan ini ilmiah loh ya. Retensi yang kita bisa harapkan itu kan tadi saya bilang sekitar 10% aja. Kecuali kalau kita bawa video segala ya, jadi cetol lagi gitu, dia melihat video itu lebih tinggi lagi, sekitar 40%-an gitu sampai 50. Tapi kalau cuman seperti yang saya tadi itu sekitar terus terang saja hanya 10%. Tapi bila dia nanti sampai di rumah dia belajar lagi, dia baca lagi sendiri, kurang rasanya yang diajarkan Bu Tri tadi, coba aku tak ngelihat. Nah, dia nambah lagi dengan baca referensi, maka tentu akan jauh lebih tinggi. Nah, itulah yang bisa kita usahakan. Kita berusaha semaksimal mungkin, tetapi jangan terlalu berharap banget begitu ya. Nah, oleh karena itu, ketika dia masuk di, tadi seperti ditanyakan Ibu dari Unjani tadi, ketika sudah masuk di mana di profesi, ya itu tadi experiential learning-nya tadi gitu. Harapannya terpapar lagi. Apalagi kalau nggak disuruh, nggak ada di dalam checklistnya suruh ngomong tentang etik, nggak akan disentuh gitu ya. Jadi memang perlu ada checklistnya bahwa dia harus ngomongin tentang itu. Apakah memang harus 4 atau harus 2 saja sesuai dengan kasusnya? Lah yang paling tahu lah teman-teman dari etik ya, yang paling tahu lah itu tolong mungkin bisa menuliskannya dengan agak sedikit lebih lebih terang atau lebih teliti. Nah, mengenai tutor yang nggak puas atau nggak pede, ya wajar. Sama seperti ketika misalnya kita mahasiswa masih awal ya, tentang anatomi yang waduh jelimet-jelimet, ada foramen ini foramen itu, kan kita ya sebagai tutor ya wis lali gitu. Tapi ya enggak apa-apa. Yang penting mahasiswa itu belajar. Dia sudah di langkah ke-6 itu dia sudah belajar mandiri, kemudian dia bicara lagi di langkah ke-7 itu ya kita percaya saja pada mahasiswa bahwa itu on the right track. Kecuali kalau cetowelo-welo kalau salah begitu ya. Jadi saya kira seperti itu. Jadi kita jangan terlalu kepingin kepingin apa ya istilahnya, kalau sempurna itu nggak akan bisa. Kita bisanya berusaha. And asesmennya, asesmen etika untuk S1. Gimana? Yang profesi ya, itu tadi kan ada tim nih dari bioetika ya. Jadi di situ memang sering-seringlah untuk workshop begitu. Kalau di tempat kami memang yang paling rajin itu memang yang S1 ya. Jadi kami bahkan setiap kali selesai blok itu selalu evaluasi. Kami dari Medu itu mesti diundang. Jadi wah kok ternyata begini dan begitu. Nah mikrokurikulum itu dievaluasi terus sehingga akhirnya untuk modul berikutnya atau untuk tahun, kan berarti kalau sekarang semester 3 misalnya 3.1 bisa didandani kan untuk tahun depan. Tapi yang kira-kira bisa juga untuk ke 3.2 ya langsung diperbaiki seperti itu. Nah bagaimana dengan yang di profesi ya harus sering-sering ketemu. Begitu. Jadi evaluasi meskipun tidak evaluasi setiap modul seperti di tempat kami di S1, tetapi barangkali bisa juga dilakukan setiap tahun begitu. Jangan menjelang akreditasi. Nah, disinilah peran dari teman-teman tim bioetik untuk meyakinkan bahwa aspek ini juga di role model kan. Ya, yang penting tuh role model loh, ya toh. Role model kan juga tentu di-assessment-kan. Jadi kuncinya adalah jangan berharap 100% sempurna, nggak bakalan Pak, nggak bisa gitu. Ya, tapi kita berusaha sebagai dosen.
Terima kasih atas penjelasannya. Bisa dilanjutkan pertanyaannya? Iya.
Terima kasih, mohon maaf saya sambil duduk.
Ya enggak apa-apa.
Saya Sopan dari Kedokteran Pasundan Bandung. Menurut saya pelajaran etik dan bioetik ini sangat penting dan tidak hanya cukup seperti 2 tambah 2 sama dengan 4, tapi ini pembelajaran perilaku. Jadi sama dengan long life study. Kita semua yang ada di ruangan ini pasti sudah tahu bahwa pentingnya etik dan bioetik ini untuk tenaga profesional, terutama dokter. Jadi ada preklinik, ada klinik, dan postgraduate. Nah di UNDIP ini setahu saya ada PPDS. Mohon pengalaman Prof, bagaimana pengajaran etik di PBDS, karena peristiwa Semarang dan Bandung itu sama, membuktikan bahwa etik itu sangat diperlukan bagi tenaga profesional. Terima kasih Prof.
Baik, terima kasih. Jadi di UNDIP itu sebetulnya ada yang namanya MKDU, mata kuliah dasar umum ya. Jadi di sini kebetulan saya jadi DPJP-nya untuk Medpen dan biostatistik. Kemudian Dokter Sigit dan teman-teman kayak Pak Tuntas dan teman-teman itu untuk mengampu bioetika dan profesionalisme. Jadi diberikan di awal. Jadi masih semester 1. Nah, untuk selanjutnya mungkin seharusnya ya dititipkan, tentu saja dititipkan untuk pada para kaprodi, kalau diperlukan ya harusnya ya ketemuan begitu ya untuk menekankan itu, apalagi kita sudah ada pembelajaran yang luar biasa dari kasus yang belum lama terjadi. Jadi menurut saya memang perlu untuk duduk bersama, kemudian aspek ini tidak hanya dicontohkan, ya ada role model, tentu DPJP itu kan ya role model gitu ya, dan untuk menerapkan bioetika ini, tetapi juga perlu untuk diamati. Jadi kalau asesmen perilaku itu kan bukan teori ya, tetapi 360 degrees evaluation. Jadi misalnya peer assessment, ada juga assessment dari kepala ruang, misalnya seperti itu, mungkin akan lebih baik. Tapi saya belum tahu ya apakah sudah dilaksanakan apa belum. Nah, karena saya itu di Medu ya juga ditarik sana, ditarik sini, mereka mengembangin kurikulum ya selalu ngundang saya sampai kayak orang kayak kitiran saya itu jadinya kalau mereka ngembangin kurikulum. Nah, itu nanti terima kasih masukannya, nanti saya akan masukkan supaya aspek bioetika ini tidak hanya diberikan di MKDU saja, tetapi juga diakses bukan dengan teori, tetapi the real apa yang dia lakukan gitu. Matur nuwun.
Terima kasih, Prof. Tri. Thank you, Prof. Tri, for the inspiring talk. Give one more round of applause for Prof. Tri. Right on time, Prof. Tri. Thank you. Okay, let's move to the next topic. The next topic will be delivered by Professor Basarudin, also known as Professor Chan. Yeah, is that correct? Yes. Prof. Chan will representing the Indonesian Ministry of Higher Education. Yes, he's the senior expert for the Ministry of Higher Education, Science and Technology, who has the PhD in computing in University of Manchester with an area expertise in machine learning and social signal processing. His professional experience are based on educational assurance network, both international and national, and the Dean of Faculty of Computer Science in Universitas Indonesia. And he also received an honorary doctorate in Management Science University, Malaysia in 2019. Ladies and gentlemen, please welcome Professor Chan. Professor Chan, the time starts.
Berdiri aja. Terima kasih, Mas Moderator. Bapak Ibu sekalian, selamat siang. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera. Kebiasaan kan kalau dosen itu kalau bicara nggak bisa duduk, jadi harus berdiri. Pertama-tama, saya ucapkan terima kasih atas undangan dari Symposium Organizing Committee untuk kementerian dapat sharing ataupun memberikan beberapa informasi tentang pendidikan kedokteran di Indonesia, dan mungkin nanti kita kaitkan juga dengan topik. I will be bilingual later on. Pertama-tama saya ingin menyampaikan permohonan maaf dari Pak Menteri karena beliau pada this very moment harus berada di Papua, ya. Jadi starting this morning he landed in our easternmost of Indonesia di Papua, sehingga beliau artinya memandang pentingnya acara ini, beliau menugaskan kepada saya untuk hadir mewakili beliau. Pertama-tama tentu saja Kementerian sangat appreciate the initiative from the organizing committee to hold this kind of symposium, bioethics or research ethics, ethics in general. So it's very, very important, and it is also quite timely because at this very moment also the ministry doing some review on our regulation and policy. What one of the areas which is still, which is also being considered is how to promote ethics in research, and this is particularly important because we are talking about medical education, which is related to bioethics. Okay. Now, one of the key driver, I think, which makes that the issue of ethics is even more important is because this area, medical educations or medical disciplines as a whole are very much driven by the current technology. 2 days ago, China announced that they have successfully conducted telesurgery. I think it was about is it heart or liver kind of disease. What is interesting is this telemedicine or telesurgery was conducted by an expert which is far away, about 3,000 something miles distant, which must be, I mean, even with the current technology is still quite challenging. The challenge, not only the precision that must be done by the robots, but how the connection barrier, the internet bandwidth or something like that for the connectivity issue between the medical doctor and the patient is very challenging, because I think if you are talking about the speed, even using the fifth generation of technology, is still something like some microsecond delay, right? So they've done it via satellite. Now, even with satellite, the delay is even bigger if we are talking about the terrestrial connection with the cabling. Another important news, I think, in this area, the Department of Health in Abu Dhabi announced that they already successfully or starting an initiative for treating the Alzheimer's disease using, they call it pharmacogenomics, which is also a kind of new approach in medical technology using the genomic approach. And we know that the precision medicine is also becoming more and more important now. Okay, so I think as a whole, we are realize that the technology will be very important in all areas of human life, including for the medical areas, in the medicine and health as a whole. Now, interestingly enough, there is a survey to look how the young generation, especially those age around 30, responding to this latest development of technology. Most of them, 78% something, are taking a very positive response. They consider this latest technology is an opportunity for solution. Even though there are about 20% said that that technology will destroy and threat for us, including like a medical doctor. Some medical doctors already consider that, well, will one day medical doctor will be replaced by artificial intelligence, for example. I read a very interesting article which telling us that, I mean, I don't know, is it anecdotally saying that the conclusion was written in that article was artificial intelligence will never replace medical doctor except those who are not using AI. So, I mean, if a medical doctor stay away from this kind of technology, he or she will be replaced, by this kind of technology. Now, talking about Indonesia, of course, we are far lagging behind in terms of technology, but in terms of adoption of this new technology, we are quite enthusiast adapters. You know, if you look at the number of cell phone owners or holders, is almost double of the number of population. You know, I don't think in the United States people have 5 or 4 gadgets in one person, but it does here. You know, but if you look at, for example, the internet access or internet users, it's also quite, encouraging to see that Indonesia already, the penetration of technology is already quite vast, you know, quite widespread. So the government are hoping that we can capitalize on this readiness, digital readiness among the younger generation, or even for the whole population of Indonesia in terms of technology adoption. Now, another important things that we are already seeing the impact of the new technology in the medical areas or in the medicine, including like artificial intelligence, robotics, you know, Internet of Things, and that's all those big names. Now, if we look at what technology that's impacting the area of health services or health technologies are concerned, there are 10 latest, technology, which is the application of technology in this area of health, you know, starting from the telemedicine, as I explained earlier, down to writing the genome, and the degree of, the magnitude of application will be becoming greater, you know, in the near future. But if we look at the skills and knowledge needed by the medical practitioner, we see that I don't think I can use my pointer, but you see that from the top, working with clinical decision support system is very important, down to the architecting, designing, and implementing large-scale health software application. You know, that's something of skills and knowledge needed by the medical practitioner. Okay, so now the artificial intelligence also coming into the scene, and in Indonesia, the ministry already launched a guideline. So this is panduan, means guideline for university, how they should use the artificial intelligence, especially generative AI, in the higher education environment. Okay, now why the bioethics is important? I think we can look at some example where this kind of ethics are somewhat, not really adhered to. We know the issue Theranos, you know, so that's something. The issue took a lot of attention worldwide, you know? And the evidence that's finally, filed in the court really proved that there is some ethical violation there, and also the COVID, cases. Even in Indonesia, some of us still believe that obat cacing. What is the name of obat cacing waktu itu? Farmis, yang bisa mengendalikan virus, COVID virus. So this is related to this case, Surgisphere scandal. And back in the day, we also remember the Pfizer trial. And these are example of the importance of ethics and including bioethics. Now, let me briefly explain the current strategy and policy of the Ministry for Medical Health, Medical and Health Education. We call it the transformative medical education, and we evolve from, 3 levels of maturity. We started with improving the efficiency. Di awal-awal dulu kita masih mengadres isu tentang efisiensi saja. And then we move to addressing the issue of relevance. And we think we have to move further up to address the transformational impact of higher education, including the medical education. Jadi kita ingin agar perguruan tinggi atau pendidikan bidang kedokteran ataupun kesehatan ini benar-benar berdampak, impactful. So that's what we call the transformative higher education or impactful higher education. And we start with how do we design our higher education standard. So in the past, we have a very prescriptive standard, and which makes, our, colleague from university are finding very difficult to follow such standard because it's detailed and prescriptive. So move away from that prescriptive. Now we set the new standard to become more principle-based framework. So its autonomy is given to the university to allow them using their best knowledge and also practices, which can be taken from the global practices, how the best method or approach to carry out the medical education. And in particular, now we are developing also the standard pendidikan tenaga medis dan tenaga kesehatan, itu sebagai mandat dari Undang-Undang Nomor 17 tentang kesehatan. Jadi di samping nanti ada standar pendidikan tinggi nasional, standar nasional pendidikan tinggi, juga akan ada standar nasional pendidikan tenaga medis dan tenaga kesehatan. Okay, another approach that we are thinking of promoting is the linking, the education directly with the profession, agar pendidikan kita benar-benar merespon kebutuhan-kebutuhan dari dunia profesi. Sebetulnya mulai dari awal di Undang-Undang 12 tahun 2012 tentang pendidikan tinggi, kita sudah menekankan bahwa untuk pendidikan profesi mestinya penyelenggaraannya langsung bekerja sama dengan masyarakat profesi. Tapi pada kebijakan yang kita sedang kembangkan sekarang juga mengintegrasikan bahwa pendidikan dan pelayanan, education and services should be tied together. And another approach, the current thinking is what we call the IPE or interprofessional education. Saya nggak tahu di UNDIP apakah inisiatif ini sudah dimulai di beberapa perguruan tinggi. I've seen it that as a medical doctor you work together with other profession, solving or addressing or approach a particular problem, which may not be approach using one approach only. You mentioned about the role of historian or anthropologist, Tapi ini yang agak lokal nih, kemarin saya dengar kenapa di Indonesia itu jarang sekali ada teamwork yang antar dokter yang bisa dilakukan. Karena ternyata kendalanya dari BPJS gitu ya. Jadi kalau pasien ini di-approach dengan satu kalau dia ditangani dengan menggunakan dana BPJS hanya satu spesialis yang bisa menanganinya pada saat yang sama gitu. It's bad, local, that's domestic issue. Tapi saya pikir ini adalah suatu move yang baik juga bahwa our medical education will be approached from not monodisciplinary but using the interprofessional approach. Oke, mungkin terakhir sebelum terakhir kebijakan-kebijakan yang mendorong kualitas yang sedang ini sebetulnya sebagian merupakan amanat dari Undang-Undang 17. Jadi yang pertama tentang kurikulum, so the standard for the development of curriculum will be, as I said earlier, using the approach of principle-based and framework. So we let the university to work together with the professional association or community to set up their own curriculum. And in addition to that, the role of association of kita katakan asosiasi program sejenis gitu, itu juga akan diperkuat karena ini mereka misalnya untuk penentuan uji kompetensi mestinya kolegium dapat bekerja sama dengan kelompok ataupun asosiasi atau konsorsium apapun namanya program-program studi yang sejenis gitu. Kita juga sudah menetapkan ada sekarang pansel untuk seleksi pendidikan spesialis. Jadi khusus untuk pendidikan spesialis ada panitia seleksi yang diawaki bersama antara Kementerian Pendidikan Tinggi, Kementerian Kesehatan, dan juga para perguruan tinggi, pihak perguruan tinggi gitu. Kemudian tentu saja peran dari hospital, rumah sakit sebagai wahana pendidikan itu juga kita pandang sangat penting to be put in the equation, and we will also work together with the Ministry of Home Affairs karena Kemendagri itu ternyata punya stronghold juga di penyediaan wahana kesehatan di daerah-daerah, rumah sakit umum daerah dan seterusnya. Oke, kita juga sudah mengembangkan Permen nomor 55 yang tadinya itu difokuskan untuk kekerasan ataupun kekerasan seksual, sekarang itu semua bentuk kekerasan. Kemudian dari sisi lokusnya, tidak hanya yang terjadi di fakultas atau di universitas, tapi juga yang di tempat lain. Artinya kalau kejadian di rumah sakit juga masih kena aturan ini. Oke, now kita juga sedang membayangkan ataupun mendesain bagaimana memperkuat tentang bioethics dalam research. Jadi ada 3 main strategies. Yang pertama adalah penguatan peer review dalam proses publikasi. Yang kedua adalah research ethics sendiri. Walaupun tadi saya diberitahu bahwa ternyata di Undang-Undang 17 itu somewhat missing. Tapi yang jelas pada saat kita bicara standar, baik itu standar nasional pendidikan tinggi maupun standar nasional pendidikan medis, tenaga medis dan tenaga kesehatan, isu etik ini kita akan tempatkan pada posisi yang proporsional. Dan terakhir tentu saja transparansi. Transparency is not only about the result in research result or outcome, but also from the data, the process itself. It should be publicly transparent. I think that's all that I can share with you this afternoon. Terima kasih sekali lagi atas atensinya, dan sekali lagi saya ucapkan bahwa dari Kementerian sangat appreciate inisiatif dari UNDIP untuk menyelenggarakan kegiatan simposium terkait bioethics ini. Sekian, terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Professor Chan. I think we can take 2 questions for 10 minutes. Is that okay? Okay, is there any question from the audience? Just 2 questions, please. Or maybe from the Zoom chat, is there anyone that asked there? Professor Chan, in your opinion, what's the ministry vision of the generative AI now? Because from my perspective, they are getting smarter too, and they can write like literature review in 15 minutes. Oh, what's the ministry point of view about this?
Well, as I said earlier, the ministry has already launched the guidelines, for generative AI application or generative AI use in higher education institutions. We've from that document, we can clearly see that the government, I mean, the ministry here, consider that generative AI is the opportunity to promote your competency, your knowledge and skills, but of course with some cautions. If you look at that guideline, it is also take a very strong statement about how student assessment should be transformed, and should be changed, from the old version of student assessment. Because if you give the student kind of takeaway exam or homework, they can easily, use the. But of course, it will depend on what sort of question that you will be addressed. You will address in your exam or homework. Now, we know that generative AI are very good in a couple of things, including summarization. I remember when I was doing my PhD, it took me almost 3 months, doing systematic literature review because I had to read that so many papers. Now, one of my students, within 10 days, she can complete reading, not really she is reading it, but I mean, get the essence of 500 papers, within a week. Why? Because she used cunningly the capacity of generative AI. Generative AI is very good in summarization. So to come back to your question, we see it as an opportunity and also as the enabling technology that can, help you even walk extra miles. But on the other side of that, we have to be very careful also about the implication of violation of ethics, especially plagiarism, so that sort of thing.
Okay, there is one from the audience. Can you please pass them the mic?
Thank you. Terima kasih. Thank you, Prof. Chan. I'm Amalia from from the Department of Bioethics at UNSUD. I would like to ask about you mentioned about planning to have you mentioned about planning to have a joint selection for the residency program. Could you tell us a little bit more about this, on how you plan to do this, and also about maybe would there be like a standard admission fee for the whole program, and how it's? Thank you very much.
Terima kasih Bu. Sebetulnya ini amanat dari Undang-Undang 17 dan di turunannya itu PP 28 bahwa untuk pendidikan dokter spesialis itu mestinya dibuat atau dibentuk panitia seleksi bersama antara Kementerian Dikti dengan Kementerian Kesehatan untuk menyeleksi calon mahasiswa baru pendidikan spesialis, ya. So that committee, joint committee, was established, I think, November last year. It's already udah di SK-kan waktu itu. Nah, siapa yang di dalam panitia bersama tersebut? Jadi ada perwakilan dari Kementerian Kesehatan, dari perwakilan Kementerian Dikti Saintek, dan dari perguruan tinggi. Waktu itu kita intentionally include all deans from medical faculties who are running specialized program. Jadi ada, saya lupa, ada 30-an atau berapa dekan yang masuk di situ. Nah, sekarang bagaimana proses pelaksanaannya? Kita akan melakukannya secara bertahap. Jadi pertama adalah untuk 6 program studi yang sudah ada RSPPU-nya. Jadi yang untuk 6 program studi yang sudah ada RSPPU-nya, maka sudah akan mulai dilakukan seleksi bersama untuk next academic year, baik yang diselenggarakan di RSPPU maupun yang di Fakultas Kedokteran. Ya, itu. Nah, secara bertahap ini akan diperluas karena amanat undang-undangnya nantinya itu seluruh program spesialis, pola seleksi masuknya itu dilakukan oleh pansel ini. Apakah ada kriteria? Iya, jadi ada juknis dan nanti akan dipublish. So the guideline will be published openly, publicly, dan kita desain dengan menggunakan good practices dari pengalaman teman-teman dari berbagai FK selama ini. Kayak apa sih sebetulnya seleksi yang baik untuk calon dokter spesialis, peserta atau resident ininya. Tadi apakah berbayar atau tidak, itu nanti kita akan mengakomodasi ada peserta yang sifatnya afirmasi, ya. Tapi di luar itu ada juga yang peserta yang bukan afirmasi istilahnya. Nah, yang afirmasi ini itu akan sepenuhnya ditanggung biayanya oleh pemerintah. Ini ya. Begitu, Bu. Moga-moga menjawab.
Baik, terima kasih. Terima kasih. I think that's the last question. Thank you, Professor Chan, for coming to Universitas Diponegoro. Please give one more round of applause for Professor Chan. Okay, unfortunately that concludes the session, the second session. That's it. All for this session. I will give it back to the MC. Thank you all. Good afternoon.
Well, thank you very much, Mr. Moderator and the speaker, for very insightful presentations. And now we would like to invite the speakers, Professor Chand, and also the other speakers to come to the stage for photo sessions. The organizing committee, could you please help us manage the photo session? Yes. Dr. Tan. Yes.
Thank you.
Thank you very much. Well, ladies and gentlemen, we are now moving to the final plenary sessions of the day, titled Culture, Narrative, and Pluralisms in Ethical Healthcare Encounters. The moderator of the session is Dr. Ardita Hartanti Pramudani from Universitas Diponegoro. Ladies and gentlemen, Dr. Ardika earned her medical degree from Universitas Diponegoro and completed her professional physician's program from Universitas Diponegoro in 2021. She strengthened her academic and ethical foundations by completing a master in bioethics at Harvard Medical School in 2024. She is currently teaching at the Department of Forensic Medicine and Medical Legal Studies, Universitas Diponegoro. Ladies and gentlemen, please welcome Dr. Ardita.
Okay, how are we doing, everybody? Great. Okay. So bear with us. We're on the last session. So I hope that you guys have still some spirit because we're going to do a plenary session with a lot of our distinguished international speakers about their culture. And we hope that this session that we can learn from each other. All right. So I want to introduce you to our first speaker, my colleague, Professor Roger Yatnart Chang, or we call Professor Chang. He is a social epidemiologist whose work bridges biomedical ethics, social justice, and health equity. His research focuses on the social determinants of health, including poverty, housing, and migrant status, and the well-being of vulnerable groups such as migrant workers and rare disease patients. He holds degrees from Johns Hopkins, Harvard Medical School, and the University of Hong Kong. Professor Chung is currently the co-director of the CUHK Center for Bioethics, associate professor at the Jockey Club School of Public Health and Primary Care, and associate director of the CUHK Institute of Health Equity. Join me in becoming Professor Roger Chung.
Mike. I have to say this. Can you hear me? I cannot really hear myself. Selamat siang. Is that good? Okay. Am I right? Okay. I heard that, I was asking Ardita what would be, most respectful for the occasion. So she actually suggested me to wear this batik, which I feel that I think I wear okay, right? So, well, thank you very much. I need the pointer. Where's the pointer? Oh, right here. Okay. So for this session, we're going to talk a little bit about culture, right? Because we feel that in bioethics, it's not, a lot of times it's not enough to just talk about the principles, but also how do we engage different cultures when we talk about these principles and when we are facing ethical dilemma. So I will start with, a case, okay? And this is a case that is based on many very common cases in mainland China. But as you can see over here, this is also presented in a movie called The Farewell. Has anybody seen this movie? you've seen this movie. 2, okay. All my friends and colleagues from Harvard Medical School. It's a great movie. I think you should watch it. It's called The Farewell, but if you look at the Chinese over there, it's not called The Farewell. It's called Don't Tell Her, okay? So there's something that we are hiding from the patients, as you can see. And it says here, based on an actual lie. Okay, so here you go. So spoiler alert, still a great movie, but here are some of the details that I think are morally relevant. So the protagonist of this movie called Billy, played by Awkwafina, is an aspiring Chinese American. So she's actually a migrant to the United States. Maintains a close relationship with her Nai, that is actually the grandmother, paternal grandmother, who lives in China, Changchun. After receiving a rejection letter for a fellowship called the Guggenheim Fellowship, she discovered her parents that her grandmother has been diagnosed with terminal lung cancer and is predicted to have only a few months left to live. Through deception and manipulation of medical test results, I don't know if this is part of your culture, but in mainland China, it is part of their culture. The diagnosis is kept a secret from Nai herself. She is instead falsely told that her recent doctor visits have only revealed benign findings. A wedding for Billy's cousin from Japan has been planned in China as an excuse to unite the family to spend what is expected to be one last time with their grandmother. Fearing Billy will end up exposing the lie to her grandmother, her parents, Billy's parents, told her to remain in New York City. Don't come, okay? Because you're going to ruin it all. Now, Billy disobeys her parents and flew over to Changchun shortly after the rest of the family arrived. She assures her parents that she will not reveal the cancer diagnosis to Nai. Throughout the trip, however, she clashes with the rest of the family over their deliberate dishonesty towards her grandmother. Guilt-ridden, Billy expresses conflicted thoughts with her parents over the Chinese cultural beliefs that result in a family refusing to disclose a life-threatening disease, including the trauma of her granddad passing away without her own knowledge after they moved to the United States. So Billy didn't know that her granddad actually passed away also. Now, one night, her uncle contends that the lie allows the family to bear or share the emotional burden of the diagnosis rather than Nai herself. And this is a practice of collectivism or familism that he acknowledges differs from the individualistic values common in Western culture. Billy later learns that Nai also told a similar lie to her husband up until his death when he was terminally ill. So almost done, okay? Now, on the day of the wedding, both her uncle and cousin broke down in tears on separate occasions, but managed to proceed throughout the banquet without raising Nai's suspicions. So that scene was to kind of illustrate that it's not that, they're not telling her the result. It's not because they don't love her. They love her a lot, okay? So this is an important piece of information. They were crying. Now, Billy intercepts Nai's medical test results from the hospital, talk in English to her medical doctor who happened to have studied abroad in the UK and has their test result altered to reflect a clean bill of health, helping to maintain the lie. So Billy changed her mind afterwards. She was going with the lie. This is one last piece of information, okay, because this will be echoed in my conclusion. That night, Nai gives Billy a red pocket, right? So you know that Chinese people like to give red pockets, right? Encouraging her to spend the money as she chooses. Billy admits that she wants to stay in Changchun to spend more time with her, but Nai declines, telling Billy that she needs to live her own life. Now, when Billy reveals that the Guggenheim Fellowship rejection to her, Nai encourages Billy to keep an open mind and not get hung up on this failure. Don't be the bull endlessly ramming his horns into the corner of the room. She says that life is not about what things one does, but more so about how one goes about doing them. So it's more about the how than the what. This is to illustrate that Nai Nai has some wisdom in her, okay? But I'll come back to this quote at the end. So Billy keeps her promise to maintain the lie, okay? The question for us, of course, is that the right thing to do? Is that ethically forbidden, right? So for Billy, these are the morally, and for us who are now looking at this case, these are the morally relevant and salient features of the case, right? So for the patients, she has terminal lung cancer, diagnosed to have that, perceived to be approaching end of life, only a few months to live. And throughout the movie, we saw that her quality of life isn't that bad, okay? So it seems like she wasn't really suffering a lot, but she was suffering from some coughing, the usual stuff. But she did not know about her diagnosis, right? Or at least she went along with whatever her family told her. And she was actually very happy, okay, that her family all gathered in her hometown to celebrate the wedding together. Now, from the family perspective, they were deliberately lying about the diagnosis, and they went so far to manipulate the medical results. And they gave an argument, okay? An argument, they say, well, this is to share the emotional burden of the diagnosis so that Nai Nai, the grandmother, doesn't have to suffer it all by herself, right? And this, we can understand it as collectivism or familism. The doctor helped the family to conceal the truth. And for Billy, very conflicting for her, okay? Should it be truth-telling? Should we just tell Nai Nai the truth about her diagnosis, or should we hide it from her? This is a conflict, a moral conflict, a moral dilemma. Now, we also saw that she changed her mind. At the beginning, she felt that Nai Nai should be told the truth, right? And we can kind of relate that to respect for autonomy. It is because we respect her, she should have the right to know, right? But then she went along with the family's decision later. Now we got to ask, so is it under pressure? Is it for family harmony, familial harmony? Or, she was actually genuinely convinced by her family's argument that we should share the burden. We're not really that sure, but then in the movie, we kind of see that, maybe it is all these stuff all together, right? Because let me remind you, this is Billy, right? She's actually under the influence of her family and of the society, right? The culture, the bigger culture, right? Exerting their influences on Billy. But at the same time, she also brought another set of moral value system from the West, from the United States over. So she's really conflicted, right? Guilt-ridden, right? And you can probably also feel that this kind of feelings for her when you're watching the movie. So this is what I want to do. I want to do a little ethical analysis with you guys, okay? Now, we need to discern the level of abstraction of culture and culture taboo. Why do I say that? Because even when we say that, oh, that's the culture, that's the Chinese culture, what do we mean by that's the Chinese culture, right? So as you may see over here, a lot of what we say we're going to do, or the kind of moral judgment that we're going to make, probably lies along this spectrum of what I call level of abstraction. Right? Specific rules are very specific, but when you go up the level of abstraction, there are moral beliefs, principles, and also theories. Okay? So in China, a lot of times some people would say, oh, we are the descendants and sons and daughters of the dragon, or sometimes we would say, oh, we are sons and daughters of descendants of Confucius himself, right? But what does it mean, right? So we need to discern. The art of discerning is at the heart of bioethics, I would say. So we need to specify the contents of the culture or the cultural taboo that we're talking about. So for example, it could be a cultural rule, right? It doesn't matter what the reason is, just don't tell her. Just don't break the bad news. That is very much a rule, right? We don't need to talk about the reasons at all, right? So that's a specific moral rules. But up one level, we have beliefs, right? It could be that, well, we believe that breaking bad news will actually bring bad luck, making the family less auspicious. There could be bad consequences that we don't know what that is, but maybe there will be. It's a belief, right? It's a faith. It's not empirically proven, but we believe that is going to happen. And then moving up one more level, we have these principles. In bioethics, we want to talk about principles. We talk about principles all the time. Remember, the uncle's principle is that, well, breaking the bad news, he said, will burden the patient emotionally. That's a principle here we're talking about. So that's why we shouldn't do it, because this is going to happen. And finally, right, theory like Confucianism or collectivism or familism or Taoism or whatever, right? These are theories. These, if you don't specify them, they don't, we don't know what exactly you're talking about, right? So these are theories with specific principles and probably influencing our belief and the rules that we think we should be adhering to. And I circled this part because the uncle was actually using a kind of principle to argue for not breaking the bad news. So here you go. What is the family perspective, right? What is the uncle's principle? The uncle's principle is that do not harm Nai-Nai's general and emotional well-being. And if we have to use the lingual of Beecham and Childress or the four principles, it is actually do no harm. So that's interesting, right? Because in a more Western perspective or Western context, doing no harm should be not harming Nai-Nai's quality of life or physical condition. So even with the same principle, both from the Western perspective or from a more family or Confucian perspective, both of them are talking about doing no harm to the patients. But they mean different things, right? The family perspective, a more Chinese cultural perspective, is that we shouldn't harm the general well-being, emotional well-being of the patients. According to Beecham and Childress, however, it says, do not harm Nai-Nai's quality of life or physical health. Same principle, different specifications from different perspectives. That is why we need to really engage culture. We need to understand culture when we're using these big words like do no harm, non-maleficence or beneficence or justice or respect for autonomy. What really matters when we're using these principles is that we need to specify them. What do you mean by that, right? Now, this reminds me of a distinction that Mark Timmons was actually proposing, philosopher, ethicist Mark Timmons, in his book, Moral Theory. In this book, he basically distinguished fundamental moral disagreement from non-fundamental moral disagreement. Now, going back one slide, do you guys think that this is fundamental or non-fundamental? That's the question we need to ask, okay? So I'm going to do a bit of an analysis here. This is what Mark Timmons said. A fundamental moral agreement between two parties is one rooted in the disagreement about the basic moral norms of the parties in question. It is thus a disagreement that would persist even if both parties agree about all the relevant non-moral facts about the disputed issue. So we got to ask ourselves, is there a fundamental moral disagreement? Does one party actually want to hurt grandmother in this case? No. They all want the best for grandmother. So here you go. There's no fundamental moral disagreement according to Mark Timmons. The difference between Billy and her Chinese family is one that is non-fundamental because both meant to do no harm. So fundamentally, there's no disagreement about the basic moral norms, but whether truth-telling would harm Nai is what they are differing, right? They have different kind of judgments and consideration over here, right? One party think that if you break the news to Nai is going to hurt her. The other party thinks that she has the right to know. And if you break the news, she may actually welcome not the bad news, but she would want to know it, right? So that she can probably plan ahead for the remaining days of her life. Okay, so different non-moral judgments. That's very important to know because if we know that the difference is non-moral, is not a fundamental moral disagreement, there's something that we can navigate, right? So such differences can be resolved by rational means. So, having said that, and I know that the time is kind of up, can I keep going though? Just for 5 minutes. I think this is extremely important when we talk about engaging cultures, is that we should be shifting away from just treating all these theories, these principles as foundations, right? This is according to Susan Sherwin, right? If these theories or principles are foundational, we would be engaging in a battle of theories. So let me put it this way, simply like the Chinese family would be saying that, oh, you guys are so Western. You know, you don't care about Nai's well-being. You know, our Chinese perspective is so much better, right? You don't understand. Or from the West side, it could be that you guys are really, you know, pointing fingers, right? You guys are really just really bad people. You're lying, right? You are hiding facts. You know, from the patient, she has the right to know, right? So both parties will be pointing fingers at each other. That would be engaging in the battle of theories, right? And because if you treat theories or principles are foundational, then you got to choose among the theories. You know, we got to find the best theories that really support what I'm thinking. All right, in the Farewell case, then it became the battle between the West and the East. But this is not what we really want, right? Because it doesn't help the situation. It is not about whether the Chinese perspective is better or the Western perspective is better. It's not about that. It is about Nai, right? A lot of times when we're engaging in this kind of like, you know, battle between the East and the West, we forget who should be at the center. It should be the patients, right? So here's what I'm proposing. We should use theories as lenses only. Lenses meaning they are important perspectives that we can take. You can take, you know, it's just like, you know, the pair of glasses that I have right here today. And as you can see over here, you can take on a pair of glasses that represent, for example, Western principalism. Look at the situation, and you may have a conclusion from a moral verdict from the theory that you use. But then you can take it down and use a Confucius lens to look at the situation. Put them down again, pick up another pair, maybe a Buddhist ethics this time, or Panchasilas, right? You know, in the Indonesian perspective, you may be able to come up with different conclusions, different moral verdicts. And you would probably ask, with so many different perspectives, then how do we kind of come to terms with all the different perspectives, right? So it's not about this, okay? We're not trying to blind you. We're not trying to say that you should wear all these glasses at the same time and look at the same problem. What I'm trying to illustrate is this idea that the truth can be quite complicated, right? From different perspective, you know, from a I don't know, deontology or Buddhist ethics perspective, it could be a square, but from another perspective, it could be a circle or a triangle. So what I'm trying to say here is that no one theory alone can represent the whole truth. That is why we should have some kind of humility, cultural humility or epistemic humility when we're looking at the picture. So bioethics is not about training ourselves to be the defender of a particular selected theory or school of thought, but training ourselves to be able to use these different perspectives as tools. That's why we need bioethics training, is to be able to understand the situation or the case from different perspectives. It is much more than just being an expert in deontology or utilitarianism, okay? Or principalism. So being able to do that can help us to see the picture from different angles that contributes to the robustness of the idea of pluralism. So if robust pluralism acknowledges the contribution, the importance, and the strengths of each of these moral theories and principles, but also critical of the limitations of each of them. So robust pluralism in bioethics rejects the idea that the right answer, the perfect, the idea of finding a perfect answer, and is not about the battle between different moral accounts, right? Because if it is like that, inevitably it will become some kind of obsession with coming up with the perfect theory. It's not about coming up with the perfect theory. It is about calling for acknowledgement and balancing. It's a key word today, okay? Balancing, weighing the different perspectives to make a considered judgment that we believe should probably be the most informed judgment in this particular situation, this particular scenario, okay? Are you guys still with me? Yeah? Okay. All right. So robust pluralism embraces the ideas that life and human nature are really messy and complicated. That we should hold ourselves to humility, that we cannot always get it perfect, get it right. The best that we can do is to acknowledge, to balance, to weigh the different perspectives to come up with a considered judgment. That is not perfect. It's not perfect because, whether you tell the news to Nai or not tell, there will be moral burden and moral residues that are left behind, right? Moral tension still exists, whichever moral judgment we've made. So the focus should not be coming up with or defending the best theory, but on making meaning out of this human experience. The focus should be back on the patient. So global bioethics embraces robust pluralism by taking into account bioethical arguments and perspectives from different cultures worldwide. So back to the case. I'm almost done, okay? But are you guys enjoying your time here? Okay, good. That's important. Billy maintains the lie. Is that not okay? Is it unethical or ethical? Okay. Now, maybe let's do a poll over here. Who thinks that, yeah, it's okay given, the culture in China, maybe this is fine. Raise your hand, please. It's okay. It's okay not to tell grandma. Who said absolutely not? Okay, all right. A few of you, okay. You're both absolutely not or absolutely not okay. Absolutely not okay. Okay, all right. So this is what she did, okay? She maintained a lie. And this could be her considered judgment after weighing out all the different perspectives. Is it perfect? No, it's not perfect. Of course it's not, right? There are moral tension of truth-telling. It's still there. But what she did not engage in is that she did not engage with the battle of theories that, my perspective I went to America for education, so my perspective is better than yours. She didn't do that, right? She maintained her humility as epistemic humility in this situation. She did not take the moral high ground and blame her Chinese family for being immoral. What she did was that she focused back on her relationship with her grandma, making meaning, caring for her grandma, putting her grandma's well-being at the center of it all. Earlier this year, Nancy Jecker and I proposed some moral values and ritual practices according to Confucianism for global bioethics. So these values include tolerance, mutual respect, epistemic justice, cultural humility, and civility. If you're interested, please go through this paper. We have kind of illustrated how we can use these kind of Confucian rituals, okay, to engage in robust, pluralistic practices in bioethics. This is my last slide. Life, this is according to Nai Grandma, life is not about what things one does, remember what she said, right? But more so about how one goes about doing them. I think it informs a lot about how we should do the work of bioethics. So I said, bioethics is not about what decision one makes, but more so about how one goes about making them. Thank you very much. Thank you very much. Thank you.
So thank you so much, Professor Roger Chung. Can we get another applause, please? So before we move on to the next speaker, we have some words from the Minister of Health, Indonesian Minister of Health, from Dr. Ana Kurniawati. She's the Director of Health Resources, who will be representative from Mr. Akemat. So if we can get, she will be joining us online. Okay, so while we're waiting on that, we're gonna figure out the IT. If you have any questions, we will have a discussion after this. So you can write down your questions and answers to Professor Chung and another 3 speakers. Again, our beloved Dr. Hajang Lee and Dr. Tan. And speaking about their culture and their pluralistic values from their own countries. Thank you. Okay, so while we're waiting, let's just call the next speaker. So Dr. Hajang Lee, let's give it a pause. And she's gonna talk about the role of religions and the role of religions in moral worlds. Let's give an applause. Welcome back, Dr. Hajang Lee.
Thank you so much. Can you hear me? Yeah, awesome. Selamat siang. Are you doing all okay? I myself has been so sleepy trying to wake up. So if you can stretch or move your body, that's totally okay while I'm talking. So I'm gonna talk about something about bioethics and religion. Please stretch. Stretching is good.
So this afternoon, I want to talk about moral words in medicine, particularly how religion and bioethics intersect in powerful and sometimes overlooked ways. So in this talk, I will invite you to think with me about what religion really means, right? So we talk about religion all the time, but what does really religion means in the clinical context, especially, and how religious beliefs shape patients' decisions, and why understanding lived religion. I'm going to use the term lived religion. Lived religion is a theory and methodology of religious studies today, and I'm going to explain very briefly about it and why lived religion is crucial to learn for ethical and compassionate care. So let's begin with a simple but essential question. Why does religion matter in bioethics? It matters because medicine is not only technical, but it is moral. And it's about the care of people who are suffering, who are vulnerable, and who are making some of the most difficult decisions of their lives. Religion plays a central role in shaping how individuals interpret illness, suffering, healing, and death. And religion may give some meaning on all of these. It offers moral frameworks, communal support, and ritual for coping. As clinicians, if we fail to recognize the religious and spiritual dimensions of our patients' lives, we may unintentionally cause harm, not just physical, but moral and emotional distress. So today we're going to go over, this afternoon, we're going to go over why religion matters. And I'm going to give you an example, like brain death case, like end of life issues. We're not going to get deep into the debate on brain death, but I'll give you some like different understanding of death according to different religions. And then I'm going to talk about lived religion and hybridization, why it is important to understand these concepts in clinical settings. So that's Ponce there. Okay. So what is religion? It's not just doctrine or affiliation. So Professor Chong was talking about like get out of like checkbox, right? I'm gonna say the same thing. Religion is not about affiliation. So let's say that someone is Muslim, does not mean that like all the Muslims think think the same way, and their end of life preferences, for example, would be the same. And a dynamic set of beliefs, practices, and experiences. And what is religion? Shaping meaning, morality, and care preferences. And it often deeply personal and shaped by life context. So here's, I've just learned how to read it from Professor Kuzewan Keper Jayan. Jawan. It is not one of the 6 recognized, officially recognized religions, right? How many people think Kejawan can be interpreted as religion? Raise your hand. How many people think it is not religion? It's just belief system. Okay, fair. So here's another Aliran Gaperet Jayan. So, I mean, I talk about it with the professor today because I wanted to make sure that am I bringing the right context or not. And I grew up in South Korea, and I grew up in like this culture, shamanistic culture, right? Or shamanistic religion, whatever you call. So if you are a K-drama fans, you probably have seen like the last like a person who wears like, red dress, red garments, that's a shaman. Super common that they do have this ritual, and you probably have seen like that ritual if you have watched like 2-3 Korean like dramas. So, but when I ask people, do you believe in shamanism? Most of people who said no, but they practice shamanism. And they go to shamans to ask fortune telling. They go to shaman to like get blessings and have this ritual. So it's super common. So the statistics tells us that a number of shamans in South Korea is more than a total number of Christian pastors, priests, and Buddhist monks. So there are so many shamans, and it's a huge, huge billionaires industry there. And so we call this, the left two photos, we call that Hosa. Hosa is the one that you want like love, you want blessings from the spirit for your business or for your film or dramas. So before they launch any Korean drama or film, they do have this ritual. It's very common, unless all the producers and protagonists and investors are like strong evangelical Christians. They mostly have this Hosa. So if you see that on the left side, you have like shrine, a small, it looks like ancestor veneration type of table. And they put some like food, and they put the pig, and they put like money to the like smiley pig. So it should, the smiley pig's head are more expensive than the sad pig. They put the money into it, into their mouth. And in the middle, like very like middle photo over there, you can see director Bong Joon-ho, like the Parasite one. Like they also had like Kosa. So it's super common. But when I ask people, what is your religion? Nobody's like, not nobody, but like less than like 1%, usually 0.3, 0.2% people said shamanism. Even shamans themselves don't say their religion is shamanism, because thick stigma is attached. People all practice it, but if you practice shaman, you're not rational being, you're not well educated. Are you still believing shaman? That's superstition. So what is religion? Lived religion, that's the like very confusing concepts. And I wrote one article about it. So if you're interested in like the definitions of religion and how we can engaging in a concept of lived religion, you can look up this article. So we're going to talk about more of religion, but here, let's talk about, let's turn to bioethics. So in many textbooks, we are taught that bioethics is based on 4 principles. These principles are important, but they are not enough. So bioethics is more than rules, more than principles. It is about relationships, context, and compassion. So ethical decision-making requires us to understand not just what is legal or efficient, but what is meaningful for each patient. This is where religion enters as a guide to understanding the moral world each patient inhabits. So you're all familiar with 6 officially recognized religions, and these categories are important for state and institutional purposes, probably, such as like IDs and national data. But however, in the clinical setting, these labels can become overly rigid, and they may cause us to overlook the diverse ways in which people interpret and live out of their faith. So when people kind of checked, I'm Hinduism, I'm Hindu, and the clinicians like look at like what Hindu believe and make the checkbox there, right? But however, like individuals may practice differently, and they may believe in a different way. So here, some limits of categorizing religion clinically. Listing the 6 official religions may obscure lived diversity. So For example, not all Muslims will agree on end-of-life decisions. It's very personalized thing when you try to make a decision or when you do have a preference. And not all Christians will respond the same way to suffering. So from Christian theology, suffering can be viewed as positively or negatively. So for positively, like you are going through pain and suffering and you go through like what Jesus went through, like on cross. So that's very meaningful and special thing. But suffering can be seen as negatively. And some people say we need to liberate everyone from pain and suffering. And here, even within a single family, you may find a range of beliefs and moral convictions. So ethical care means respecting the diversity. So not assuming it away, right? So when someone is affiliated, on their card says Hindu, their card says Muslim, that doesn't mean that they do have the same belief. So let's not assume that. That's the people of using the charts, using the boxes. So let's take the example of brain death briefly. We're not going to get into like ethicality of brain death and like whether it makes sense or not legally. But in the United States, like brain death is defined legally and medically as the irreversible cessation of all brain functions, and as Indonesia as well, and most of Asian countries. But Asian countries, if you see like where brain death has legalized, it was like kind of very late in the game. And many researchers consider religious cultural factors play there. So people had a hard time to embrace a concept of brain death. Why? So if you see, I really don't like this dichotomy, West, East, it's not exclusive to each other, but like I'm going to use some dichotomy, like some binary system. So here, if you see West, clear body, soul separation, brain is dominant organ and soul lives in the brain. I mean, not everyone believes that, but generally speaking, and clear boundary between life and death. So you are either alive or dead at certain threshold point. And it values autonomy. And Eastern tradition, integrated view of life consisting of body, spirit, and nature. So no obvious dominant body part. So your spirit can reside like all over. We don't know where, but all over. And ambiguous transition from life to death. It's not like life and death at the like one moment, but it is a gradual process in many Eastern traditions and many Eastern religions, like Buddhism, for example. And values interpersonal connections and family-centered approaches. So, I mean, you can see some differences here. And so again, in Buddhism, for example, the moment of death is significant because it affects the nature of one's rebirth. So depending on how you die, your rebirth, your reincarnation can be good or bad, or whatever happens, it could be affected. And according to shamanism, it gets affected as well. So intact body, peaceful death and dying, very important. So a peaceful conscious death is seen as the most ethical and desirable way of dying. For example, if we consider Buddhist perspectives. So decisions like withdrawing life support or organ donation, brain death, all these must take into account these like layered meanings. So, and I want to introduce, I'm going to introduce like some framework in religious studies. You may or may not familiar with it. One of those is elite religion versus popular religion. Again, sorry for binary system, but we call like all of your 6 officially recognized religions as elite religions. So it's elite religion traditions, but there's a concept of a popular religion. So popular religion, for example, shamanism can be popular religion, and kejawan can be popular religion. So whether we can use the term religion or not, like it's controversial among religious studies scholars, but it's worth to think of and recognize as popular religion. So here, who defines it? Elite religion, religious authorities. So religious authorities exist, and many times theologians exist, or in elite religions, they have sacred books. They have like Buddhist sutra, they have like Hindu sutra, they do have Quran, like the Sharia, like Bible, they have like these doctrines. So you can study with that, and you can find foundations like where some concepts come from. So, but popular religion, it's among like lay people, local communities, they practice it. So it's more focusing on practice, and it usually doesn't have any sacred books. So for example, we don't have any books that like famous Korean shaman write about shamanism. We don't have any doctrine, but it's thickly embedded in culture and in society. So everyday life, people do practice shamanism, for example. So it's by oral traditions and lived experiences, and many times bodily experiences. They are chanting together, they're singing together, they can jump together, like use their body, rather than like reading and praying, right? And so in elite religion, formal rituals, official worship, they do have at mosque, and you do have the prayer time. And for popular religion, some folk religions, healing, some hybrid customs. And the functions, popular religion provide daily meaning and support, but it doesn't have usually any theological interpretation. And view on deviation. So for popular religion, it's viewed as adaptive and meaningful. And in elite religion, if you have any deviation, they call it heretical. You are excommunicated if you are Catholic, and you're excommunicated if you're Protestant, if you do have very different views from the mainstream views. And in Indonesia, Javanese Selamatan feast, local healers, and sister veneration, we can consider that as popular religion. So again, whether you can call it as religion or not, it's controversial among religious studies scholars, but it's one way to interpret that. We can be more inclusive to understand what religion means and what is religion, because popular religion has been practiced among many women and many uneducated people. So it has been looked down. It has been discriminated. That's a superstition. That looks weird. That doesn't work. But elite religion, it does have all authority, and people do consider these are the only way that we understand religion. So examples in Indonesia, elite religion, Islamic fatwa councils, very important in bioethics, and Catholic catechism, state registered churches. All of these, including Confucianism, Buddhism, if you think of it, there are like sacred books, and those are all elite religion. And then if you want to consider about end-of-life care issues, death and dying, like how they view good death, how they view afterlife is very essential, actually. So that's why like religious studies and religion matters here. So it's a good example. So again, it's dichotomy, this worldly religion, otherworldly religion. In religious studies, we have used these terms for a long time, but I don't think it's exclusive each other. So if you see Hinduism, it says both. It's this worldly balance, reincarnation cycles. And so Christianity is otherworldly religion. Afterlife is more important. Like people go to heaven and hell, and we care about that, and that gives our moral guidelines as well. And then Confucianism is a very this worldly religion. Like Confucius didn't really talk about what's going to happen after life, but let's just focus on this life. That's for example, Japanese like Islam,
maybe more this worldly, well-being, cosmic harmony important. So depending on what kind of like branches of interpretations about the sacred books, it can be like otherworldly or this worldly, and what are the focuses, what are the important moral guidelines that gives us the meaning, and it's very helpful for clinical setting. So views on brain death by religious traditions, there are like all is, different interpretations, and it depends on how you view about life, how you view about death. So when we talk about death, it can give us a chance to think of what life means, right? And what is important in our lives, and if there's any next life or reincarnation or going to heaven and hell, like, is that important to you? Really, religion offers all these like moral framework. So some application in end of life care, like if we say Semarang like context, some popular practice, Selamat and ancestor remembrance, like Japanese rituals and taboos, animist and local deity offerings, chanting and incense with local mediums. So a lot of these popular practices have been discriminated, because like some people say it's like cultural imperialism or academic imperialism, that a lot of anthropologists and religious studies people have categorized it as like, oh, that's non-religion, that's all like superstition. But today, the main like stream gets kind of changed in religious studies, and people are like looking into popular practice, and like rather than what the textbook, like, I mean, not textbook, sacred texts say, but we are looking for what people are actually practice in their daily lives, not only in mosque, not only in church, or not only in the Buddhist temple, but in mundane life, like everyday life. What do you do?
Dr. Lee, I'm sorry, time's up.
Oh, can I go a little?
Yes.
So define lived religion. That's the methodology and concept as well. So it's a broad conception of religion that is practiced, experienced, and expressed by ordinary people in everyday life. So it doesn't have to be at the religious institutional spaces, nor by sacred books. So it may not have any guideline, but what does ordinary people do, and what do they believe, and what do they practice? So it's trying to be more inclusive in a way. So a lot of, like for example, shamanism, it has been practiced by many women, and not like well-educated women. And it does get like some discrimination, but we are trying to inclusive, and like lived religion is very important in clinical context. So how people embody, interpret, and practice faith daily, and decisions around end-of-life care vary widely. So it's not the same like among two Muslim people. They may have different views and different preferences. And even and religion is shaped by personal experiences, not just texts or institutions. So beyond the boxes, let's get out of the checkbox. So once you check the box, I look at the national card ID, and it says Muslim, it says Confucianism, and then you check the box. But that's not it. Like, you gotta think like out of the box and think of hybrid religion. So religious practice is often hybridized. We use the term hybridity, hybridization. There's like hybridization theory as well. In an easy word, mixed. Everything is mixed together in different local contexts, right? So, for example, Japanese Islam may include elements of Hinduism or indigenous cosmology, and some like Korean Christians, like Protestants, may go to shaman, right? So people do have all these like mixed or hybrid religious practices. That's the realities. And like hybridization reflects adaptation. So here are some examples of lived religion and hybridization. So here, in Indonesia, like, Christian rituals combined with weighing narratives or offerings, or Japanese like Islam, Ramadan fasting practice alongside ancestral venerations. So a lot of different practices are all mixed in individual life. That's the reality. So here are some indigenous beliefs and Elan Kepercayaan, like you can see some examples here. And most of non-Western religions and even Western religions, like they do show hybridity, which we have recognized because a lot of Westerners think their Christianity is authentic and your Christianity is syncretic, it's weird, it's contextualized. But in reality, throughout the history, religion and religious sacred books have been interpreted and contextualized and practiced in so many different ways. It's all localized and contextualized. So, I mean, it's one of the example of the diversity toolkit. So if they have the religion categories, for example, Buddhism, I got it from Cleveland Clinic thing, and then you check the box. They do have many checked box. Checking box is very handy, very efficient, very utilitarian. So I'm not against checking box, but don't limit yourself to just within the checked box. Think out of the checkbox. So you can check like whether you are Theravada Buddhism, Mahayana Buddhism, like all these boxes. You see so many boxes, but the lack of understanding of patient's religion can happen when you just check the box and not communicating with your own patients. So patients may feel othered if you don't really understand what their values and what their religions are, and it can trust can break down. So doctor-patient relationship can get broken down. And their families feel moral distress, and patients may avoid seeking care because they don't feel that they are recognized and they don't feel that they are respected. So health disparities can grow potentially. So it is very important to get to know their religion and what their actual practices are, what their actual beliefs are, and oftentimes it's also shaped by their education, their religious institutions, and their family background. Like a lot of things are all mixed together. So try to find out an individual practice, an individual belief, rather than check the box only. So don't assume based on label, ask about beliefs and practices. So just communicate with your patients, talk to them, and recognize the religion and its role in moral reasoning, and accept that hybridization is common and very meaningful. So tailor ethical care, not just to doctrine, but to lived reality and lived experience. So here's my, here's one of my favorite, oh, it doesn't come out, okay. So it's the refrigerator magnet that I just purchased like 3 weeks ago from Einstein Museum. It says, it is harder to crack a prejudice than an atom. So our implicit bias and prejudice, like to cracking down, is harder than crack an atom. Like, we are usually ingrained with so many different biases about human beings and about others and about myself. So try to examine what your implicit biases are, examine yourselves first, and then try to get out of these boxes. And the box method about religion, especially like if you check the box of 6 officially recognized religions only, then that can add more bias actually. So if you have any questions, I'll talk to you and just talk to me like after the session. Thank you so much.
Thank you so much, Dr. Lee, for your amazing presentation and your efforts on really incorporating the Indonesian context. So before we move on to the next speaker, we're going to listen a 15-minute presentation from Dr. Akemat. Dr. Akemat, are you there? From the Minister of Health. So Dr. Akemat is a policy analyst in the Department of Human Resources and the Ministry of Health. Yes. Hello, Dr. Akamat. Can you hear us? Can give a thumbs up if, oh, maybe the IT can unmute. Okay. You are already on mic, Dr. Akamat?
Okay. Thank
Okay,
you so
great,
much.
great. We can hear you. Thank you so much.
Can start? Oke. Selamat siang. Assalamualaikum warahmatullahi wabarakatuh. Pertama-tama Bapak Ibu guru besar beserta Bapak Ibu sekalian peserta pertemuan pada sore hari ini. Perkenankan saya mewakili Kementerian Kesehatan, dalam hal ini Ibu Direktur Jenderal SDM Kesehatan, karena beliau berhalangan untuk bisa hadir bersama-sama dengan kita pada sore hari ini. Mohon izin share screen. Ya, pada sore hari ini, pada siang hari ini saya akan sampaikan terkait dengan refleksi sistem sumber daya manusia kesehatan Indonesia dan bagaimana peran strategis dari Kementerian Kesehatan untuk bisa mengelola sumber daya manusia kesehatan ini sehingga bisa seoptimal mungkin memberikan yang terbaik dalam pelayanan kesehatan untuk masyarakat, tentu supaya juga indikator-indikator kesehatan di negara kita itu bisa ditingkatkan secara signifikan. Sedianya materi ini akan disampaikan oleh Ibu Direktur Penyediaan SDM Kesehatan, tapi dalam waktu yang bersamaan beliau sedang ada tugas di Klatimnya sehingga tidak bisa hadir bersama-sama dan memberikan materi ini kepada Bapak Ibu sekalian peserta pertemuan hari ini. Iya, Bapak Ibu sekalian, kita akan melihat potret SDM Kesehatan di Indonesia yang tergambar dalam slide-slide berikut ini, bahwa yang pertama secara nasional kita masih mengalami kekurangan tenaga medis dan juga tenaga kesehatan di fasilitas pelayanan kesehatan kita. Bahkan untuk standar minimal sekalipun kita masih kekurangan, apalagi kalau dibandingkan dengan standar-standar yang lebih tinggi seperti di negara-negara OECD ataupun negara-negara maju yang lain. Kita masih memiliki beberapa atau banyak puskesmas yang belum memiliki cukup dokter, yang sudah lengkap 9 nakes, ini 9 nakes di puskesmas yang standar minimal dengan 2 dokter, 1 dokter gigi, perawat dan sebagainya, masih ada sekitar 40% yang belum lengkap. Dan masih ada sekitar 40% RSUD kita di Indonesia ini yang belum lengkap memiliki dokter spesialis yang dipersyaratkan, yaitu 7 spesialis dasar. Ya. Nah, ini kondisi di mana kekurangan SDM kesehatan itu terlihat secara nyata di 8 profesi kesehatan prioritas. Kita masih banyak mengalami kekurangan dan ada 7 profesi yang masih kurang begitu ya. Dari perawat, psikologi klinis, dokter gigi, promkes, bidan, ATLM, apoteker, kesling, dan juga nutrisionis, kita masih mengalami banyak gap ya. Untuk perawat Misalnya, ini adalah salah satu-satunya tenaga kesehatan yang sudah mencukupi kebutuhan, tapi kita masih kekurangan di psikologi klinis, dokter gigi, promkes, dan yang lain-lain. Bapak Ibu sekalian, ini menggambarkan tren capaian output puskesmas yang lengkap dari 9 jenis tenaga kesehatan di 2024. Memang ada peningkatan, ya, jumlah puskesmas yang lengkap dengan 9 jenis tenaga kesehatan, tapi kita lihat bahwa targetnya belum bisa mencapai 100%. Ini peta Indonesia yang menggambarkan bahwa dari 9 jenis tenaga kesehatan di puskesmas, terdapat 6.645 puskesmas itu yang kekurangan 9 jenis tenaga kesehatan. Artinya tidak lengkap memiliki 9 jenis tenaga kesehatan dengan jumlah yang sudah ditetapkan di dalam Permenkes. Ya, terutama di Indonesia Timur kita masih banyak sekali mengalami kekurangan. Sementara di Jawa relatif sudah mencukupi antara 76 sampai 100% dan juga 51 sampai 75%, tetapi di daerah-daerah timur seperti Papua, kemudian juga di Maluku, kemudian Nusa Tenggara Timur, kita masih banyak puskesmas yang belum lengkap mempunyai 9 jenis tenaga kesehatan. Bahkan yang lebih ironis lagi, ada 3,4%, ada 344 puskesmas yang kita catat itu belum memiliki 1 orang dokter sekalipun. Dan 291 puskesmas yang kosong dokter ini adanya di wilayah-wilayah DTPK yang memang mengalami masalah dalam hal keterjangkauan, transportasi, dan juga fasilitas-fasilitas yang lain. Kita lihat di dalam grafik ini bahwa Papua Pegunungan itu yang paling tinggi puskesmas yang mengalami kekosongan dokter. Bagaimana dengan rumah sakit umum daerah? Di rumah sakit umum daerah itu seharusnya memiliki 7 dokter spesialis dasar, yaitu dokter spesialis penyakit dalam, anak, bedah, obgyn, kemudian radiologi, anestesi, dan juga patologi klinik. Itu masih ada 291 atau 38,9%. Itu rumah sakit umum daerah belum memiliki secara lengkap 7 dokter spesialis. Ya. Nah, jadi Ibu Bapak sekalian, gambaran-gambaran tadi menunjukkan bahwa dalam hal jumlah kita ini masih kekurangan, ya. Kita masih kekurangan jumlah SDM secara nasional. Sementara suplai lulusan untuk dokter spesialis ini masih sangat-sangat terbatas. Tidak dipungkiri juga, Ibu Bapak sekalian, bahwa bukan hanya jumlah. Kalau kita lihat dalam peta tadi, ada yang menunjukkan bahwa jumlahnya sudah cukup, bahkan mungkin ada beberapa wilayah itu yang sudah mungkin kelebihan jumlah dari SDM kesehatan termasuk dokter spesialis, tapi ada wilayah-wilayah tertentu, contohnya saja di Indonesia Timur itu masih sangat kekurangan. Artinya kita juga bermasalah dalam hal distribusi. Bukan hanya secara nasional, tetapi barangkali kita juga bisa melihat bahwa di satu provinsi pun maldistribusi itu juga terjadi. Nah, di kota-kota mungkin jumlah dokter spesialisnya mencukupi, jumlah SDMK-nya mencukupi, tetapi di wilayah-wilayah yang jauh dari ibu kota provinsi, daerah DTPK itu sangat kekurangan. Terutama kalau kita lihat adalah di Indonesia Timur. Ya. Kemudian kita juga bermasalah terkait dengan distribusi ini adalah rendahnya retensi tenaga kesehatan di daerah. Banyak permasalahan terkait dengan ini, salah satunya adalah karena insentif kurang menarik dan juga pola karir yang tidak jelas. Ini juga menjadi masalah. Bahkan kami pernah temui bahwa ternyata dokter-dokter PGDS itu mendapatkan insentif yang ternyata lebih besar daripada insentif yang dari untuk dokter spesialis yang sudah menetap di tempat tersebut. Ini juga menjadi permasalahan tersendiri. Nah, terkait dengan distribusi SDM yang tidak merata ini, ada kendala-kendala yang kita hadapi. Salah satunya adalah karena dengan otonomi daerah berdasarkan Undang-Undang 23 tahun 2014, maka kami di pemerintah pusat itu memiliki kewenangan terbatas untuk melakukan redistribusi tenaga kesehatan di vaskes milik pemerintah daerah. Kami di pusat mengalami ini, bahkan juga Bapak Ibu sekalian, ini kendala juga yang dihadapi oleh pemerintah provinsi. Ya, pemerintah provinsi juga mengalami kendala yang sama untuk bagaimana meredistribusi antar kabupaten kota yang ada di wilayahnya. Ini yang tentu harus menjadi pemikiran dan perenungan kita semua. Dan masalah dan tantangan yang ketiga terkait dengan SDM kesehatan ini adalah kurangnya pelatihan berbasis kompetensi. Terkait dengan ini, tentu saja bahwa SDM kesehatan yang ada di seluruh Indonesia itu harus memiliki kompetensi yang standar, yang tentu diharapkan bisa mengatasi masalah-masalah kesehatan yang dihadapi di semua wilayah. Namun, kita tahu bersama bahwa akses untuk mendapatkan pelatihan, seminar, workshop, dan sebagainya itu sangat-sangat berbeda satu wilayah dengan wilayah yang lain. Variasinya sangat lebar begitu ya Bapak Ibu sekalian. Nah, untuk itu kita juga ingin benahi dengan upaya-upaya yang kita bisa lakukan, misalnya dengan pelatihan online dan sebagainya, sehingga walaupun ini bukan sesuatu yang sempurna, tetapi mudah-mudahan bisa mengatasi masalah terkait dengan pelatihan berbasis kompetensi ini. Nah, masalah-masalah dan tantangan-tantangan yang kita hadapi, Ibu Bapak sekalian, ini sejak 5 tahun yang lalu, bukan 5 tahun lah, sekitar 4 tahun yang lalu, sudah dicoba untuk diatasi dengan Kementerian Kesehatan melaksanakan transformasi sistem kesehatan dengan 6 pilar transformasinya, dan salah satu transformasi yang menjadi tentu concern kita adalah transformasi SDM kesehatan. Mengapa transformasi SDM kesehatan menjadi sangat penting? Karena SDM kesehatan merupakan enabler bagi transformasi yang lain. Di samping sistem pembiayaan dan juga teknologi kesehatan. Tanpa SDM yang handal, profesional, jumlahnya cukup merata dan di seluruh Indonesia, maka transformasi layanan primer, transformasi layanan rujukan, maupun transformasi sistem kesehatan, sistem ketahanan kesehatan tidak mungkin dicapai secara optimal. Jadi begitu pentingnya transformasi SDM kesehatan ini, karena akan menjadi enabler, menjadi transformasi yang lain itu dapat dilaksanakan dengan baik. Nah, transformasi SDM kesehatan yang kita laksanakan ada 3 kegiatan prioritas, yaitu pemenuhan dan pemerataan SDM kesehatan, kemudian peningkatan kompetensi dan pelatihan SDM kesehatan, dan juga pembinaan jabatan fungsional kesehatan dan karir SDM kesehatan. Pemenuhan dan pemerataan SDM kesehatan terutama kita prioritaskan untuk pemenuhan 9 tenaga kesehatan di Puskesmas melalui penugasan khusus, kemudian pemenuhan dokter spesialis di RSUD, dan juga pendayagunaan tenaga kesehatan warga negara Indonesia lulusan luar negeri. Kemudian untuk peningkatan kompetensi dan pelatihan SDM kesehatan, kita melaksanakan pendidikan dan pelatihan tenaga kesehatan dan juga SDM kesehatan yang lain. Termasuk juga bagaimana memberikan bantuan pendanaan pendidikan bagi calon dokter spesialis, calon dokter subspesialis, dan juga tenaga kesehatan yang dibutuhkan untuk pembangunan kesehatan. Sementara pembinaan jabatan fungsional kesehatan dan karir SDM, kita melakukan penguatan pengelolaan jabatan fungsional dan juga pembinaan karir tenaga kesehatan di Pasyankes. Ya, mohon maaf saya salah pencet. Ya. Eh,
Mohon
Ya,
izin.
program unggulan transformasi SDM kesehatan, oleh karena itu terkait dengan penyediaan, kita melakukan upaya-upaya untuk bagaimana menambah jumlah SDM kesehatan di Indonesia, tentu untuk mencapai standarnya, maka dilakukan penambahan-penambahan prodi, ya bersama dengan Kemendikti-Saintek, kemudian juga baik itu prodi dokter, prodi dokter spesialis, khususnya yang menjadi prioritas, kemudian juga memperbanyak wahana pendidikan kedokteran di Pasyankes, kemudian juga pemberian beasiswa dan upaya-upaya yang lain juga untuk mendorong pembukaan prodi-prodi langka yang dibutuhkan di dalam pelayanan kesehatan seperti fisikawan medis, psikologi klinis dan sebagainya yang kita upayakan, SPKKLB dan lain-lain. Kemudian dalam pendayagunaan kita juga melakukan kemudahan regulasi para diaspora kesehatan BNI lulusan luar negeri untuk bisa memperkuat pelayanan kesehatan di Indonesia. Kemudian peningkatan mutu juga kita lakukan pelatihan-pelatihan dan pengaturan penyelenggaraan pelatihan, menstandarisasi, mengakreditasi penyelenggara-penyelenggara pelatihan sehingga semuanya itu dapat secara sinergis, penyediaan dilaksanakan secara optimal, pendayagunaan juga optimal, juga peningkatan mutu. Sehingga tantangan-tantangan yang kita hadapi dalam hal SDM kesehatan ini bisa diatasi. Ini upaya-upaya pemenuhan tenaga medis dan tenaga kesehatan melalui pendayagunaan tenaga medis dan tenaga kesehatan, baik dalam negeri, tenaga cadangan, kemudian tenaga medis dan tenaga kesehatan warga Indonesia, warga negara Indonesia ke luar negeri, kemudian juga terkait dengan pembagian kewenangan tenaga medis dan tenaga kesehatan, kita juga melakukan upaya-upaya baik di pemerintah daerah maupun pemerintah pusat, di mana pemerintah daerah wajib memenuhi kebutuhan tenaga medis dan tenaga kesehatan melalui pelayanan kesehatan dasar, kemudian juga pemerintah pusat melalui pemberian insentif atau disinsentif kepada pemerintah daerah. Nah, strategi transformasi sumber daya manusia kesehatan itu juga sudah jelas legal standingnya di Undang-Undang 17 tahun 2023 tentang kesehatan dari pasal 197 sampai dengan pasal 313. Upaya-upaya menjamin ketersediaan dan kualitas SDM kesehatan kita lakukan secara all out, yaitu dengan penyediaan SDM kesehatan, kemudian pendayagunaan, dan penyediaan itu tentu merefer kepada perencanaan SDM kesehatan secara nasional dan juga melakukan peningkatan mutu. Nah, pembunuhan tenaga medis dengan dukungan pendidikan Universitas kita lakukan juga dengan academic health system, di mana ada upaya-upaya untuk memenuhi jumlah itu dengan baik itu penambahan kuota mahasiswa, baik dokter maupun dokter spesialis yang sudah kita sepakati dengan SKB 2 Menteri, kemudian juga meningkatkan jumlah dosen, rumah sakit pendidikan, dan juga pembukaan prodi-prodi baru termasuk prodi FK, FKG, dan juga prodi-prodi spesialis baru. Dan ini diorganisir secara baik di 6 wilayah academic care system, di mana Unhas mengkoordinir wilayah 6, UGM wilayah 4 yang meliputi Jawa Tengah, DIY, dan juga Kalimantan. UNER mengkoordinir wilayah 5, Jawa Timur, Bali, Nusa Tenggara Barat, Nusa Tenggara Timur. UNPAD mengkoordinir wilayah 3, yaitu Jawa Barat, Sumatera bagian selatan. UI mengkoordinir wilayah 2 di DKI Jakarta, Banten, dan Papua. Kemudian USU mengkoordinir wilayah 1, di mana wilayahnya adalah di Sumatera bagian utara. Nah, masing-masing universitas ini bekerjasama dengan pemerintah, dengan universitas di wilayahnya, kemudian dengan pemerintah daerah, dan juga rumah sakit pendidikan untuk mendorong atau mendukung upaya-upaya baik itu penambahan kuota, kemudian juga peningkatan rumah sakit pendidikan dan sebagainya, serta pendayagunaannya oleh pemerintah daerah. Selain dengan kita mendukung upaya-upaya pendidikan melalui university base, kita juga menyelenggarakan pendidikan PPDS berbasis hospital base. Kenapa ini kita lakukan? Karena kita ingin mempercepat pemenuhan dokter spesialis, dan ini sudah ada dasar yang kuat di Undang-Undang Kesehatan tahun nomor 17 tahun 2023 maupun PP 28 tahun 2024, bahwa rumah sakit pendidikan merupakan salah satu penyelenggara pendidikan dokter spesialis selain yang berbasis university. Dan kita sudah menyelenggarakan di 6 RSPPU, dan ke depan kita akan menambah jumlah RSPPU sehingga ini akan sinergi dengan pendidikan berbasis universitas. Kita juga memberikan bantuan pendanaan pendidikan, baik itu untuk program pendidikan dokter spesialis maupun subspesialis, pendidikan dokter gigi spesialis, kemudian SPKKLP. Kita juga membiayai fellowship, afirmasi dokter dan dokter gigi, afirmasi tenaga kesehatan melalui Padinakes, dan tugas belajar SDM kesehatan. Jadi Bapak Ibu sekalian, peserta webinar yang saya hormati, Kementerian Kesehatan senantiasa berkomitmen untuk melaksanakan transformasi SDM kesehatan. Kemudian ada 3 masalah yang terkait dengan SDM kesehatan di Indonesia, meliputi kekurangan jumlah tidak sesuai dengan standar, kemudian distribusi yang tidak merata, juga peningkatan kualitas, mempertahankan kualitas yang belum terstruktur. Nah, upaya-upaya itu dilaksanakan dengan perencanaan yang baik. Tentu saja perencanaan nasional, kita sedang mengembangkan standar-standar untuk dasar perencanaan secara nasional yang presisi, dengan bekerjasama dengan lembaga internasional maupun universitas-universitas di Indonesia. Kemudian juga di penyediaan kita all out untuk mendukung perencanaan nasional untuk mencapai standar kebutuhan. Kemudian tentu pendayagunaannya, peningkatan mutu, pembinaan pengawasan SDM kesehatan, serta pembenahan bagaimana sistem registrasi, perizinan, pembinaan mutu dan standar yang tentu lebih tertib yang saat ini dikelola oleh Konsil Kesehatan Indonesia. Demikian yang bisa kami sampaikan. Terima kasih atas perhatiannya.
Applause to Dr. Akema. Terima kasih Bapak atas pemaparannya. Data-datanya sangat menarik Bapak Ibu. Kemudian, so we are on the last 2 speakers, so bear with us. And yes, so can we get an applause first, maybe? Yeah. We're going to invite our beloved Dr. Tan back to talk more a little about clinical ethics. And then after that, we're going to talk a lot about, the social media usage of Indonesian doctors who are now kind of trending because a lot of people are like posting in TikTok and stuff like that. What is the ethics behind social media usage, right? So yes, thank you so much for the whole day. We love the crowd here. So yes, Dr. Tan, please take it away.
Okay. Yes. Hi. Hi, everyone. Okay. So in this afternoon, we are going to just go through something that, again, something that I'm using, and I'm employing in much of the case consults, and the most important thing, when we want to get to the bottom of like resolutions, we have to actually understand the identity's perspective and what matters to our patients the most. So as medical educators and as, you know, clinicians, I think it's good to actually impart to our junior doctors and also students, you know, to not forget about this part. So the one thing that I have used, and also many of the ethicists have actually tried and employ, is trying to use the narrative approaches. Okay, so this is my, okay. Does it move? No, it doesn't move.
We can go to the next slide, Mas Iskil.
Okay, that's me. Sorry, yeah. Okay, so this is where I'm from. So I'm from a friendly coastal town called Kota Baru in the state of Kelantan. I'm not sure whether you have been there. Okay, and it has very solid Islamic influences and political hold, and also a bit of the border cultures from the Thailand side. So, and this is where I'm based now, in the capital city of Klang Valley, basically the Selangor and the Kuala Lumpur, where, you know, all the actions are. Okay, next slide. Okay, so just a little bit about myself. Okay, so kalau boleh, saya nak cuba bagi dua cerita, ya. Okay, cerita yang pertama, okay. So ini bukan gambar yang betul untuk pesakit itulah, tapi saya ambil gambar daripada surat khabar, ya. Okay, so a 52-year-old lady, Puan Halimah, is the primary parent for her 7-year-old child with both Hirschhorn syndrome. Okay, so wholly dependent, poor neurodevelopment outcome, just had a bout of seizures after a year of well period. So there was no recent problems or frequent admissions, but she used to have a total of 20 admissions, including an ICU stay before the age of 5. So I was called upon my colleague to speak to mom, who was described as being mentally challenged and not fully comprehending an advanced care plan that the team was trying to seek permission for. And this plan was mainly about intubation and also chest compression in the event of collapse. So I was hesitant, okay? And because the child was on the verge for discharge, she's well, anti-epileptic was restarted, and it seemed that she will be okay for the next few months. So when I interviewed the staff, they said that the mom is very reliable, as she will insist on admission when she feels the child is not right and her intuition is always right. And 2 other children are not attending school because they are surviving on welfare assistance, and she's the single parent at this point. Okay, next slide. So I have another story. Okay, so this is another patient. His name is LGK, and he is 65 years old, Chinese gentleman, currently under our care. That was the referral from the ENT surgeons for advanced nasopharyngeal carcinoma with cervical lymphadenopathy and pre-renal acute kidney injury secondary to poor oral intake. So his post-op day 2 open tracheostomy for impending airway obstruction. So he signed an DIL and an NAR by himself during this admission. However, today he was removing all the rice tubes, IV lines, and refused for another insertion after counseling. So he's living alone, no family members around. As the ENT surgeon said, we plan for CT scan staging and for oncology referral. However, he refused that as well. So we have referred him to surgical team for a PEG tube. And at the moment, he will benefit from medical treatments such as antibiotics, chemo, or radiotherapy. The HPE showed high-grade malignant tumor, and we have managed to persuade him to keep the tracheostomy this morning, but he's attempting to pull his urine catheter out too. So we would like to know, is the DIL NAR form that was signed by him is valid? Is there any way that we could help him out? Okay, next slide. So what we are sharing today is a general, overview about identities and perspectives and a little bit about narrative ethics. Okay, next. So this is where I came from. Okay, next. Next, identities. So again, we talk about identities, everyone's identity, me, you, the person that sits beside us, who we have dinner with, persons should be treated in ways fitting to their common humanity, dignity, and inherent rights. So one must act so that you treat humanity, whether in your own person or that of another, always as an end, never as a means, okay? So whatever it is, whatever we are doing is for the person's best interest and also what means, what is valuable for him or her. Okay, next. So the complexity of identity, who am I, is more than this. So this is a slide that usually we do in quite a bit on during our communication workshop. Okay, so we try and again to precondition everyone to think about ourselves first before we kind of connect with other people, okay, to have the conversation with other people. So it's important to actually go back to asking, who am I? So this is one piece that, ME, and again, the MBE program has actually kind of really inculcated us about looking at ourselves, as the concept of identity is a complex one shaped by individual characteristics, family dynamics, historical factors, and social and political contexts. So in the end of the day, when we say, who am I, is not much of what we answer, who am I, but the answers depends in large part of who the round around sees me, okay? So what do my parents say I am? Who do my peers say I am? What message is reflected back to me in the faces and voices of my teachers, my neighbors, my store clerks? What do I learn from the media about myself? How am I represented in the cultural images around me? Or am I missing from the picture altogether? Okay, so when you see me, I look Chinese, but I eat my hands, I eat nasi as breakfast. I don't eat noodles. I prefer nasi. Okay, so it's much of like when we look into the mirror and and also others, they are the ones that are going to fit us who the person I am. Okay, next one. So next, okay. So I think when it comes to person, then the next thing it moves to cultural, because I think the cultural definitions are also important. It has been said many times, by Hajong also and the rest that in the end of the day, we have to know that whatever we are today is in a way socially constructed, defined by our upbringing, our political influence, our social practice, nations, customs, and also professions. Okay, so I think when there is a difference between multiculturalism that demands that the states move beyond toleration, not just, cultural sensitivity or cultural tolerance, from a negative to a positive attitude, from a non-interference to active support and accommodation. Okay, so that is where you don't have a dominant crowd culture. Okay, so next. So that's the ideals. Okay, next. So in Malaysia, again, I think in a way, I think we share with Indonesia is we are multi-ethnic and multicultural. And I think it is important to know that we are pluralistic with some cultural tolerance. Again, the dominant group, our Malay counterparts defined by Islam. The Chinese Malaysians are defined by Chinese philosophy and customs and religion. Indian Malaysians are defined by both culture and religion. Indigenous people, various groups with unique customs and beliefs. And again, from here, it is also more diverse than we think just from a simple slide. Okay? Okay, so every of these cultures has further ethno-linguistic differences and also branches. Okay, next. So I think in a way in Malaysia where when ethics comes in, when it comes to ethics education and also practice, I think we try and put this slide in to talk about cultural humility. So I think in the sense that there are extensive background, psychosocial and cultural dimensions when it comes to the health, death, and living, and clinicians need to be culturally competent. I think at least to know just a bit of basics about various cultures and faith, but we have to also move beyond and think about, the knowledge gaps and biases that we will never be able to fill in. And that's why we need continuous self-reflection and try to fix power imbalances so that the humility part can come in, fill in the gaps and have more partnerships. So in a way, I think in the hospitals, in clinics, we want to inculcate the value that, we have to actually maintain that personal, respectful spaces for patients to make decisions, because at times, even when you have being in a setting where you are of the dominant culture, there is still tendency of having some pressure for the patient to actually make a personal choice. Okay, next. So in Malaysia, I think the culture also includes the medical culture. So at this point, I think similar to many maybe Asian countries as well, patients are not fully empowered to actually self-determine their care, and it is still professionally directed care. And with the notion that of our passion, of our compassion towards our patients, and the sense of duty, and also it doesn't help when on the other hand of the patients that they have this non-confrontational behaviors, or respectful way of looking at the doctors. And I think because of their gaps in literacy, and the whole thing actually fits into a vicious circle of disempowerment. But when we actually try and sit down and ask our patients, I think many of them actually would want an active decision making. Okay. So as this part of shared decision making creates confidence, self-trust, and trust to the professionals. Next. So in the end of the day, when we think about how do we merge and also bridge the gap between different cultures, medical culture, and in a multi-ethnicity and cultural society, I think one thing which is going to be the way to go about is actually to have a personalized individual approach to explore the psychosocial and cultural dimension of individual patients. So they may come, with, a certain look, a certain appearance, they may come with, a way of talking, a way of, how they express their thoughts, how they talk. And I think in the end of the day, we should not assume what they understand, that is what they believe in. And I think it's very important to actually ask, who are you? Who do you believe in? What do you value, and what matters to you? So that's why it's actually important, not only knowing the patient, but also knowing how and why those decision making through their perspectives, and at the same time, be conscious of our own cultures, biases, our own identities as well. So next. So perspectives, I think it's important to differentiate between, next slide. Perception, okay, is what you interpret understanding of a given situation, person, or object, meaning assigned to any given stimulus. So perception is when, it just directly, you feel sad, you feel happy, you feel scared, and perspective is your point of view, the lens you see the world through, and determines how one view oneself, others, and everything else around. So if you look at the photo here, the perception that gives us is going to be like, the floor is sinking and it looks dangerous to walk on. So that is a perception. The perspective is, this is likely just an illusion, right? Okay, next. So I think this one is something that we tend to use as well when we are teaching on identities and perspectives, that, between the patient and us, and with them and us, okay, it's also important to know this concept of promoting more self-awareness, also promoting something that we want to actually know better from the other end, to know that there's always this open area where it's very known to each other, and this area where it's not known to self but known to others, or also the area where it's not known to others but known to self, and also the area where it's unknown to everyone. So I think this model, even though it's being used in other settings, in settings in the corporate sectors, or in educational sectors and whatnot, but I think this is one where to actually kind of be very mindful about where we are, when we are talking to our patients, how much they know about ourselves, and I think that is important to fit each other during the communication and conversations. Next.
1 minute.
So narrative ethics, next. Okay. So narrative ethics is actually a branch of ethics. It's all about story-based ethical reflection and learning. And it flourished in the 1980s to understand illness and healthcare through the story of a patient, family, or healthcare worker. So sometimes, when we talk about ethics, it can be big principles, but sometimes it takes a bit of stories to ask the different kind of questions. And sometimes the secrets actually lie in the stories, unspoken, Okay, next. So some moral ideas and truth can only be relayed through stories. That's how we know the why and the hows, okay? And most importantly, it actually shift the attention to who we are and capturing identities and perspectives. So our ethics role is most of the time when we're in a healthcare setting, we are trying to keep an open and accessible moral reflective spaces for sound and safe process of deliberation. So narrative ethics approaches can come in during that facilitation, clinical practice, and even educational learning. Next. So this is some of the things that we have started in Malaysia. Okay. Next. Some of the stories and reading material that we have used. Next, for doctors. So from Mata Montello, basically the guru of narrative ethics, she will say, there are a few methods that we use. First, to follow the story. Second, to understand whose voice are the stories speaking from, who are the characters, what are the plot, like you're watching a movie, what are the plots, and what are the places or, spaces that we can actually come to a resolution. So importantly, she used the concept of mattering map, which I'm going to share later. And she talks quite a bit on when we listen and reading, and even though it's not spoken, we try and look for the third thing and try and interpret and relate to, what is going on at that point of time. Next. So this is a mattering map. I have to use this because I think it has been very useful. And when we think about like our own self, what matters to us the most, who matters to us the most, you can go back to Winnie the Pooh's maps and look at, where he actually put, not him actually, it's going to be people occupying a mattering map. The map is a projection of its inhabitants' perceptions. A person's location it is determined by what matters to him, matters overwhelmingly. So when you're going to draw your own map, you're going to have something like where are your family, this is your work, okay, this is where you go home every day, this is your colleagues, and one and the same person can appear differently when viewed from different positions, making sometimes communication sometimes difficult. Okay, so next. So I think when it comes to narrative ethics, these are the themes. Next, okay. So sometimes we use moral imagination, like this sajak here by Muhammad Haji Saleh that we use in classrooms to actually to read and to understand, try and put ourselves in the shoes of the author or the shoes of the characters, okay? So this is about seorang wanita usang, was waiting for her son, yeah? Okay, next. So the rules in medicine, even though we have moral principles, but narrative ethics actually lends a depth of context and expression through subconscious thoughts and hidden intention. So clinicians can make better connection, and clinicians also can find closure and meaning in the most challenging impossible situation. Next. So in the end of the day, so when I sat with Puan Halimah, remember? Okay, she was actually speaking. She was stuttering we call what in Bahasa Melayu. So she gagap. Is it gagap? Okay. So she was taking a bit of time to speak. And I think that gives a wrong impression about that she has she's mentally challenged, but she's not, she has very clear thoughts about what she wants the care to be like. And when we ask her, what do you think you want for your child? Then she said, "Buatlah yang terbaik, doc." Okay. So that was her words, buatlah yang terbaik. Okay. So we had to actually ask, buat yang terbaik, terbaik itu apa? Okay. So what she said was, kalau doc rasa kita masuk tube, dia boleh selamat, buatlah. Kalau dok rasa kalau letak tube pun tak berbaloi, tak ada guna, then tak perlulah buat. Itu semua doktor punya keputusan. Okay. So what she meant was just you do what you think is clinically the best. If you think we should tube her, then you tube. If you don't think it's meaningless to tube, then I don't think you should proceed, because I'm not the doctor. Okay, you are the doctor. So I think that's where, when we sit down, it was not so tough. She actually understood everything, but of course she said, we don't want a chest compression. I've had a nightmare looking how it was done before, So I think by sitting down, her perspectives actually was a bit clearer to the team. And I think that's how it helps the team to actually understand that she was actually aligned with what they were planning for the child. Okay, next. So what about Uncle LGK? That is him sitting there. The one thing about him is it was actually hard for him to communicate because he was deaf and he was mute because he was having this airway mask, a big mask there. So he the way that we had to actually listen to him was actually to sit down and ask him to write on a piece of paper, and he had to gesture, he had to signal. And at that point, when he was pulling all his tubes out, right? So we were thinking, is he seeking death? Is he trying to commit suicide? And but what he wanted was actually to go back home. Okay. So when we further asked him, why are you pulling all the tubes out? And apparently he just wanted to go to the bathroom. Okay, so he just wanted to go bathroom, and what he wanted to do was actually just to take a bath. Okay, so when we've managed to actually find out that that was what he wanted at the point of time, that he was in such a high stress level because he was feeling very dirty, or you know what, and once he went over, you know, he get the water splashing on himself, and he was so happy. He was following all the orders after that. So I think in that way, that was the plot. Okay. Of course, it's just an acute issue. Like it was not a big, like, kind of critical decision or what. But I think what matters to a person the most, even though it is just one wish, I think it's important to actually try and listen and you know, and really spend time. Next. So I think these two cases illustrate that spending more time, you know, and not assuming, you know, I think, you know, we can actually understand our patients a bit better, and, you know, provide better value and quality of care to our patients. Okay. So I think today is just an introduction. It's a very specific field of narrative ethics. It's very, very new as well in Malaysia. But I think it is, from my point of view, you know, the experience that we have had for the past few years, it definitely helps quite a bit when we have a difficult case, or when it helps in educational, you know, reflection, you know, ethical reflection and learning. Thank you. Sorry.
Thank you, HS, for your wonderful intro on narrative ethics. So we're going to move on to the last speaker. We're going to call UNDIP's own Dr. Edward. He's going to touch on about the use of social media in Indonesian context. Dr. Edward, floor is yours.
Okay, thank you very much. Good morning or good evening right now. Hopefully we are still in morning, because maybe we are all tired today. Okay, thank you very much. And I'm happy to, because I'm the last person here to deliver my slides here, that before Hajung Lee, Prof. Chung have delivered the same slides with me. So I just make some conclusion, or make some see the reality for the social media, I guess. And my moderators say, Dr. Edward, don't talk too much. Please short and fastly. So, okay, I say, okay. So now I will deliver my slides with the title of Bioethics in Practice, Doctor Influencers, Patient Consent, and the Ethical Gaps in Indonesia Social Media Era. Okay, we see that the Indonesian is very complicated and it's very wide, and with lots of population on 2025 is estimated is nearly 300 million people, and there are 6 religions here, and there's lots of tribes and also the race here. So what it makes the Indonesian is very diverse. It makes us too why we have a different thinking of one perspective or perception, because we have another maybe background and culture also, and also the religions. Ethics or bioethics will talk about lots of fields here. Maybe it's about law, medical, environment, daily life, politics, education, economics. So the ethics and bioethics is very needed in all fields. If there's no ethics and bioethics, I guess we are not a very good person to do what we have to do in the activity of daily. In the medical field, we have a very lot of field too. So we don't want to make a discussion all of the field of the medical field. We have healthcare education, healthcare services, patient safety, patient privacy, medical research, and etc. So we have learned, Prof. Chung said, and another speaker said that this is the 4 basic principles as the common morality. We have known this is an applied bioethics, and all the clinicians applied this principle to analyze maybe an emergency condition. But we have to remember, if we want to talk about the ethics and bioethics, you have to read more about the theory and also about the value of the ethics and bioethics. If not, you cannot analyze all the condition with these 4 basic principles. Okay, but mostly on the cases of the emergency condition, yes, for the patient, we have to see this theory. And how healthcare providers should act. We have to remember what is the relationship between doctor and patient. It has a very special relationship with both of them. And you see this sign in the hospital, right? No smoking, no littering, no photograph, etc. No teeth, no ties, no teeth, no photo or video allowed. Remember this, okay, yeah? And we have known all the hospital in Indonesia see this sign. And what's happened? And what's the reality inside the hospital? Let's we see. And because of the social media today is improving and very lots of social media. And is there anyone do not use social media here? I guess all of us use the social media. Yes, there's lots of here. Relationship between doctor and patient, we have to remember it again. I just want to remind all of us this is a very applied bioethics, okay? And spanning verbidness, so it means that the doctor will serve the patient not with the promise of the result. We have to make the best for our result, our effort to the patient. Respect to autonomy, privacy, and confidentiality, beneficent, do not harm, justice and virtue, and lots of theory. We have some Indonesian doctor competency standard. Okay, when we do the bioethics and ethics in the education, we have a standard for the competency of Indonesian doctor, and 1 till 7 there's the item for this is an effective communication, and 1 is a high professionalism. So we see that the ethics and bioethics has been implemented in education for the medical doctor. And this is for the noble professionalism that's a detailed title for the noble professionalism that you can see here. That we as the lecturer especially in UNDIP, and I'm sure and in another institution for education must be implement this standard for professionalism for our students. And we see that the Hippocratic Oath too, that the ethic and bioethics is implemented too, that mostly in Indonesia after we graduate for the doctor have oath of the Hippocratic, and we have to remember about that. Okay, this Hippocratic Oath ceremonial in UNDIP. And okay, this is the philosophy of Pancasila again that has been delivered by Hajun Lee, that Pancasila have 5 principles that makes this country's philosophy of law, philosophy of ethics, and how to live. We Indonesian have to remember all the item 1 till 5 is the best when we live in this country. And how about the law and rules? Yes, it's law and rules. And this is talking about the law of health. Okay, law number 7 year 2023. And also the government rules, and it is talking about the medical and health professional, and also the Minister of Health Regulation, and it is talk about the medical confidentiality. And how about the Indonesian Medical Code of Ethics? Yes, there is an Article 10 and Article 16 that stated that it is a respect for the rights of patient and colleague. And also it is about the office confidentiality, that the confidentiality is very important in the Indonesian Medical Code of Ethics. So I guess you have a wrong my presentation. Please send me the slides, not in the PDF. Okay, I will show the reality in the hospital before I send my conclusion, okay? Okay, this is a case of the social media. I have closed the eyes of the doctor, okay, and the patient. What do you think about this thing? It is a video. And if you have a TikTok, you can open it. Wow, yes, that's your comment. And I'm wow too. And after I have, after I have investigation, not only in Indonesia happen, but also in abroad, in Malaysia, in China, in Iraq, also in another country. It has happened. Why the doctor do this and why the professional health care do this? We have to remember our confidentiality theory, privacy also. Who do you want to be the patient like that? No one, I guess. Why becoming like this? Because maybe they want to be famous. The TikTok social media is becoming a tool to marketing idea. So be careful to use your social media. You can see also, although the patient, maybe this is a woman, we can see the face, but the back till the buttock, we can see the buttock. Is it a confidential or a privacy? I guess not. So we have to remember, okay? Next slide for the real life. Yes, this one too. Okay, look at that buttock and the back. Yes, this is happening here. Yes, in Java, and I'm really sad to see here. And this another of doctor activities in TikTok. There is an obstetrician and gynecology, and also the cardiologist. They have a consultation online. Is it consultation online is same with a social engagement for the education of the society? I guess not. If you want to make a social engagement, just give a brief presentation of something diseases, right? And there's no consultation about the diseases, about the therapy, how to make a follow-up. Yes, they do that. Okay, I have to stop here. So my conclusion, I go to my conclusion. I just remind, and we have to remember to, of course, the outset. Medical especially said it when we graduate, and maybe with another ethic code of ethic in a health professional, others, and the Indonesian law and rules, and also the grundnorm and the philosophy of our life in this country is Pancasila. With this, the reality in hospital will not happen like that. And hopefully that we are here. If we see here in your area, please cooperate with the maybe medical organization or the healthcare professional organization and give them the therapy, psychology therapy or the ethics therapy together. I guess that's real. I'm sorry if I'm very late. Thank you very much.
Thank you, Dr. Edwards. So we're going to have a 10-minute discussion panel, Q&A. If I can invite back the speakers, Professor Roger Chung, Dr. H.S. Tan, and Dr. Hajing Lee. Please take a seat in the hot seat for the last time. So we're opening up for the folks here in person. Yes, I got one.
Yeah.
Yes, please, Dr. TV.
Okay. Thank you. I'm Agnes Tiwi from Center for Bioethics and Medical Humanities from Jogja. Thank you for the insightful presentation, for all the speakers. It's really gives a fresh perspective to me how we think about the patients. So I really like the how Dr. Roger say that to make a most considered judgment, it is in a particular scenario, so that it is the patient that matters. And so as a teacher, because I'm teaching bioethics also, we face this dilemma that the students, they ask us about the right questions, the right answer. What should we do? We discuss long stories, and at the end of the discussion, they still ask us, what should I do? And we don't have the time to do some lectures or something like that. But how can we, like in 1 or 2 minutes, address this when we encounter this question? Okay, thank you so much.
Well, that's $1 million question, isn't it? Because in Hong Kong, we still face the same problem. I think it has to do with how they were trained when they were younger too, right? So, you know, it is so ingrained in our culture that we need to get the right answer so that we can get, you know, a good GPA to go to medical school, right? So I think it is something that is not only happening, that is not only unique in Indonesia, I believe, right? So we still face the same problem in Hong Kong, but I don't know how much time you have for your bioethics curriculum. Can you tell me a little bit?
So in the, it is a longitudinal one in the bachelor for medical students.
Right. So like, how many hours per year would you say can be dedicated to bioethics?
Per year. Not sure. I think one block that incorporates it, and then several discussion session.
Right. Okay. One block meaning like 3 hours block, or what do you mean by that?
No, like several weeks.
Module. Yeah, module. So I don't know.
One module.
7 weeks.
A 7 weeks module?
Weeks. Yeah. Probably like 3 hours per 7 weeks.
3 hours per 7. Oh, okay. So per year though, I mean, you know, does it run every year?
Yes. So maybe it's like some medical institutions, Roger. So the bioethics, it depends on the university, right? But maybe like if I can say from UNDIP, right, Pa Edward, it's pretty minimum. So it trumps a lot with the clinical parts. So bioethics is really like basic and only the start. So maybe per year, I can confidently say maybe like, I don't know, 20 hours.
For 4 weeks.
4 weeks.
Okay.
I'm not sure about the time, but 4 weeks is effectively in a professionalism.
Yeah. Sure. Okay. So I think we need to really think about it, you know, from a more policymaking perspective. Like, you know, do we need to revamp, you know, our curriculum so that bioethics can be taught in a way that will, you know, can be taught in a way that the students won't get the idea that there is always the perfect answer to everything. I think that has to be built in to the curriculum, and make sure that all the trainers and the lecturers, the speakers that we invited also understand this, right? So I think that's important. So I can only speak from my own experience. So in Hong Kong, we do have to train our teaching assistants and the tutors who are actually leading these tutorials, when we're doing case studies. You know, I'm also involved, but then there are other people who are also involved, and we make sure that we are not trying to teach them to think that way. Yes, it may be something new to them, but I think that is much more realistic than telling them that there's one right answer to every single scenario that you have, because in reality, that's not happening, right? In reality, it is complicated. There are a lot of more distress, a lot of more dilemma. Even if you make the decision B, you know, whatever it means, doesn't mean that decision A is completely wrong, or you know, it has to be sidelined or silenced, right? There's still something there in decision A that is important, and we call them more residues that we have to deal with, even if we make decision B. I think that should be a message that as bioethicists or people who are teaching bioethics should try to convey to our students. And, you know, you can go back and look at your curriculum and see, you know, when can that be conveyed. You know, I'm sure during your, is it 5 years, 6 years over here? 6 years curriculum, there's gotta be, you know, an opportunity to convey that kind of ideas. So I'm trying to be very encouraging, because I truly believe that if there are people who understand this and really want our students to learn, we can work our way to, you know, so that they can learn. Yeah. Hajung, you want to say something? Oh yeah.
So students always want to know the correct answer, the right answer, and then they also wants to know what instructor, oh, I know, what instructors are thinking of, right? Because they assume that whatever their teachers, their professors are saying is a correct answer, because they are so used to like taking chemistry exam, like bio exam, like those have like the answers, right? But in bioethics, many cases, like we don't have the answer, but we can find a few reasonable answers. So at the very beginning, like in the beginning of the class, I tell them that like learning ethics is being more comfortable or being familiar with the gray area. So there's no like black and white. I mean, that's the lesson that I've learned from my Harvard bioethics training as well. So like, let's feel more comfortable with the gray area. I mean, I myself like study engineering and I love answer as well, and I don't feel very comfortable when we are like in between, and it can be, that can be like, it's a mess, right? But that's the way that we learn. And I tell them that we're not like seeking a correct answer or the correct answer, but we are trying to learn how to think together and how we can find some reasonable like options, like, and so they ask me, so, oh, what is your answer? What do you think? I don't give it to them because that sway their opinions. And, you know, if I say A, then some people who think of B is more a preferable option, they're going to be quiet. So I don't say anything about like my position, like more neutrality. And then I tell them at the end of the semester or at the end of the sessions, let's have a Q&A session if you're super curious right before we release your grade and, you know, we're done with the curriculum. So ask me, I'll give you an answer. So we have kind of a Q&A time so they can kind of see, you know, what my opinions are. But I mean, I myself now, I don't have one answer either. Like I'm a little bit more and more familiar with a few options, and it totally depends on the context, and it totally depends on, you know, what kind of, you know, preferences that the families and family members do have, and there are medical conditions, and there are millions of like different, you know, facts that affects. So let's try to learn how to think through and try to find a way that we can find reasonable options or that we can recommend.
Thank you, Hajang. I agree with you, but there's another thing that I would like to say is that I think there are questions. I understand that a lot of times we have to distinguish students, right, according to their grades. We need to do that as an educator. So I think there are questions that you can ask. For example, like, if you apply principalism in the situation, okay, and then you can be specific about it. What would that mean? Or, what would non-maleficence mean in this situation? I think there can be closer to a right answer if you do it that way, right? What would virtual ethics actually give you? What are the limitations and strengths of virtual ethics in this situation, right? I think that would give you some kind of a right answer, but then they are also learning. But then, yes, I agree that there are situations, other, cases that we may not really have a perfect answer. And it depends on which type of perspectives you're taking. So remember, when I was talking about, these theories, these different moral accounts, using them as lenses and perspectives, I think that is what we're trying to train them to do, right? So yes, they need to understand, what would a utilitarian ethics look like in the situation. So we can test them on that, and there will be some right answers, right? So, if they're saying that, oh, utilitarianism is about categorical imperative, then that's wrong. That's right? I think that could be built into when you're trying, into the assessment methods, but it doesn't have, and it shouldn't be the only assessment methods in bioethics education. Yeah, that's my take on this. Yeah, thank you.
Hi, Jung. So with the interest of time, we are going to close the Q&A. But again, the speakers kindly shared their social media for good purpose. So if you want to contact all of these speakers, they're willing to, answer your questions. Yes. So thank you so much for being such a good crowd. Let's give it up for all the speakers today.
Can I say one more thing?
Yeah, sure.
And very quick. End of October in Hong Kong, we're actually organizing the Asia Pacific Bioethics Education Network. So you can look at it. If you're interested, you can come. And this is a platform for Asian Pacific universities and institutions to really share their learning experience and how do we do our bioethics education in our own respective regions. So if you're interested, please submit abstract too. We're still accepting abstract till mid-July. So this is the Asia Pacific Bioethics Education Network. So thank you very much.
We will share the flyer through the WhatsApp group, and also Malaysia, we're going to have a pediatric ethics conference in October, right? No, it's okay. I'll share. Yeah. So yes, thank you again. We are now, so speakers, maybe you can take another seat. So we are moving on. Oh, stay here. Okay, Pak Nur say we have to stay here then. Okay. MC, take it away.
Yes, thank you, Mrs. Moderator. Ladies and gentlemen, in appreciation to the speakers, the organizing committee would like to present a certificate and would like to invite the representative from the Unit of Bioethics, Humanities and Professionalism at the Faculty of Medicine, Universitas Diponegoro, Dr. Sigit Kirana Lintang Bima, Specialist Forensics Medical Legal Consultant, for giving certificate to the speakers. So first will be provided to Dr. Hajung Lee, and then Dr. Tan, Professor Roger, and then Professor Rebecca, and also Dr. Edward. We'd like to invite Professor Rebecca to join us on the stage. Yes, Bu Astika. Okay. Is Pak Ciki, is Dr. Sigit, please join the speakers and for the facilitation. Thank you very much. So, ladies and gentlemen, we have now reached the conclusions of day one of the International Bioethics Symposium and Workshop. On behalf of the organizing committee, we extend our sincere appreciations to all speakers, moderators, participants, and partners who made today's event a success. We hope the sessions have enriched your perspective and inspire continued collaborations in advancing bioethics. See you tomorrow at the workshop, and thank you. Goodbye.